Yes, I can hear you.
Okay, good morning, Nakamura-san.
Hi, good morning.
Okay, wait a moment.
Good morning. Good morning.
Hi, Dr. Nakamura.
Hi,
I'm Dr. Chang. Thank you so much for your support. So we are going to start our program, but first, and we invited you to perform an opening. And the first one would be Professor Wei, and then you, and then
me.
Chang. Yeah, please.
Okay.
Yeah. So after Professor Wei, we will invite you to do the opening remarks.
Okay.
So the program will start a few minutes later, 8 a.m.
morning. I'm so happy to announce that this is our second day of Changing Life 2020. Today's highlight is the complex and high-risk indicated patient. We have 11 cases to be performed today, and well, I'd like to say that yesterday we just finished our HCM program. That's hypertrophic cardiomyopathy. We had a collaboration with the Mayo Clinic, and they have several good lecturers to present their lectures yesterday, and I think a lot of audience can benefit from HCM treatment yesterday. And today the highlight is in CHIP. So as I know, many centers are doing more and more interventions on the patient with complex and high-risk patients. So it's our mission to save these kind of patients who are not suitable for open heart surgery or for conventional intervention, coronary interventions. So today we ask many experts, very skillful interventionists to come to our meeting to share their experiences. So I'm deeply thank their efforts and their support for this meeting. And this meeting is sponsored by Cheng-Cheng General Hospital, and it's also collaborated by the Taiwan Society of Thoracic Cardiovascular Surgery and Taiwan Society of Cardiac Intervention Society. So let me welcome our Dr. Nakamura from Japan, and I'd like you to say some words to our audience. Thank you.
Okay, thank you very much. Thank you very much. Always, you kindly invite me as one of the members of this very nice the meeting. Because of the COVID-19 pandemic, this time cannot join you directly, but I very allow me to join the internet system. So actually today's topic, chip, is very important because of the currently we are handling more and more complex region or the PCI, of course maybe the cardiac for the cardiac surgeon. So keeping a safety of the patient, we need a technique and the knowledge. Maybe it's in all of the members and also the maybe many of the Taiwan doctors join this meeting, so can learn about the technique and the knowledge. So maybe this will be a very nice meeting. So let's have a very special time. Thank you very much.
Thank you so much. So now we are going to move to our first session. So please, our moderators will be Huang, Liu Shih-Chi, Fang-Yu, Zheng, and Huang Wen-Pin. Well, I think all these moderators and commentators to come to our hospital for sharing their experts with us. So we'll shift to the first session. Thank you.
还是过不去。那我们只好就是。
Hi, good morning, everybody, and good morning, Dr. Nakamura. And this is our we have our moderator, Dr. Huang Wen-Pin, and Dr. Cheng-Cheng, and another moderator, Dr. Fang-Yu, is online. He's from Kaohsiung, so it's quite far away from us. So he will be online to join this section. So can we go to the room 2, Dr. In? Dr. In, are
Yes.
you ready? Okay. Dr. In,
Yes.
Dr. Nakamura is online.
Hi, my old friend.
Oh,
How have
great
you
friend.
been? Yeah, how have you been?
Long time no see. I miss you.
Long time no see.
I miss
Yeah,
you.
I miss you very, very much. I hope we can see each other face to face in near future. Yeah.
Yeah, very much.
Yeah.
So, Dr. In, can you present your case?
Please, Dr. Jin.
PowerPoint.
Please show the PowerPoint.
Oh, it's a 72 years old female, and she has underlying history of hypertension, type 2 DM with diabetic nephropathy, and her creatinine is pretty high. Creatinine is for 2.4, 2.41, and the GFR estimate GFR is 21, so it's around CKD stage 4, and hyperlipidemia. And her chief complaint this time is chest tightness for 1 month. And her ECG shows sinus rhythm. And her stress test showed thallium scan positive. And transthoracic echography showed preserved LV systolic function, dilated left atrium, and concentric left ventricular hypertrophy. So she had diagnostic coronary arteriography last time, and which showed left main ostium 30% stenosis, distal left main 50% stenosis with moderate calcification, and proximal to middle LAD 80% tendon stenosis with moderate calcification. And what about the circumflex? The distal circumflex is 50% stenosis, and OM branch 50% stenosis, and proximal to middle RCA showed long diffuse 60% stenosis, with PDA branch 50% stenosis and PL branch 80% stenosis. And let's see her angiography. Next one.
Well, as you can see in the angiogram, there is an osteo. Actually, there's some lemon disease, but which is not the target of today's PCI. But we want to treat the proximal, the very proximal LAD.
Next one. We can show the cranial angle.
As you can see, the patient had diffuse calcification from ostium to the very proximal and then proximal LAD, a long segment, about 3 to 4 centimeters in length. And the problem is that the patient has a poor renal function. So Dr. Cao ordered me that I cannot use any contrast today. So I have to do all the things by IVUS guidance. The main concern of this patient would be two. The first is, will we need to use rotablation in such a CKD patient with heavy calcification? And for this, we decide to use IVUS first, then to determine whether there is any circular or ring calcification. If not, we will just do cutting balloon angioplasty and then stenting. The second is that where will be the proximal landing zone? There is still some disease at the ostium. So should we cover the ostium? This will be guided by IVUS 2. So I'll show you what we have done. Any comment from the panelists before we proceed to show our initial result?
Professor In.
Yes.
Anyway, this is not speaking. So actually, I completely agree with you. Actually, this is looks not so difficult, but actually difficult because size different left main and LED.
Yes.
So we should implant a stent or the LED proximal very precisely.
Yes.
So it's very difficult to implant. Actually, maybe if we have a calcification, superficial calcification or thick calcification, maybe we need to change the strategy.
Yes.
So
yes.
maybe I think should IVUS use very indispensable.
Yes.
And it's actually this is not easy. Good case for first, number one.
Oh well. Any other comments?
Dr. Fang-Yu, do you have any comment?
Yeah. Actually, if the renal function is fine, I think maybe OCT is the better choice because it can estimate the calcium signals, long and detailed length of calcification and the arc. But because of the poor renal function, so I think we still use IVUS is recommended. Yeah. So if we can do OCT in such case, it's fine, pretty well. And under OCT guidance, we can finish the case. But because of the renal function is not so good, so we can only use IVUS. This is my recommendation.
Fang-Yu, have you been using dextrose for OCT to replace contrast median?
Yes, I also do. It's not so clear, but some not well situation was told by other doctors. Dextrose is also fine, but maybe not so good to myocardium, according to some report. Yeah, but I think maybe it's fine.
Yeah, how about the use of zero contrast PCI in your center?
Zero contrast in my center?
Yeah.
Actually, in poor renal function, yeah, we also do IVUS guidance, but not so much. Not so many doctors do in this way. We often send patients to dialysis after PCI, but zero contrast is some doctors will do, but not so many.
Mm-hmm. Yeah, we are trying to do that today.
Yes.
And then I can show you the initial result.
Dr. In, what is your guiding caster and the guide wire?
Yeah, we use just conventional JL 3.5 as we used in the diagnostic angel. Can we show the diagnostic angel from LAO view? As you can see, it just barely touched the ostium of the element. So we keep our guiding in the same position. Show today's angel, the first angel. We didn't use any contrast today. So, 放今天的啊，不是啦，对，我们Y第一条 Y， 第一条 Y， 那你就让它跑啊。
これ誰も入ってないよね。3箇所。
As you can see, the engagement of the guiding to the coronary ostium is not that easy. Because it's superior takeoff. So we make some attempt to do that. Okay, we successfully get into the left circumflex. Then we keep the wire there as a reference because we need to do posterior LAD stenting. So we use another wire, which is intermediate run through because it's stiffer. Stiffer can make sure that the IVUS and the devices to go downward easily. Then we wire the LAD to the distal, and then we did the first IVUS. Chia-Pin, could you show the first round of IVUS?
Okay. Good morning, everyone. I'm Chia-Pin from Changcheng Memorial Hospital. So here is the IVUS run, and it's started from the middle segment beyond small septal branch. So here is the healthy segment of the middle LAD. You can appreciate that the diameter is around 3.0, and the plaque is only minimal. It looks quite healthy here. And now we can have a small septal branch from 4 o'clock right here. After this diagonal branch, you can see we start with the disease segment here. And the calcification is superficial, but it's not napkin ring. So I think maybe rotablation is not necessary for this case. And here is still some calcified, but the length is not so long. We still have some calcified on your left-hand side. Here's, I think it should be the minimal lumen right here. And it's long and diffused. Now the vessel lumen is quite enlarged at this part, but still we have the plaque at 5 to 9 o'clock. Here is the relative normal segment, but you can appreciate some plaque at your right-hand side close to the ostium. Here is the circumflex wire from 9 o'clock. Here is the lamen right here. And the lamen is quite large. Even we have some plaque at your right-hand side from 12 to 6 o'clock. So I think by this IVUS evaluation, I think we don't need to touch the lamen. So in summary, I can give you the measurement here, and I would measure that the distal reference is right here, and it's about 3.0. The lumen is 2.88 by 3.11, and the EM is 3.6 by 3.2. So I think the 3.0 stand should be accommodated for this part. And here is the minimal lumen area. Here is the area is only 2.7 millimeters square. And here is the I think it's the proximal reference. It's also about 3.0. Even we still have some plaque here. And here is the almost ostial of the LAD. The lumen is not so well. Maybe I think the lumen is only 2.75, and actually the EM should be around 4. And here is the middle lamen trunk. I think the area is quite large. It's over 15 millimeters square. And here is the proximal lamen is almost 4.5 millimeter. And I measure the length from the distal reference to the proximal reference. So the length is about 22.6. So by IVUS, I will recommend to put a 3.0 by 23 or 24 stand and very close to the LAD ostium if we are going to spare the ostium. That's the IVUS findings.
Okay, as Dr. Lin said, the strategy will be cutting balloon angioplasty first, then we will stand the LAD.
We have,
yeah.
Oh, sorry.
Please.
Yeah, the IVUS image clearly show the calcification is not so severe.
Not so heavy.
Yeah, and the ostium of the LAD is not very diseased. So just like Dr. Nakamura said, you can do the precise positioning of the stent from the LAD ostium and down to the LAD. I think so. Because the next room is ready, can you just tell us what's your strategy for this case, and then we will move to the next room.
Okay, I briefly show what we have done. Yeah, we first did a cutting balloon angioplasty. Please show the cutting balloon angioplasty.
You use
okay. This is 30 cutting balloon. Next.
Caster, right? Guy extending caster. You use it?
I use it. Now at this stage, because the stent, there is an acute angle. There is an acute angle, and the disease maybe a small calcium at the ostium of LAD. So it's not that easy to cross the stent initially. So I use extension caster. Then as you can see,
Gazira or Canada?
Gazira 7 French. Then you can see the stent can be easily pushed downward. And then we localize. We want to cover all the osteal disease. So we use circumflex wire as a reference, and then stent. And then we post-dye, and then we did IVUS again. Please show the last IVUS.
Last IVUS?
Yes.
Okay. So here's the IVUS run after standing, and also the post-dilatation. And here is the I can for the time limit. So I'll show you by manual. And here is the stent distal landing zone, and you can appreciate that unfortunately our stent H was landed at a plaque right here, and here is the distal reference. So by the all the way pull back, I think the stent expansion is a little bit under expansion. Maybe we need further post dilatation. And here comes the proximal end of the stent. And the stent was very close to the LAD ostium. And you can appreciate that circumflex comes from 6 o'clock. Here is the circumflex wire. If I go distally a little bit, you can appreciate the strut at the 12 o'clock. So I think for this IVUS image, we still need further post-dilatation to expand the stent more. But just be careful for the distal H, because our distal H was landed on the plaque right here.
So, Dr. Cao, we are going to do post-dilatation, so you can go to room 2. Room 5.
Okay, thank you.
Okay, thank you very much.
Thank you.
Thank you
We
for
can
your
move to
suggestion.
room 5. Can you move room 5? Dr.张其任is ready.
Good morning, Dr. Zhang. I'm Dr. Huang from Jianxin Hospital.
Hi, Dr. Huang.
Yeah, hi, good morning. Yeah, and here's the panelists, Dr. jiann-John and Dr. Cao, and Dr. Nakamura and Dr. Guo is also online. So can you introduce your case first?
Okay, good morning, Dr. Huang, Dr. Cao, Dr. Nakamura.
Hi, good morning, good morning.
Yeah, good morning. Hello. I miss you very much.
Yeah, very miss you very much also.
Hope to see you soon.
Yeah, soon.
Okay. Today, the case that I'm assigned to perform is a circumflex CTO. Very interestingly, it's a triple vessel disease. He received a cabbage 3 years ago. Unfortunately, the all graft failure within the past two years, and maybe some guy is going to show the clinical background for this patient.
Please show slide. Well, good morning, dear chief and panelists, ladies and gentlemen. I'm Wei-Hsian from Jianxin Hospital. This case is 60 7-year-old male presented with 2 complaints of intermittent chest tightness for 1 month with underlying disease, including coronary artery disease, left main with reversal, post KBG 2 years ago with 5 anastomosis site and graft failure, and moderate heart disease, moderate AR, post AVR, hypertension, and echo showed preserved LV systolic function. Salient scan showed anterolateral myocardial ischemia. Next one. And next one. And the angiography, we can see.
Okay, maybe as you seen from the slide, the patient received the cabbage and aortic valve replacement 2 years ago. But as I remember, just 1 year after the procedure, the patient has severe stenosis at the lima, right at the distal anastomosis, and there's a very critical stenosis at the graft to RCA at that time. So he received the PCI to treat the graft at that time. And at that time, we also found that the native vessel, the LAD, initially there's a very tight stenosis, as you've seen from the screen, maybe a AP caudal view, there's a very tight stenosis at the osseo LAD. And initially there's some disease at mid-distal segment, but 1 year after cabbage, the LAD was occluded at mid-segment. And also RC, okay.
Next one.
Can we go back? Sorry, go back to previous slide.
Can you help me play the right?
Play this one. Okay. So at that time, the circumflex was patent. There's a venous graft with a wide grafted to both OM branch at that time. But RCA was also occluded 1 year after cabbage, but they treat the graft successfully, and the patient doing well for 1 year. But recently he has angina on effort again, and this time, as you've seen from the Salim scan report, there's a quite large territory ischemia at the anterior and lateral wall. I think the ischemic over anterior wall came from resulting from the ischemic the stenosis at LAD. There's tight stenosis at osseo LAD and occlusion at maybe mid LAD. So for LAD, only distal part, the apical part, is well perfused by the patent lima graft. But circumflex has gone, it's totally gone. The circumflex is a quite big one. If we can review the angiogram before the cabbage, it is a quite big circumflex. And as you've seen from the AP caudal view, there's a dimple. Maybe you cannot see it very clearly, but because I have chance to review the angiogram before cabbage, so I can see a dimple right at the small side branch, right at the right distal to the takeoff of the small side branch. And after that, there's a very acute bending. It's about 180-degree bending. So can we see RCA?
Next one.
This is the RCA. RCA is occluded at mid portion, but vein graft to our distal RCA is patent. And on the left, right-hand side, you can see the angiogram of lima to LAD, distal LAD. And it seems that there's some collateral from distal LAD to distal circumflex. So, but they're moving the table, so you cannot see the collateral very clearly. Okay, next. I'm sorry, it's a quite complex anatomy. I need some time to explain it. I even took 1 or 2 hours to analyze the image. Here's the grafted to RCA. The graft is patent. This angiogram was taken in this August, right? Yeah, it's about 4 months ago. But it seems patent, but because it is very difficult to engage the venous graft selectively. So we cannot see whether there's any collateral to circumflex from distal RCA. So this is the angiogram for this patient. It's quite complex. Maybe I can show you the angiogram we took this morning. Okay, can you show the first one? Native vessel. Okay, this morning I tried to took angiogram to try to have a clear picture for vein graft to RCA to check whether we have a collateral from RCA to circumflex. But again, I failed to selectively engage it. Even I tried to wiring, I still fail. I give up. I don't want to spend too much time to engage it. So I think graft is patent, but we cannot see whether there's collateral to circumflex or not. Okay, next. Okay, next. Okay, here's the angiogram for left coronary artery. There's quite significant disease at distal left main with some calcification. And from the spider view, just as I mentioned, after the takeoff, we see a small OM branch and right distal to the takeoff of this OM branch. That's the site of occlusion. And there's a very acute bending if you have the chance to review the angiogram before CABG. Okay, next. Of course, LAD is occluded. And from this, from the RAO view, we cannot see very clearly where's the entry, but we took the AP caudal view. Next. I hope you can see it, but I'm not sure. Right at the distal left main, we see a very small branch which goes downward. And after that, we can see a dimple. That's I think that's the entry. And next. Okay, so we try to find some collateral from Lima to circumflex. And I can see some collateral, but the course is very unclear from the LAO cranial view. I hope you can see there's some collateral to very distal OM. No, play it. And okay, next. I try some angle, try to find the route to the distal circumflex, but it's hard. I think if I try to find the course, I need selective tip injection. So that's the anatomy of this patient. I'm sorry if I took some time to explain that, but because I think it's quite complex. Any comments, any suggestion for me?
Okay, Dr. Zhang, this is a very difficult case, and the patient received bypass surgery at other hospital, and the hospital, the graft failure was noted, so he was transferred to our hospital. And after we discussed, I discussed the case with the cardiac surgeon, and found maybe circumflex can be done percutaneously. So this is quite a tough case. But because Dr. Wen-Lieng has something to tell us, can we, can we move there first?
Yeah, of course.
Okay, thank you. Can you move to room 3? Professor Lee, can you hear?
Hello.
Thank you. Please, I'm new. Please introduce your case. Thank you.
Okay. Here's our crew. This is to my right-hand side is Dr. Chen. He's a chief resident. And further right is Dr. Lin. He is a fellow of Cheng-Cheng Hospital. I'm asking Dr. Lin to present the case.
Okay. Can you show the PowerPoint for me? Okay, this is a case. We will present you a lemon bifurcation, distal lemon intervention, and show me the patient's profile. Okay, the previous one. The patient's profile. He is an 85-year-old man and has a past medical history of hypertension, hyperlipidemia, and complete block post the pacemaker implantation. He had the effort-related chest tightness for 6 months, and the ECG initially showed the pacemaker region, and the stress test was revealed by the saline scan and the abnormal finding. The echocardiography found the preserved ejection fraction of the LV and RV function. And the CAG was done, which showed the distal lemon 80% stenosis and with calcification.
Okay, let's transfer the camera to the screen. Director, please shift the screen to the image that we taken this morning. Now put the images on the center of the screen. Okay, so this is the angel that we have just done earlier. I'm sorry, my throat is a little bit dry. Because you can see this is a typical true bifurcation lesion left man. You can see there were also circular calcification at the right distal of left man. And the calcification actually extends to the proximal circumflex. This is the angel that was taken to the from the caudal view. You can see on the upper wall of the distal lemon, you can see there was a calcium nodule there. And also on the low half, and also extending to the ostium of circumflex, you can see there was a layer of the calcification at the inner curvature of the lemon circumflex curve. Okay, I'm going to show you another view. This is a cranial view. You can see also the LED is heavily calcified, but it is eccentric, not concentric. The normal appearance of LED was located at just proximal to the diagonal branch. Okay, so this is the angel that we have done. So I would like to poll your opinion on how to treat the patient.
Your opinion for this case, true bifurcation. This
is there any suggestion from the panelists?
Okay, this is Sunao speaking. Sunao Nakamura speaking.
Okay. Morning.
Good morning and long time no see.
Yeah. Sure.
I miss you very much.
Thank you.
Okay. First of all, this is a very great case. So actually, looks not difficult, but actually this is very difficult because anyway, this kind of case, of course, calcified and true bifurcation lesion, not so severe stenosis looks like. But actually, maybe I think the point is the thickness of the calcification is very point. So if you can use the OCT, maybe I think this is helpful. Or beforehand, if you check the coronary CT, maybe also you can understand the thickness of calcification. if you have a not so thickness of the calcification, you can use the rotor. But if you have a very thick calcification, maybe you need to use another strategy.
Yeah, but a great opinion.
Imaging devices are very important.
Great. I share the same opinion of yours. Because when we are doing the alignment bifurcation lesion for a long time and done a lot of cases, I think all the operators will have the same feeling that heavily calcified distal alignment lesion is very difficult to treat and to obtain an optimal result. That's the most difficult one. So as you pointed out, that if the thickness of the calcium is really big, then there's no way to treat it with the rotor ablation. However, in Taiwan, we now, at this moment, we only have the rotor ablation. So this is what I'm thinking about.
Don't you have a Diamondback?
No, not yet.
Oh, okay.
Not yet. But anyway, if we use the axial support rotor wire, maybe we can create a pressure. That's what I'm thinking about. So I'm going to already. I have treated the alignment to LED with a 1.5 burr to take away a little bit of the heavy calcium and the upper wall of the alignment bifurcation. Now I'm putting an axial support wire inside the circumflex. I'm trying to use the bias cutting to treat the calcium at the innerval curvature of the lemon circumflex curve.
Very great.
Yeah.
The best wire bias would be the wire close to the outer curvature of the circumflex, right? Because
No, I'm going to show you. There was two wire bars there, so I'm going to show you.
From the angiographic, the calcium seems to be the outer curvature of the vessel.
Well, as you can see right now at the moment, there were two wire bars. One is the left main to the circumflex ostium. You can see the wire now presses on the heavy calcification. But beyond that, you can see now the wire touches the other side of the circumflex at the very proximal, at the beginning of the OM. So there was two wire bars there. What I'm going to do is treat the rotor ablation for the very first curve, but not to touch the second curve. Otherwise, it may create wire bars and dissection at the proximal circumflex. I think that is my theory.
What kind of wire you use? Floppy or extra support?
No, to create such kind of the bias cutting, we got to use the axial support wire. So right now you can see on the screen, the axial support rotor wire is in place. Dr. Nakamura, what else do you like to advise me?
Oh, already you did.
No. I have already done the rotor ablation for the from the left main to the LED, but not from the left main to circumflex, because we are waiting for you.
Okay. Circumflex also. Maybe I think little taking time, but maybe every procedure, after every procedure, maybe I think check IVUS to confirm with what you did, and then maybe proceed the next steps. Maybe I think this is my recommendation. But leave it to taking time.
Yeah, I quite agreed with you, because in this kind of the tough lesion, but not too complex, but to not, I would like to take your advice and do it with patience and doing it step by step.
Yeah. So actually, currently we have not only rotor, but also currently we have a shockwave and a Diamondback. So actually we can use a Diamondback, not yet the shockwave, but actually, so outside Japan I use a shockwave. If we use a shockwave and a Diamondback and a rotor, maybe I think we can do most of the calcified region in the left main. But now you have only the rotor, and maybe you need some technique to change the direction of the rotor. And
Absolutely.
then confirm the IVUS after the procedure.
Absolutely agree with you. Okay, but however, at this moment we don't have shockwave balloons. So because the calcium really thick and also deep. So I don't think the rotor ablation will do all the can do all the role. However, it is better to do rotor ablation than doing nothing.
Dr. Lee, have you checked the IVUS to make sure the wire is biased at the calcium?
Not yet.
From the images, it seems the wire seems to bias to the opposite of the calcium. I'm not sure.
Yeah, that's true. Because you can, when you as I can show you, as Dr. Nakamura said, this is a really difficult to treat lesion. You can see there's no way for the Boston Scientific catheter, IVUS catheter to going in. That's what I'm worrying about at the very beginning of the procedure when I look at the cine. So also, there was somebody said you can always put in a stand from the layman to LAD and to see what happens to the circumflexor. But I don't agree with that, because if you put in a LAD to layman stand, then you have to treat the circumflex. Then you have no way to get into the circumflex, and putting in a stand would be very difficult given the angulation from layman to circumflex in 90 degrees.
Actually, if you want to use a stent, maybe always we need a condition. So condition meaning best preparation. If we can finish the stent, and good position of the stent and the round shape, this is quite very important. But if you cannot, maybe I think we need another option with just leave it. So because of the calcified, it's actually for the patient, left main to the LAD should be perfect stenting. But the circumflex option, if you cannot finish the very perfect stenting, maybe I think just leave it. It's one of the options.
Okay, thank you very much. Thank you very much. And the other point of the to consider is the size discrepancy from the layman to either LAD and circumflex. Given the two vessels of the LAD and the circumflex was only 3.5, and the only stand that can expand to more than 5 is the Sierra. So there were different stands manufacturers in the market, but we have decided to use to choose the Zions, because the Zions Sierra, because this is the only stands that can expand to 5, more than 5, with the 3.5 make.
Procedure.
Okay, thank you.
Any comment from our panelists? Fang-Yu, 有没有 comment?
不用。
Could we see the IVUS after rotor operation?
Okay, sure. No, I'm going to do the because the bird was inside the wire. I'm going to treat the circumflex, and I'm going to show you the images after the procedure.
What size of bird will you start with?
Oh yeah, this is 1.5. Okay.
The purpose of the rotor operation just for plaque modification, right?
I'm sorry.
So the purpose is just for plaque modification.
Oh yeah. This is for bias cutting only. 这个帮我推过去一点点，推过去一点。 Okay, good. Thank you. So I'm going to leave the bird stop at the 2 centimeters in front, behind the guide. So I'm going to control the bird very exactly, depending with the using the calcification as the mount. I'm going to use 180. See, the calcification really tough. I don't think you can see the blood pressure. However, the blood pressure just 120 and activation of the bird. However, it returns to 140 after I just stop the road ablation. I'm going to try that again because this is going to take time. See, really difficult.
Stop floral.
If the 1.5 bird cannot go, I would use the 1.25.
So you don't use the so-called pecking motion to try to advance your bird. So just
now I'm going to control the bird position exactly. So I'm not going to use the pecking position. Okay, it goes.
Stop floral.
It does you pass through.
Oh yeah. But I would watch very carefully the relationship of the bird with the calcium. So if the bird deviated from the calcium too much, I would stop without hesitation. Okay, now the blood pressure is 140. I'm going to make more ablation.
I think it's very safe for you to do this case because you know all the complication of rotablator. You ever analyzed all the perforation cases and what kind of mechanism of perforation it occurred during the procedure? You know everything. So this case is very safe for you to do it.
Thank you very much. I never thought that they ever read my article. It just published just 2 weeks ago. Yesterday I met a colleague. He told us he told me that Japanese Society of Intervention and Cardiovascular Therapeutics also published the expert consensus on rotablation. I read the article, and the experts there actually made a diagram on how to treat the circumflex oscillation. That was very amazing. They and me have shared the same opinion because the rotor bias cutting is really important in treating these kind of lesions. So you can see now the bird touches the calcium, and I'm going to make a puff. Okay, see, it's really enough. Dr. Nakamura, what do you think?
So can I see one more time?
Yeah, see?
Oh, looks very nice. Looks very nice.
Yeah, yes, this is what I'm thinking about. So I'm going to make more ablations.
Yeah.
But to switch the wire back to the regular workhorse one.
So totally, you just only ablate the O-stem of the circumflex only.
Oh yeah, yeah.
So no need to pass the bird too far. Yeah.
No, it will create another bias cutting at the proximal circumflex.
Oh, very smart.
Okay.
Yeah, very smart.
So Dr. Lee, how's your rotational speed of this bird after
180. 180.
Not so high speed.
No.
Mm.
Okay. No. Just a second. OK， 来，不，你不要打我的东西，来，可以，帮我打开来。帮我拿药，外，那个东西，那个管子卡住了，不要动，你不要管，不是啊，那个是另外一个管子，你不要拉，千万不要拉。Okay, good. This is my habit. I like to control the web by myself. Okay, thank you. Perhaps if you like, you can move to other rooms while we are continue finishing the other procedures. Are you going to stay with me?
We want to see you do the case.
Okay, no problem at all.
So what is your strategy for this bifurcation? 2 stand or 1 stand?
I'm going to do it 2 stand. Because as I said, if you put in a stand from the lemon to LAD, then you have no way to treat the circumflexation, given the angulation is 90 degrees and they were heavy calcified and osteum when the restenosis happens in the circumflex in the future. Now I'm going to use the microcatheter to switch the rota wire to the regular workhorse wire.
Our panelists or moderator about the 1 stand or 2 stand technique. If what kind of technique you would choose for this kind of lesion?
See, I have difficulty to put in the fine cross. Because this is white Chewy, both Chewy is very difficult to use. I personally, my favorite is Goodman's. However, this device is, for me, is a little bit awkward to use. And I don't know what happens to the microcatheter. It seems it is not going to, okay. There's no way to put in because of the bias. Given this wire is not so I would be very, very delicate in putting the wire to not to create the taxation. Okay. Oh, not there. Chia-Pin.
I would like to ask our panel, and for such a case, if you use 2 stand strategy, what kind of 2 stand strategy would you like to use? What kind of 2 stand strategy is the best for this case? Or is anatomy, the angle of lemon, LED circumflex?
等离是到位之后，等离准到位的。
Dr. Guo, what kind of two stand strategy
Okay,
would you use in this case if you use two stand?
Without strong evidence, I won't do two stand in such kind of case. I mean, if the after 11 to LAD stenting, if the FFR showed less than 0.7, 8. I mean, put a stand if FFR after 11 to LAD stenting is less than 0.8, yeah. So on purpose, I would like to do one stand crossover in such kind of case because the angulation is very big between two vessels. I mean, LD and circumflex. So it's not easy to cover the ostium by two stand strategy. So I may use one stand in such kind of case.
Dr. Guo, if you prefers one stand strategy, then would you like to treat the circumflex lesion as I did just earlier?
Maybe. I'm not sure because if we treat it, maybe we need to stand it, and I think in current era, two stand strategy is very suitable for this case, and for me, the flow will determine the ischemia. So I'm not sure I will do circumflex also or not, but I think I would like to start with this case with OCT guidance if I do this case, because I can see more clear how calcified and the ring, the arc degree, and the depths of the calcium. But maybe I'm not right, but I think Professor Lee have done very good work on the circumflex os because it really make bigger and better flow after the rotation of the calcium crack. Yeah.
Lee, so what kind of strategy technique you used for this case?
I'm sorry, I can do only the Q-lot. So this is only one and the only choice. To me, that actually Q-lot is a versatile strategy. And personally, I don't think there is a contraindication to it.
For the circ? You would do the IVUS again for the circ to try to...
Sure. As I promised. Okay. IVUS.
So Dr. Lee, can you just keep your work?
Okay, I can show you. I can show the IVUS. I can show just a second.
Okay.
I'm going to satisfy you guys. Just a second. Okay. Now the both wires are in, and the as I said, I don't know how to use the both two. Really difficult for me. also very good, very difficult one. Because this is wire bus at the upper wall. Dr. Nakamura.
Hi. Yes.
Can you see it? You can see that the devices cannot go through the very proximal of the circumflex.
Yeah.
You want me to treat it with the burr, or you are hesitating to treat it as me?
Okay. So first of all, I need to confess, Japanese economy is not good, but still, we have a very big, crazy reimbursement system. All the PCI procedure, we use IVUS, OCT, FFR, IFR, RFR. We can use it. Currently, at least in my center, that's kind of case. Check FFR, IFR. So confirm the ischemia of the circumflex territory.
Okay.
So maybe I think that in this case, at first we check the physiology. And actually, you did rota in a very proximal path. So maybe in this case, in Japan, check FFR, and if you cannot see any ischemia, maybe just leave it. Because of the calcified surface, it's not good, is not good for the stenting. So maybe I think, like he said, the stenting, the left main LED, this is a great, very important mission. But circumflex, if we cannot, if we think, if we cannot do the compressor stenting, maybe I think just leave it is one of the good options.
Is there any safety concern if the left circumflex is left unstented?
Safety concern.
Safety concern.
God love me very much. Maybe it's okay.
Okay, thank you very much. Other opinions from the panels?
Huang Wen-Pin from Cheng-Cheng Hospital. It's a very tough case, and you have choose a very brave and smart strategy. But will you check, because the intravascular image is very important, will you check the left to LAD by IVUS more easier?
Oh, sure. But our focus is in the circumflex.
Before you start the road operation, will you use a small balloon to assist the IVUS to cross to the LAD and get the first intravascular image?
Yeah, we have done the IVUS for the LAD. Okay, if you like to see, I can perhaps we can switch the IVUS catheter to the LAD. But okay, just a second.
So thank you, Dr. Lee, and now we can we invite Dr. Nakamura for the lecture about the CTO?
Sure. Go ahead.
Sorry,
CTO.
No, sorry. Okay. About the shockwave and the role of DCA.
LAD.
This is the IVUS from the circumflex.
This is the IVUS run from LAD. From proximal LAD. Is the calcium nodule at 3 o'clock. Right here, the vessel here is about 3.5. And of course, we have some plaque from 12 to 3 o'clock. And it's a superficial calcium, and here is the ostium. Here's the circumflex wire comes from 9 o'clock. Here's the distal left main. Here's the distal lemon, and you can appreciate that vessel is quite huge. It's about 5. Now it's back to guiding.
So totally, we will come back to you later, okay? After
Okay,
the
sure.
lecture of Dr. Nakamura. Dr. Nakamura, can you please start your lecture, please?
Okay, we have some problem. I can sharing my slide. Cannot.
Yes, we cannot see the slides. Yes.
Okay, now I can.
3.0不论
好，3.0多长15啊？330是不是？好，3.0 30。一般的 semi compliance。
Accept. Could you please activate
OK， 好。
your screen?
3.0 30。
Okay, thank you. じゃあちょっとメッセージ送りますか。Hello? Hello?
Hi, we still cannot see the slides yet.
Could you please activate the share screen? We tried to share a presentation slide. On your side, please activate the share screen.
이렇게 기대. 화면 큐 나왔네요. 화면 큐.
We are in the share screen already.
Actually,
なんでわかんないの
Dr. John,
Hi.
you're online. You're online.
Okay.
Can you
welcome back.
Your progress?
Yeah. I think I have crossed. As I mentioned, I think the anatomy is quite confused to me, but finally I got a clear picture. So I think what is changing is that this is a stumbless CTO. After the OM branch, the circumflex is totally occluded. Maybe we can see a stump, but the angle is very acute. So what is changing is that anti-gray, anti-gray approach is challenging because we need some support and to get the wire in. And after that, that's a very acute angle. So I think for anti-grade, maybe the panel can give me some suggestion at the beginning. Although now maybe I'm lucky I have passed. But with this setting, any comments?
You show the yes, the image on the center of the screen. Yeah.
Okay, maybe I can share with you my strategy. I think because it's post-cabbage lesion with totally occlusion. So in my experience, almost the entry part is very stiff, even you don't see very heavy calcification. So, and it's stumbless. So my plan is to use Crusade following the wire in the OM branch to approach anti-grayly. But because the angle is very, very acute, if someone can show the angiogram before operation, can someone show the angiogram before operation? Then you can appreciate how acute the angle is after the entry. I don't know whether they can show it or not, but I think because this is very challenging, so I'm not sure that anti-gray approach can work. So I also prepare retrograde system from the Lima branch, which the Lima graft, which I've shown you from the very distal LAD. There's some collateral to very distal OM. Although the collateral is not that good, but maybe it's usable. But of course, I'll try anti-gray first. This system is a Crusade wire and a Gaia second wire. Any suggestion for this scenario? I don't think Gaia second is a good wire for this scenario, but I have no better option. Any suggestion for me?
Dr. Zhang, yeah. And in my opinion, I have some experience about this integration to the circumference, and I have tried only STR and negotiation the lemon curve, and it can go into the circumference smoothly. And at the first time, I don't use the Kusei catheter. I just only wiring, try to into the circumference, and I don't think the angulation is too big for circumference.
Can you see the angiogram, the diagnostic angiogram?
I see. And in my opinion, I think the curve to the LAD is more curved, more angulation. I need and maybe counterclockwise into the LAD. So I will try only one wiring and don't use the Kusei catheter to try to go into the ostium.
So you think the lesion may not be that stiff, and maybe you can tracking?
Yeah, that's all. I think so. There's some channel. I think.
Just as I mentioned, in my experience, most of the post-cabbage lesion. The native vessel, they're quite tough. Maybe Dr. Nakamura, we have done a case with cabbage 1 or 2 years ago. We cannot advance at all, even with A20 wire. So that's my experience. So I skip the soft wire, and I think maybe a wire with a better support maybe workable. But with of course with Gaia second, the primary curve cannot make me to reach the entry because there's an angle. So although making a secondary curve for Gaia is not a good idea, the wire performance is totally different, but I try the wiring without making further curve initially, but I cannot catch the entry at all. If you can see the angiogram now, under the support of the Crusade with a secondary curve, small secondary curve, I think I catch the entry. If you can see from the spider view, it's a very acute angle. But of course, the performance of the Gaia is totally different with this curve. So I just as I mentioned, with this curve, I don't know what is the best manipulation for this wire, but luckily I do not manipulate the wire as I usually do when I use Gaia second. Sometimes I advance, sometimes I torque, but fortunately I make some progress. Maybe here. Okay, let's skip it. But anyway, I think I make some point entry here. After confirming that I'm in the entry, I control the wire. Maybe that's the way I control that wire. I think it's quite stiff, so I really don't think any XT wire can penetrate the entry. So use this wire, I advance very carefully. But you can see, to be honest, this is not a very long total occlusion. From the RAO or AP caudal view, you can see maybe there's some collateral here from OM branch. There's some retrograde flow from to OM branch, and then give some collateral to the circumflex. So I think what is the most difficult is this part. And sometimes I can see the collateral, but sometimes I cannot see it very clearly. So as I remember in the previous angiogram, LAO cranial gives the most clear image of the collateral. So you can see, can you see right above the wire, you can see some collateral, although it's not very clear. Can you see, show the LAO cranial? LAO cranial. Can you move the LAO cranial view to the stent? Okay, okay. So can you see it?
Yeah, we can see now.
Yeah. But when I turned to the LAO cranial, I found that I was totally wrong. After this acute bending, I should go upward from RAO, from apicaudal. There's a curve, then there's another acute bending.
Yes.
So the wire is in the wrong direction. But I went back to LAO, try to adjust the direction of the wire. And I think after try for a while, I think I'm right. I have crossed, but after I checked from the LAO cranial view, I found I was totally wrong. Maybe we can skip some of them. Oh, here. Okay. So here, can you see the LAO cranial view? I have to go upward. The direction is upward, but it's quite difficult to control the wire without support. Especially, I make a secondary curve at the tip of the Gaia second. So I think the easier way at this moment is to exchange the crusade caster to usual micro caster, and then I can reshape the wire, and I have some chance to cross. So here's the. So can you see from LAO cranial up to here? I think maybe I'm right, but end up I'm wrong. If I check from the other projection, I found I'm wrong. Maybe we can skip all these, but anyway, I changed the microcaster to Corsair. Now the microcaster you've seen is Corsair, so I changed to a new wire, which without the secondary curve. So from aerial view, I think I'm still in the right direction. So what I need is to adjust the wire direction from LAO cranial. So can you see the LAO cranial? The wire is downward. So I adjust it now. It seems the direction is right. So after this, I think everything is not a big deal. So I think we have crossed, we have we have done pre-dilation. So, but we haven't done any angiogram and IVUS yet.
Okay, Dr. Zhang, this is really very tough case, and congratulations, you passed the wire.
Thank you.
And Dr. Nakamura is ready for the talk.
Oh yes, please.
To, his talk. So Dr. Nakamura, can you? We have seen your slides already. So can you start your lecture, please?
哇，过不了，好吧，2.5再来好了。
刚刚看到了。
いいですか？画面共有でこれですよね。共有。
で、最初は。Okay, can you hear me?
Yes, we can hear you. Yes.
Okay, so sorry taking time. So let's start my talk. So title the Japanese Test Strategy Guidebook for Complex Letmen and Calcified Letmen. Okay. So making a light of the foundation work, building a destined to collapse. This is our Niccolo Machiavelli. Means every success depends on the preparation. Meaning for us, doing something pre-PCI, pre-stenting. So actually, first of all, now regular PCI stenting is always the end point. However, good perfect stenting always needs some vessel preparation. From this meeting, we have several devices for vessel preparation, as you already know. Today, just want to pick up the 3 devices: shockwave, diamond back, and DCA. Actually, this is a case of 83-year-old gentleman who had a severe progression angina, having several risk factors and showing a big ischemia of a cinchgram. This is RCA. Actually, it's okay. How in this case, this is the left main severe stenosis, beautiful true bifurcation lesion on the left main, another true bifurcation lesion on the mid circumflex. Maybe you may think we cannot finish the BCI with a one stent. 2 or 3 stents we need. Maybe you think. This is another view, left main true bifurcation lesion. So now you can understand we have a double true bifurcation lesion in the left main and the circumflex mid. At first, I present to you IVUS pictures left main to the LED and the circumflex. So actually, we had a coronary CT picture beforehand. Upper panel show the IVUS on site corresponding to the lower panel coronary CT. As you can see, we have a calcium deposit in the left main to LED and the OM, no calcification in the circumflex. Again, no calcification in the circumflex proximal and much pattern to the plaque. Actually, these findings contribute to make a decision with the strategy. Please look at the IVUS finding of circumflex proximal. This is a big plaque burden, more than 80% plaque burden, as you can see. So from this diagram, you may assume we cannot avoid the double stenting. And of course, everyone believes if we can finish the one stent in the bifurcation region, long-term result would be very nice, but it looks very difficult to finish with one. As you already know, we have two dogma in this area. Provisional stent in a European group and DK crush with a DK crushers in China. And both are friends of mine, so I cannot take one usually. But by the way, my great respect to Steve Jobs said,
"Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice."
So I'd like to choose my own idea. At first, we'd like to divide the 3 parts, left main to the LED. Superficial clarification, which is not good for the special device for which I consider, but easy to implant the stent. Circumflex. Actually, this is very short, but big plaque burden, few clarification, maybe good indication of the DCA. Circumflex to OM, this is a very diffuse superficial clarification, looks easy to implant the stent. So, very important point for us is using DCA and circumflex because if we do that, we have a possibility to avoid a complex overlapping stent in the left main bifurcation area. Let's explain the procedure of the DCA. At first, in the test cut, like this procedure, like this picture, of course, we can recognize the window of the DCA case, so, as you already know. So we can estimate the region of the direction of the cut. However, we need to confirm the IVUS all the time, what we did right or not. After we confirm, we need to proceed the next step. Again, after confirming what you did right or not, like I was finding, you need to proceed the next step. By the IVUS finding, we will get a good orientation. Then we need to number the cutting. With starting a low pressure 1, 18 minutes 2, 18 minutes 3, 18 minutes 4, 18 minutes totally 30 cut. After totally around the 30 cuts, now you can recognize how much plaque burden we already removed. So actually, big plaque burden 88%, going to decrease 37 to 7%, less than 40% is the plaque burden. These are the IVUS series after the DCA with 1, 2, 3, 4, 18, total under 30 cuts. In each procedure, always checking IVUS to make sure. Then stenting OM to left main, finally KBT, and the final pot. This is the final angiogram. How do you think? So-called hybrid with DCAB and DES. This is a pre and post, no overlapping. Of course, follow-up is very important. 4, 10, 16 months follow-up, and just angiogram and OCT, as you can see, beautiful follow-up angiogram. Of course, checking physiology is okay. DCA, very effective, but we need a condition. Need IVUS 100%. You should be very familiar with IVUS. Now, if you have a superficial clarification, a bit difficult, of course, we have a learning curve. Additionally, usefulness of the DCA in the bifurcation area is not only reducing the number of the 2-to-1, sometimes tentless. This is the case of LED just proximal. Maybe most of the use think a crossover left into the LED, but if you can do DCA very perfectly, we can finish only the DCB, like this. And this particular case actually in the no restenosis. This is a case of left main distal, like today's second case, but no clarification. Most of you plan crossover stenting the left main to the LED, but if you can do DCA perfectly, we can finish with only the DCB. This is IVUS picture, as you can see, pretty much plaque burden in the distal left main, while no obvious plaque in the LED in the circumference ostium. At first, we did the DCA, the left main to the LED, plaque burden reduced 91 to the 54, and then DCA to the left main, the circumference, and totally more than 100. This is a bit too much, but so actually we need. And then double DCB kissing. This is a pre and the post. We could reduce plaque burden 92 to 43%. We had a perfect angiogram DCA. Actually, this is the 12 months. So actually, we already have 31 cases of DCA at the bifurcation area. So we don't have no MI, no death, and so actually only the one TLR. This is DCA. So next about the calcification. This is a case of very severe calcium left main to the LED, actually obviously. OCT pictures, and found a very severely diffuse large arc, more than 200 degree calcification, and more importantly, this is very sick. So about shockwave, my grandfather Antonio introduced 4 years ago, actually for me. And then stenting to the, then starting the collection of data and the guidance of the Antonio. But they are the task force in the investigating the shockwave. Shockwave, it works actually. This case with shockwave 275 S session, 325 the S session, so gradually inflate the 10-second shockwave 4 times in each region. This is OCT finding after this procedure. You can see part AB. We got the enlarged lumen, but not obvious plaque. Part BCD shows some dissection and the calcification. Only the panel E shows the crack of the calcification. Most importantly, left main area using a 375 shockwave, the 8th session, and plus high pressure burning. After using a 3 onyx stent and a check OCT, we got a very optimal stent expansion and not obvious, not dissection in the distal. So good result. Back to the baseline OCT, we can see the very thick calcified plaque. And if you look at the second vertical line, you can see some little cracks and no lot of the dissection. And third vertical line, we got a beautiful expand, pretty round shape, and very above the stent slot. Little bit less picture of the crack of the calcification, mostly dissection, but the result is quite okay. This is actually a bit interesting. This is another case of interesting case of a very calcium reference to circumference LED area. As you can see, we had a very, very severe calcium lesion all the way. Especially, we never expect a good expansion in the circumference of proximal area. At first, check OCT, and you can see diffusely severely thick calcification with a large arc more than 270 in the proximal, again, very thick. And we did 2.5 in the shockwave and proximal to the mid circumference and post dilatation 3.5 NHG balloon with a very high pressure. And actually did the stenting. Actually, this is the Antonio case. Good expansion of the stent. At first, I said Never expect this kind of the expansion. Next LED, we did the 3035 shockwave in a 16 session. And then we can see the several crack of the calcium, but not so much as we expected, while we could see the expanded area after the shockwave without crack. And then stenting. And then this is the OCT picture after the stenting. We can see the very beautiful full open up with the round shape of the stenting. Circumference to the OM, circumference to left main, also very beautiful round shape, full open up. This is the final angiogram. Shockwave, it works. In the case, very calcified region with the pitch angle show the more than 100 degree and very thick calcification, it works. Still, we have several questions. If you have a big ostium, the circumference, will energy losses occur? And the second question is if you have a very, very, very thick, it works. And the third question is sometimes we have the very interesting picture, which is very enough to expand the vessel lumen without a small number of the crack, meaning that does the shockwave have a power of modifying the calcium plug without cracking. Number 4 is a pattern of the calcification. So finally, diamond back. This is very unique because the very fine diamond back, diamond coated crown pictures. Diamond back, not easy to control, but then we have so actually we have a running curve. Interestingly, ball sticks movement follow the guide wire bias like a rotor, but a bit different one. And very need to be care. We sometimes cut even a software. Rotor going to only calcify, but this is this going to the even a soft plug. This is a paper from the CRF, but you know the future of the difference of the rotor and the diamond back. As you can see, diamond back system can average much bigger than a rotor in the case of the bigger vessel. Usually, rotor blade tend to air shot in a large pipe fight, but this is one of the different future of the rotor and the diamond back. As you can see, this is diamond back makes a funny movement, mostly moving rule of the guide wire bias. If you look at the left picture, you can easily understand that the diamond back went into an area which is close to the vessel wall. And more interestingly, diamond back bar makes a funny movement, and mostly they are moving rule of the guide wire bias, and even a soft back they are going to. Just showing a part of our research. If you ever evaluate, anyway, if we evaluate the length between the lumen surface and the calcium plug of the OCT catheter and the lumen surface, and then compare, evaluate the averaged calcium plug area, and showing this graph. This is the line chart of the bar graph. The horizontal axis shows the length between the lumen surface and the calcium plug in the OCT catheter position. And the vertical axis shows the averaged calcium plug area. Now you can understand future of the diamond back. Diamond back average much more in the area of the cross vessel. This is the final case, actually. One very interesting case. This is a very unique ISR in the left main region. And the region located the funny position, the bottom of the left main, which is not good target to the rotor and the diamond rotor. Unfortunately, patient had the 4 previous PCI with a different DS. Because of the funny position of the ISR, we use diamond back. And this is the OCT. You can see there the mixed tissue after the fibrous plaque and the deep calcification and some lipid plaque. Of course, every 4-5 rounds, check OCT. And I finally did around the 30 round. And then stenting. Because of the effective plaque reduction, get enough achieve lumen after multi-layered stenting. And the checks physiology, it's okay. So finally, just I want to say, in China, we have a great teacher, as you already know. He said, clever fight is the one who not only win, but excel in winning with ease. Also said, great victory should be adoption of the surprise attack which is depend on the situation. That is the battle which is a combination of the regular tactics and irregular tactics. I think this is exactly the meaning of the DC and the shockwave and the Diamondback in the before stenting. Thank you very much.
Dr. Nakamura, thanks for your excellent speech. I'm Dr. Juey-Jen Huang from National Taiwan University Hospital. It's very nice to meet you on the air in the morning. Okay.
Thank you. I miss you very much.
In Taiwan, the COVID-19 situation is quite safe around the world. So
yeah,
we
best in the world. No need mask.
Okay. Thank you.
Thank you very much. Thank you very much.
Thank you. We miss you. We all miss you. Okay, so let's turn into the Dr. Chang-Chiren's lab.
Hi.
Back. Dr. Zhang, will you show your case? What's the progress?
Good morning. When you leave me, we have crossed already, but and I can dilate with a 2.5 balloon. But when I try to check IVUS, I found that I cannot advance the IVUS cast at all, right? At the osmium at the takeoff of the circumflex. So I do repeat dilation again, and I try to use a guide extension caster to support or to get a better alignment. So now I try to check to advance the IVUS caster again, but this time it seemed to be bad. But again, I have very strong resistance at the entry of CTO. I think the problem is the angle. Hope you can see there's a very acute angle here. I advanced it a little. Oh, okay, now it advanced. Wow, but the caster has several acute bending made by me. We can check whether the IVUS still can still workable.
The curve is very tortuous. Yeah.
Yeah.
It will be very tough case. The second phrase is very tortuous. Is
okay. So we'll ask Dr. Lin to read the IVUS finding. Okay. It's not moving.
Is it moving?
No, I don't know.
No.
It's not moving.
Okay, it's moving.
No, it has moved a lot. I think we're still in the circumflex raised left main now. Yeah, we're in the left main.
Okay. So here is already we located at the lemon, and lemon is diameter is at least 3.5 to 4. And now the image is not clear here.
Yeah, because we use guide extension caster.
In the child caster.
But maybe what is important is the circumflex. Can you review the previous run?
Okay. Okay, now here is the circumflex pullback, and here now the vessel is around 3.0. and with the calcified from 9 o'clock to 12 o'clock. And beside the calcium, we cannot see a lot, anything here. And now the vessel here is a little bit larger, about 3.0 here, and with a lot of calcium. But it's not circumflexure.
So I think there's quite heavy calcium, which makes me cannot advance all these devices.
Yes, but by this IVUS, I cannot exactly tell you where is the circumflex osseum.
Okay, so can you go
now it's
distally?
go distal.
Go distally, more distally, more distally.
Oh, hang on.
No, let's start from the very beginning. Okay, I think the IVUS has just passed the CTO entry a little bit. So this segment is inside the CTO segment. I'm not sure whether it's in the true lumen or not. Dr. Lin, is it in the true lumen?
Well, it's quite difficult. It's quite difficult to tell you that here is the true lumen or the false lumen, and it's already dilated by balloon, right? So because from the maybe 4 to 5 to 6 o'clock, I cannot identify the media layer here. And also we have another calcium right here at from 8 o'clock to 1 o'clock here. So it's a possibility that here is the collapse true lumen, but I'm not sure because right here with the IVUS caster, I cannot identify the 3-layer structure of the vessel right here.
Okay. So
any comments from the panelists? The true lumen or not?
I think the possibility of a false lumen is large.
Now here's the entry of CTO. You see, it comes into the bigger circumflex. Now you can go forward yeah, run here now and then go proximally.
Okay.
Proximally, more.
Okay.
Yeah, here's.
Dr. Zhang, because time is limited, I will move to another case lab. And please keep going on your work.
Okay, so do you suggest to do road ablation if I cannot pass?
No.
No? Yeah.
Sorry, no. I think you may use the Dolicaster or to pass the devices.
But I failed to advance the Dolicaster also.
I think you can use anchor balloon and try again instead of push the Dolicaster along.
To be honest, I have done everything you said already, but I still.
Sorry. Yeah,
okay.
But it is really very difficult case.
Okay, please switch to the case lab.
Okay. 你说嘛
Room 2.
对啊，我想可能是在副手，所以一直要看。
Okay, Dr. Zhen, please show your case. The Dr. Chief in the case.
Yeah, the Professor Ying has already finished the first case because he's still busy, so I can tell the final result. Then the Professor input 3/24 thinner drug elution stent from the LAD Austin to the middle part, and then we use IVUS to evaluate because this case has poor renal function. So we use the IVUS to make sure the standard expansion. But from the image the finding, we find there's some under expansion over the standard middle part. So then we use 3/8 NC balloon for high pressure dilatation from the standard, the distal, middle, and the Austin proximal side. So then we can shift to the final result. And The final result is show a good position from the LAD, the Austin to the LAD, the middle part. Yeah, this is the final result. Any comment or any question?
I think this is an excellent demonstration. And thank you for Dr. Chen.
Okay, thank you, everyone.
Thank you.
Yeah.
And please switch to the room 3. Room 3, Dr. Li Wen-Lieng's case. Okay, Dr. Li Wen-Lieng, we are back to you. Please show your case. I'm Dr. Huang from National Taiwan University Hospital.
Okay, I'm just doing the post-dilatation of the circumferences. So could you allow me a few seconds? It's a little bit, okay. Okay. I'm doing the post-dilatation of circumference more. Because it's a little bit difficult for the NC balloon to going into the circumflex. So we have struggled for just a while. Okay, after finishing the post-dilatation of circumflex, I'm going to show you what we have done after leaving you. Okay, just a second. Okay. Okay, now we got time. Okay, just a second. I put in the wire in. Okay, I'm showing you what we have done. This is what we have shown you by doing a precisely located rotor ablation. Just targeting at the very the calcium at the very outstream of the circumflex, but not to do not to ablate other parts of the circumflex. Okay. There's some difficult to going through. Now you can see the bird was inside the calcium and through. Okay, this is what we have done after finishing the rotor ablation, just targeting at very outstream. So we have done what we aim to do. And this is, okay. After doing this, there was some difficulty to switching the rotor wire back into the workhorse wire. So we have done it. Again, because of the acute angulation, you can see the IVUS catheter failed to go in despite due to some resistance. Okay, but we have done the IVUS for LAD. Perhaps we can show you. Chia-Pin. Okay. Okay, Chia-Pin had just come in. LAD 最后一个是 LAD， 嗨。Okay, director, please help to put the IVUS images in the center of the screen, please. Control center, could you help us? No? Okay. I'm sorry. So there was nobody to help us put in the IVUS images to the screen. So I'm going to proceed to showing you what we have done. This, after the, though the IVUS catheter cannot go into the circumflexes, but the balloon can. I first use a 2530 balloon to try to dilate the circumvallation and measure the lesion length at the same time. Because you can see now the lesion should be more than 30, so it was 38. So we choose 3538 Zine Sierra because only the Sierra 35, only the 35 Sierra could expand to more than 5 at the lemma. So when we choose in a stand, we have to consider other factors at the same time. Again, we put in a 30 balloon in the LAD, also trying to measure the lesion length. You can see that now the lesion was also more than 30. We dilated with a 2.5 balloon. You can see the LAD, the distal lemma can be fully dilated. Again, you can appreciate there was an S-band in the circumflex and starting from the lemma. So, okay. We have some difficulty to put in the stand, so we use a 5.5 guide liner to help putting in the stand. This is a 3538 Zine Sierra. Okay, we can precisely locate the place the stand, and they brought it up without any difficulty. Without the rotor ablation, I don't think the stand would expand at the very ostium of the circumflex. So that's the beauty of rotor ablation for the distal lemma bifurcation. After this, we test and showing you that the LAD was not jeopardized at all. So we brought it to higher blood pressure, and we use the Crusade microcatheter to precisely rewound. You can see now the wire precisely going to the LAD from the very distal stent strut. Okay, then we can show you there was no difficulty for the balloon to go in to LAD through the stent strut. Okay, and then we put in a 3.5. Also, this was a 3538 Zine Sierra using the distal. Using the LAD as the reference vessel size. You can see now we can precisely place the stand. It fit quite well, and also we brought it up without any resistance. And then we brought it to a higher pressure to 16. Then we also use a double lumen microcatheter to help the wire go into the circumflex. Okay, then we finished rewiring. I think not through the very distal stent strut, but through the center of the stent strut, because it was a little bit complex anatomy. So then we use the inflated balloon. It cannot go down the circumflex. Then we use another balloon without any difficulty. So it was because of the character of the stand, but not because of my technique. So after the 2.5 balloon, then we use, this is 375 9.1 balloon. So this is what we have done so far. Okay, so we
Dr. Wen-Lieng, excellent work. This is a very beautiful demonstration, the rotor operation for distal lemma calcification. So Dr. Nakamura, do you have any comment on this case? Please give us your comment.
Okay, first of all, this is very nice. It's actually nice, but for the patient, nice is not nice. But anyway, this is very difficult case because of the calcified region. And in this kind of case, imaging device is very necessary. And check imaging and then decide the strategy. And so after good vessel preparation, so we can do the anything and stenting perfectly. Like he did. It's a very anyway. He did a perfect stenting. More than perfect.
Okay, thank you very much. Well, as you said, I would like to be proud to say without rotablation at a very precise location, we cannot obtain a picture like this. So I would say pre-treatment and treatment strategy is really important, and lesion preparation really important for this very patient, very lesion.
Nice demonstration.
Congratulations.
Yeah.
Thank you.
Congratulations. Congratulations. Thank you. Thank you, Dr. Nakamura's comments.
I don't like the ball theory. It was very difficult for putting two stents and wire devices. So I asked Dr. Ren, the patient's attending doctor, to finish the last part of the job. As I said, I have finished the non-compliant post-dilatation of the second. Now we're going to proceed to post-dilatation of LAD, and then we finish with the port in the left main. And perhaps we have to finish with the IVUS imaging.
Okay, thank you, Dr. Lee. Nice demonstration.
Thank you.
And we will pass to the next session's moderator and panelist. I will invite Dr. Lin Chang-Chyi, Shi Junming, Hong Zhiling, Wang Jianzhong. And thank you, Dr. Nakamura. Thank you for joining us this morning, the Sunday morning. We all miss you.
I miss you. I very miss you.
Dr. Guo Hongyu, thank you.
Thank you.
And thank you
so
all
much.
the panelists. Thank you for joining us this morning session.
Thank you.
Here, I'm Wen-Lieng from Cheng-Cheng Hospital. On my right is Dr. Hong Zhiling from Changchyi Hospital. And On my right is Dr. Shih-Chi from Taipei Medical College. And on the further right is Dr. Wang Jiann-John from Cheng-Cheng General Hospital. Now we have Dr. Takashi Kubo online with us from Japan. He's a attending physician of interventional cardiology from Wakayama Medical University at Wakayama, Japan. He's also a associate professor for Department of Medicine at the same facility. I welcome him warmly. Now, can we start our program right now? We need to move to room 5 with Dr. Chang-Chyi with the last case session. Dr. Chang, please.
Welcome back again, but I'm very sorry we don't have any progress because we have opened the CTO, we have to pre-dilation with even 3O balloon. But what is said is that we cannot deliver the stent because of the calcium and several acute bending. So what I'm doing is trying to advance the guide extension caster to pass all these curves to ensure that the stent can be successfully delivered. But to be honest, I try guideliner 6 French. Hope you can see it with balloon anchored, but it cannot be advanced. The caster stopped here. I think that's around the distal left main, not even getting to the circumflex. So this is 3O balloon. We dilate with a bigger balloon. And again, with the balloon inflated, I try to advance the guide extension caster, but hope you can appreciate from the angiogram, there's some eccentric lesions, some calcium by IVUS, and the guide extension caster cannot be advanced at all. And I even shift to the telescope, the guide extension caster from Medtronic, which is more, the pushability is stronger and the tip is more flexible because of its special design on the tip. But to be honest, it stopped almost at the same position. So it doesn't work at all. So to be honest, I do not, I cannot think of any better strategy. So I need recommendation from the panel what to do next. Maybe the other option is a rotor ablation, but when we check IVUS, we are not sure whether we have a short segment inside the subintimal space. Although I'm not so sure, maybe it's not in the subintima because if it's the subintima, I think it will be very tough to recross back to the true lumen at distal circumflex. But anyway, I'm not so sure. And if it's in the subintima, rotor ablation will be very, very risky. Now I'm trying the smaller guideliner, 5.5 French, which is suggested by Dr. Ren Xilong. It may worth to try it.
Dr. Chang-Chyi, I'm Dr. Hwang.
Yeah, good morning, Dr.
Hey, yeah, my suggestion is that you try to use the high pressure balloon to dilate the vessel again.
I've done it. I dilate with 3O high pressure balloon up to maybe 14 or 16.
Yeah, you can go higher.
Go higher?
Yeah, just go higher and try. I think that's the easiest way to do it.
Okay.
Yeah.
See, I think we have a very acute bending right at the osm of circumflex. Okay. And some eccentric lesion at distal left main in play 12. Okay. Deflate. Oh, it's not bad. 5.5. At least it advanced a little bit compared with 6 French guideliner and 6 French telescope. Okay, in play. 10, 12. Okay, deflate. Hope we can advance a little bit, then I think we have a quite high chance to deliver the stain. Okay, in play. 16. Oh, it's still distal. Okay, deflate. Okay, 16. Oh, no. Deflate. No. 16. Okay, 10. Just 10. Okay, deflate. Yeah, it advanced. Oh, yeah, it's good. It's really good. Thanks, Dr. Ren, for his suggestion. Okay, in play. Okay, 10. Okay, down. So I think maybe I can try to deliver the stain. The stain we choose is a 3038. I think we have to put the stain back to the distal left main, which from the diagnostic angiogram, there's definitely quite a significant lesion there. And we cannot check the lesion at the distal circumflex by IVUS very clearly because the IVUS catheter cannot be advanced at all. Maybe at this moment we can check it again. 11点20 Okay, maybe to save time, we can skip IVUS. Okay, let's go. Stain. So I never compared 6 French guide extension catheter with the 5.5 French, but in this case, it seems that 5.5 works differently from the 6 French.
齐仁兄，
是，
我们先要去这个 room 2，所以
没问题，没问题。
录一下。
OK， 希望我赶快可以结束了。好
，OK， 谢谢，你这个做得非常好。So we're going to move to room 2 to Dr. Gao Xianli, please.
Morning.
Yeah, how are you doing?
Morning, everyone. Yeah, I'm doing fine, thank you. And also, I'm feeling lucky today.
Yeah, pretty good.
I'll ask Dr. Chia to introduce the case for all of us.
Yeah, okay, go ahead.
Okay. Next page, please. This is a 58-year-old male, and he has hypertension, and he is a smoker, 1 pack per day. And this time he had chest pain with cold sweating for hours, and he came to our ER. In ER, the ECG showed acute STEMI with inferiority ST elevation. And here's the angiography. And next page, please. Next. And this is an angiography of the left side coronary artery. You can see there's a proximal CTO of proximal LAD. And the distal circumference gives collateral to the DB branch and the distal LAD. And next. Next, please. And here's a coronography of the RCA. And the RCA, there's a total occlusion at the middle RCA. And then we perform balloon dilatation only and the thrombo suction. And the final result shows there's some collateral to septal branch. And no standing.
Okay, so the case is quite interesting because this is a relatively young gentleman and who suffered from an inferior infarction a couple of months ago. At that time, the right coronary was aspirated, but actually no stent implantation because the vessel looks very ectatic. So from the appearance, my suspicion is that he actually had Kawasaki disease from the beginning. But anyway, we are facing with the LAD total occlusion today, osteo, I would say. So let's read from the first shot today. Yeah. So when I had the angiogram, my impression is that he had collateral from the right coronary artery, both from the septal as well as from the cornus branch. He had at least 2 sets of cornus branch connecting to the LAD. And also he had the ipsilateral collateral coming from the circumflex system to the diagonal system. My hope is that this time, by the time the right coronary is recanalized, the septal collateral will be even more pronounced. But for me, this is a LAD osteo CTO, probably very short. So an antegrade attempt is still worthwhile. So this is the angiogram I had today. It's a right coronary injection. You can appreciate the ectatic appearance of the middle and the distal part of the RCA, but the flow is good. And you can see from the frontal, there are several septals and also 2 sets of cornus branch connecting to the mid-LAD. Can you all see that?
Yeah, very clear.
Okay, next. So with this information, I think we don't have to use a guiding from the right side because I think the collateral is so good, it's good enough for us to visualize the distal vessel. And I can see that the CTO segment is actually very, very short. So the chance of going retrograde is probably low. According to our APCTO algorithm, this is going to be an antegrade starting case. So this is a bilateral injection. We had a EBU, BL 3.5 facing the left coronary. You can see with the simultaneous injection, the CTO appeared to be very, very short. And also if you change to the spider view, the lateral, no. Please change to the, blow up the lateral. No, director, can you show the lateral? Yeah. This is even more telling. You can see there is a stump at the osteo LAD and it's funnel shaped. And from the collateral, you can see the CTO is actually very, very short. There could be even microchannel connection in the CTO segment. So like I said, this is probably an antegrade case. Next one. Please go back to the frontal projection. Yeah. Okay. Again, you can see the CTO looks very short. Okay. So that's why I said I feel lucky today because I think the case is straightforward and relatively easy one. Comments?
Dr. Gao?
Yep.
Jimmy Shi. What's your selection of the wire? Do you favor such a stump here? So try softer wire or some your choice.
Yeah, I think I will start with probably XTA which is tapered, very controllable polymer jacket wire. Because I think with the channel or soft tissue probing, I can probably make the cross. But before I do that, we can all appreciate that curvature between the left main circumflex and the LAD. So I started with IVUS pullback from the circumflex, just to make sure that these stump that we are talking about is actually an entry for the LAD instead of an ectatic vessel segment. So we had a pullback. Dr. Chia-Pin. Oh, okay, please. Comment.
Can you see the IVUS?
Yeah, we can see it clearly. Go ahead.
The IVUS is from pullback from circumflex, and circumflex looks relatively normal. And as we can see, I think maybe the stump is right here. The osteo-AD is right here, around the 3 to 4 o'clock. And yeah, just maybe, and this maybe the left main.
And also right before the LAD takeoff, there is a small branch coming off, which is identical to the spider projection here. So we have actually a very good landmark. Yeah, that's the.
Yeah, maybe a small.
It's a very small one. Yeah, very small one.
Very small branch.
Okay, so with that information, I have chosen a dual lumen catheter, which is a Sasuke, and then using an XTA, I'm trying to probe from the antegrade. So if I am not that lucky, and I was stuck in the CTO segment, then I will change my right side system into a guiding, and then probably go from either septal or the corners to begin my retrograde work. So this is going to be a antegrade starting and probably retrograde case.
Is there a timeline in your plan?
Well, I will probe with the antegrade for maybe less than 20 minutes.
Oh,
if by 20 minutes I'm not progressing, then I'll go for retro.
Well, wish you
or
luck.
Or if I have complication, or I was stuck and inside the CTO segment without any progress, I will go for the retro. So we had a bilateral bifemoral setup. Good. So I believe you are all familiar with the Sasuke dual lumen, so I'm not going to introduce that. But I think it's a very good dual lumen catheter because he had a very good crossability. Okay. Okay, please take a shot here. Okay. Good. I think the wire is progressing, hopefully to the right direction. Okay, inject. I think so. So we can also do a retro injection here. Yeah, we are probably 3 millimeters from our target. So I'm hitting some resistance here. I think it's the distal plaque. Yeah, you can see the wire starts to prolapse. So this is probably the time I switch the dual lumen into a single lumen microcatheter. So can I have a 2.5 balloon for trapping? 2.5, any 2.5. And 2.5 by 15. And a 135 Corsair Pro. Yeah. Any other suggestions here? Okay, we are ready for exchange.
Dr. Gao, this is Sam Hang from Kaohsiung. I usually do this kind of cases in a very simple way. Yeah, I think you make it very complicated. What I would do, I would just use perhaps a UB3 intermediate guy while trying to poke the total occluded site. No, I don't like to use the terrible type of guy while from the start.
Oh, you don't like the polymer jacket wire because the lack of tactile feedback.
That's right. When you hit a hard one, it is difficult to go. Sometimes it will go subintimal, easy.
Yeah. Well, Ultimate is also a very good choice. It's also a hydrophilic coated wire with a relatively blunt tip. So the chance of going subintimal, I would say, I agree with you, is probably less. The thing is that with the Ultimate, maybe you lose the chance of probing inside a small connection because of the blunt tip. But I agree with you that the chance of going subintimal will be less. So we are using a 2.5 balloon for trapping the wire and for the exchange of microcatheters. For this case, I'm using a dual lumen because the angulation between the two, the LED and the circumflex, are actually very acute. I mean, very wide. So if I use a single lumen microcatheter, the wire inside the microcatheter, I mean, the curvature will be difficult to decide. If I make it too big, it will tend to prolapse into the circumflex. If I make it too small, it will also be deflected because of the resistance. So I think a dual lumen catheter will give me more axial support on the second wire with a large bend. And that's why I did not use a single lumen lumen catheter in the beginning. Oh, the wire is lost. What is that? Ooh, okay.
Miss your wire. Where's the wire?
Ah, you deflate the balloon, did you? No? Oh, why? So why? Okay, no. So we can do it. Okay, deflate. It's okay. It's okay. This happened. So I'll make the wire out.
Did anybody deflate the balloon?
No.
What happened?
Dr. Chia did not. So it's not his fault. It's my fault. Wow. This is live case, not a taped one. All right. Okay. Let's see. Okay. I think I'm tracking on the same direction, huh? See if the microcatheter can give me more support.
Have you changed the LED wire already?
Retro. LED, still the XTA, the same.
Oh, okay.
Yeah, I think I'm closer, right?
Cross the region.
Almost there, yeah.
I need to puff right now.
You see, the distal part is still resistant. Okay, so the Corsair Pro is making some progress as well. I think now I have more resistance. I mean, more support. I think I'm through. Okay, yeah, but let's confirm with the retro. Yeah. No, actually not. I'm in a diagonal probably. Can we fix this? So from the spider, it's very clear that I'm in a diagonal. If you can move to the lateral projection.
We can see it clearly. It's okay.
Good.
We have split film.
Good. Okay. So I'm redirecting my wire, and if this failed, I will leave the wire in the diagonal and then use my dual lumen catheter again, retro injection, to insert a secondary wire. Okay. So you can see that, like I said, the distal vessel looks very ectatic. Yeah, maybe I should go into the diagonal first and then advance my microcatheter through as well. And then maybe change the shape of my XTA because I did not make too much of a curve at the tip. Now I can take it out and then shape it again. You know. Yeah. Well, is the image quality good enough for you? Because yeah, I use a... Don't
worry about it. We're just fine.
Okay.
We can see it very clearly, yeah. Well, we have split screen, so don't worry about it.
Okay. Because I reduced the frame count, frame rate, and the dose for the sake of radiation conservation. So if the image is not good enough for you, you can ask, maybe we can go back to the original setup. Okay, so I think all I need now is a redirection. Ooh, some resistance here. Huh? Okay. I can go to the septal like that, diagonal like that. Okay, LAD. Okay, so I think.
Okay, you're almost done. We'll get back to you. So work on it a little bit, okay?
Sure. Thank you.
Yeah. Thank you.
Thank you.
Can we move to room 5, please?
28
第5导管室。
好，20。
其任兄。
是。
成功了吗？是吧？
我们放了支架了。那这个5.5的guideline呢过去之后呢，支架应该就没有太大问题。那下面血管的情况，因为没办法 IVUS 评估清楚，所以我还是选了一个3.0。那我们在 deploy 的时候就是比较 under the pressure。那刚刚已经放了 stand 了。那我可以给大家看一个 angel。我们刚刚已经 check 过一次 IVUS。那在那个特别钙化的地方呢，其实stand expansion 是很不好的。或许有人可以 review 一下 IVUS 吗？那所以呢，我们现在用短的3.0 high pressure balloon 重新再做 inflation。不过因为这个地方刚刚是我们没办法100%确认它是不是 subintima， 而且呢有一侧是非常 heavily calcified， 所以这个 post dilate 我是有一点点顾忌的，怕 真的打太大会有这个 perforation 的可能性。我们刚最后一次打多少呢
？20，对，
是
第手。
没有，现在这里。OK， 没关系 ，Let's inflate again。我们再一次 inflate。20、24、26。OK， 久一点啊。It seems that by angiogram， 这个 angio 上看起来呢，它开的看起来是好像还好的，不过如果我们 check IVUS 这个 stent expansion 实在是非常的不好。那我想是因为eccentric lesion 那非常 heavily calcified， 有一次非常 heavily calcified。不过当时我们刚刚也讨论过如果是 rolled ablation， 它如果是 subintima 的话呢，怕有相当的风险会有vessel rupture 的可能性，所以呢end up 我们还是选择就只是用 balloon dilation。那当然可能这样没有办法 achieve 一个 perfect 的这个 stent expansion。我们现在可以再 check this IVUS。那我想这个 case 是非常有趣的，大概就是典型 post CABG 之后的 accelerated atherosclerosis。病人 triple vessel 原来大概都是70-80% 的 stenosis， 也相当 focal。不过 CABG 之后呢，很不幸，这个3条血管都发生 total occlusion。那主要应该就是因为native vessel 在 CABG 之后 competing flow accelerated atherosclerosis 的原因。那么我个人觉得这样的血管在做 PCI 实在是特别的困难。第一个，这个 anatomy 常常非常的复杂，那 collateral 也跟一般我们CTO 看到 collateral 的这个来源走向很不相同。那有时候呢，这个 collateral 因为bypass graft anastomosis acute angle 也常常这个很困难的做 retrograde 的使用，所以我觉得这些 lesion 当然我们遇到的越来越多，可是常常是有相当的困难度。OK， 我们现在post 类到这个28、26个 bar， 那我们看看这个 stent expansion 是不是好一点。这地方 stent expansion 其实还是不尽理想了，不过我们基本上已经达到26个 bar 了。这个地方我想 overall 的 expansion and position OK， 这就是我们刚刚提的，在这个特别 eccentric 钙化的内侧呢，确实这个 stent expansion 还是不好的。So far 我可能不一定有太多可以再做的事情。最近其实这个英国也有一个 study， 就是这个post CABG 的病人发生 PCI 之后呢 ，treat native vessel 或者是 treat graft。那当然它是一个 registry 的这个分析，那我看起来似乎 treat native vessel 它 overall 的这个 mortality 还是比这个 treat graft 要好。那我想 graft 的 durability， 尤其是已经是一个 degenerate 的 graft， 可能本身就是很容易再有这个复发。那而且呢，这个当我们处理 native vessel 的时候，可能会尽量 aggressive， 把大部分的 native vessel 有 lesion 的都尽量处理。可是处理 graft 的大概也就只能 keep graft patent， 所以 native vessel 如果继续 progress， 我想应该确实是比较容易再有新的 event。
对，齐任兄啊，
是
洪世林哈，
是，
我认为说你那个 post dilation 哈，
是
用 inflation time 比较长一点，因为你们通常 inflation time 都很短。
我大概 inflate 了20秒。
20秒，我通常都是最少30秒到60秒。因为有的话，我通常都是这样子。时间有时候就会令到真的是本来没办法 expand 的就 expand。OK，
不过这 case 呢，基本上看起来 expansion 是 OK，balloon expansion 看起来是 OK， 不过balloon deflate 之后 recoil 马上就 recoil， 我想我可以稍微占用下一个 appraiser 一点时间，那我们就照 这个洪医师的建议试试看。那我们30秒，1分钟好了，看看是不是有比较好的结果。但我认为这确实是重要的，因为就 patient 的 vessel 已经有够condition 有够糟糕了。那如果 post PCI 不能得到一个足够好的 result， 确实 long term 恐怕会是很大问题。
Subaccurate occlusion。
那其任我是俊明哈，那你用的那个 NC balloon是短的，
对，12
，OK。
28，好，那请计时1分钟。当然，这个 patient 的如果照这个 Salim scan， 其实 anterior wall 还是有问题的。那我想，因为这个 circumflex 其实确实是一定程度的 complex， 所以我们大概没有机会在这个 procedure 同时去rescue LAD。不过我想如果这个血管是 follow up 是维持 patent 的话，那我们当然有机会不管是做 tap 或者是 Q dot 再把LAD 这一段打开。如果就 Salim scan 这一整个 territory 都是 ischemic。1分钟到，麻烦告诉我们。
看一下那个，
看一下balloon是不是有全开
？pressure 是不是有降下来？有降下来，表示说它有打开了。
OK， 刚刚看起来 pressure 是没有降下来的。
没有降下就没办法。
没降下来。
没有用了。
我们也不过看起来真的有至少 angiographically 看起来是 better。谢谢洪医师的建议。看起来 longer 是work。我想我们就不再拉下一个这个 IVUS 了，因为可能会 delay 下一个 operator 的时间。
其实最少 angiographically 非常的漂亮。
是，谢谢。我们刚刚 check 过了，lemon 的地方我们用 4.0 post dilate 之后呢，整个 stand 的 expansion position 倒是好的。当然我们没有 cover 整个left main， 大概就是在 proximal distal left main disease 那个 segment 用 stand cover。
齐任兄，我想大家 panelists 也一致同意，大概到现在已经是很完美的结果了。
谢谢。
There's only this much we can do。那你有没有建议任何的时间 frame 可以去 salvage LAD？
我觉得这个病人并不是洗肾的病人。那如果以这个结果，实在说 restenosis 的机会，以最后的这结论或许没有这么高。但我觉得如果病人是 keep symptom free， 那或许可以半年的时间，我们同时看看这个circumflex 的 patency， 那也在那个时间来处理LAD。我想这个并没有一个 standard 的 recommendation， 什么样的 timing 是特别好的。
好，谢谢这个。
谢谢。
performance， 我们要到另外一个房间啊，恭喜你。
谢谢。
Room 2 please。高医师，我们现在回来。
OK， 我们等一下哈，我现在照个相来。
好，
然后跟各位一起 review。
好，现在已经到了 stand 了吗？快好了。
快好了。我们 review 一下好了。来，我们看一下刚刚so we have， 现在是讲中文还是讲英文都可以吗？
中文就可以了，因为那个日本的线上那个
好
还没来。
好，所以我们刚刚看到那个 STA 过了嘛哈，然后接下来的话呢，我就打算直接看 IVUS， 但是 IVUS probe 过不去，所以我们用了一个 1.5 的 balloon 先做一个低压扩张，然后之后呢 IVUS 就可以过去。我们来看 IVUS 好了。所以从远端开始拉回来，其实它这个血管是很大的，但是呢斑块相当多哈。哦 ，sorry， 这是已经到，对，我们从最远端开始看，对，再来，对 ，OK。
但这边是血管大概是2.5，顶多2.5左右，这边比较大一点，这边可能到接近3点多。play burden 是就像高主任讲都很厚。 钙化倒是不是非常的明显，其实应该一般的把 low angioplasty 应该是可以处理。Relative soft plaque。plaque burden 就像刚刚这边还是都是很重的 plaque burden。长度刚刚量大概可能整个 plaque burden 可能长度可能有40，就是整个 lesion 的 length 大概40 mm。好，这个已经进入 left main 的地方。那 distal left main 其实相对是 disease 是还好 ，disease burden 不是非常的重，主要 disease burden 还是集中在这个 osteo LAD 左右。
所以从 IVUS 来看 ，CTO 本身的长度大概是在20毫米左右，21、22左右。但是问题是，远端有一个很短的 relatively normal segment， 以后更远端还是很多斑块累积。所以我们后来照了相，来我们看一下 IVUS 之后的照相。下一个，所以我们 IVUS 看完了以后，我们照了一个相，可以看得到呢，其实大概这个 CTO 那段以后，后面还是有个大概连串的大概20 mm 到25 mm 左右的 plaque。所以如果我们只是放一个很短的支架放到 CTO 远端正常段的话，未来我们也许还是要再加一节。所以后来我们大家讨论了一下，我们决定用一个48把它一次涵盖过来。那当然考虑到远端血管的大小，我们选一个3.0乘以48的 Zions。那这样我们到时候近端开口的这个地方，我们甚至可以把它扩大到4.0、4.5，大概是这样的想法。那我们在 next， 那这是支架定位 next。这样子好像有一点点太出来因为我们晓得 Zions 它的那个支架它的 edge 是刚好在我们的 balloon marker 的中间的，所以我们可以用balloon marker 很精确定位。这样子的话看起来是太偏 left main 了 next， 所以我们把它往前推了一点以后再 deploy。OK， 这是4个大气压嘛OK， 然后 next 我们又把它拉回来了一点，把它的近端稍微喇叭口做到16。OK next， 所以我们现在就是对，还没有照，不过我想我们直接 IVUS 吧，不需要照相。我们直接 IVUS。
Austin 大概3.0，对啊。Austin 那边的 diameter 大概3.0左右。Austin LAD 对。
这么小吗？但是它好像
感觉量起来是大概这样。
这么小？对，因为我们刚刚从一开始 circumflex pull back 的话，感觉上好像很大。没关系，我们用 IVUS 看一下
4.0以上。
感觉上血管很大
不是。OK，
不是。
不好意思，看起来你那个 stand proximal edge， 都在 LED 里面，没有 protrusion
是，因为我们刚刚从 IVUS 看的时候，我们知道它其实 LED 的洞口是一个像喇叭口一样的，相对是很干净的，所以我们也许
有人会主张斜的凸起来一点，然后就 leave it alone。
那个，
对不对？
我知道你的意思，就是也许有一边凸出来到 left main，
它是歪的嘛。
对，我们来看看 IVUS， 我们就知道了，我们后续要怎么做。所以这是从远端看，远端的血管是有斑块了，不过我觉得 lumen 是很 healthy。这边开始有一些 build up 但是我们没有打算放到那么远。再过来应该 OK， 这是支架的 edge， 所以支架的 edge 是干净的但是看起来是 under expansion。我觉得我们等会还可以再用更高压更大的球囊做高压扩张准备一个3.5，
基本上都有3.5呢。
所以我们准备一个3.5 15的 high pressure。
近端我们 Paris 的估计大概至少有4到4.5
，maybe。所以我们现在慢慢往回看，对。不过当然看起来，因为斑块的 volume 很多啦，所以支架的贴壁是没有问题的那其实 expansion 也到 3.0 了，但是我们可以再 over expand 它。
Right。
我们都有注意看一下 LED osteo OK， 到了所以我们的支架其实刚好是在 ostium 上没有影响到 circumflex。好，可以停了。那请帮我们量一下 LED osteo 这边，我们 high pressure 大概要用多大？ 那么中远端我们用3.5。我刚刚跟阙医师有讨论一下，就是说这个病人他的 RCA 中断，到底今天要不要一次处理？看起来是有一些 ectasia， 但是残存的 lumen 大小又还不错，所以也许可以考虑 FFR 或 IFR。
我 Paris 的建议不需要了，
不需要哈。
对对对，
OK，
不需要，
那就不动它。
You know, for future。
对，
他这个 ectasia 太厉害了，这个 complication rate 很高的。
对，他这个血管到底它的 nature 是什么？是单纯的动脉硬化，还是说有一些其他的 inflammatory disease？ 不知道。
说不定中膜发育不良这种的也很难讲。会不会建议开口先用4.0来后扩再讲哈？
我现在用3.5，我会从支架远端一路扩回来，然后呢最后开口的地方我们用4.0。我们现在测量嘛，算起来多少？3.6、3.9呀。
3.9。
所以给我也准备一个4.0的NC balloon 哦。好，来6。
对，我们日本的讲师上线了，所以 you can start with English。
Okay. So this is a 3.5 NC post dilatation at no, go 16. At 16. Okay, down. Yeah, 4/12. Okay, again. 18.
Dr. Gao,
yes?
in order to save a balloon, they usually use a 4.0 balloon. And then we started at very low pressure distally.
my understanding is that
about using the balloon.
My understanding is that if it's an NC balloon, if you inflate at less than nominal pressure, then the balloon is not going to be actually inflated. Yeah. But if you go to the nominal, then I'm afraid that you will have some distal edge dissection. But I think balloon nowadays is relatively cheap.
或者那个南部的病人跟北部的病人投资的意愿比较有点差异。
Balloon won't cost the patient, right? Balloon is reimbursed.
But Dr. Gao, I started with reused balloon for a long time.
I know, I know.
I reused the balloon more than 20 times before.
Even now?
No, not nowadays. No.
Yeah. Okay, so this is a 4.0. I think after these, we will run the IVUS and then probably finish it up.
So, Dr. Gao, we're going to leave you now. Congratulations for your success, and I will move on to the lecture. The topic will be on OCT guidance for complex PCI. It's going to be presented by the I can't find the name. Oh, I'm sorry. It's Dr. Kubo Takahashi. Please, Dr. Takahashi, you're online right now. Go ahead.
Hello? Can you hear me? Can you see my slide?
Yes, please, go ahead.
Yes,
loud and clear.
Thank you so much. It's a great pleasure to join you. Congratulations. This is a great meeting, CHIP Summit. Today's my topic is OCT guidance in complex PCI. Especially I focus on the calcified lesions. Now OCT, as you know, it's a high-resolution intravascular imaging using near-infrared light. OCT can visualize very important atherosclerotic plaque features, including fibrous tissues, calcifications, lipid, thin fibrous cap, macrophages, basobaculums, cholesterol crystals, red thrombus, white thrombus, and CTO microchannels, and healed plaque layered structure. So especially OCT is very strong modality to visualize the calcium because there is no shadowing from the calcium. In OCT, calcification is characterized by well-delineated signal polar lesions with sharp borders. And a circumferential calcification is closely associated with stent under expansion. So pre-PCI lesion preparation is important to achieve optimal stent results in severe calcified lesions. So the key is a calcium fracture. Calcium fracture is associated with well stent expansion. OCT visualizes very clearly calcium fracture looks like this. In this case, we use a high pressure ballooning, and you see the pre-PCI circumferential calcification. After balloonoplasty, you see the calcium fracture here. And after stent implantation, stent is well expanded. Next case is we use a cutting balloon. Pre-PCI, you see the severe calcification, circumferential calcification here. And after cutting balloon angioplasty, you see the calcium fracture here, 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 according to the blade. And a stent implantation. Stent is well expanded, and the fracture site is widely expanded here. And this calcium fracture is closely associated with the a good stent expansion. This data is obtained immediately after stent implantation. Minimum stent area and the stent expansion index was significantly larger in the calcium fracture group compared to the non-calcium fracture group. And a long-term follow-up, least node slate, and a target lesion revascularization rate was significantly less frequently in the calcium fracture group compared to the non-calcium fracture group. So we measured the calcium fracture thickness. This left panel shows the thickness distribution of the calcium fracture. Median thickness is 450 micron, and the maximum was 770 micron. And the ROC curve demonstrated the best cutoff to predict the calcium fracture was 500 micron. So if you see the circumferential calcium, and you measure the calcium plate thickness, and if it is less than 500 micron, you can use a high pressure ballooning or cutting balloon angioplasty. And if it is more than 500, you should use a low ablation. So this is a low ablation image, OCT image of the low ablation atherectomy. Center, this is a fully low ablation, and a light panel, post-low ablation atherectomy. The OCT can visualize very, very clearly of the cutting surface after low ablation atherectomy here. And you see the plaque here, calcium here, and you can estimate the residual calcium area and calcium thickness. And you can, in this case, you can increase the bar size. And the left panel, IVUS, after low ablation atherectomy, you see the artifact reverberations, a ring-like artifact here. So image is unclear, but OCT provides very clear image. So calcified region, especially low ablation atherectomy, OCT is very useful. This slide shows the role of OCT in low atherectomy. OCT allows us to understand calcium arc, calcium length, and thickness of calcification. Number 2, appropriate bar size. Number 3, wire bias. Number 4, suitable guide wire. And number 5, appropriate endpoint. So this slide shows the concept, basic concept of the lesion modification for heavily calcified region. A, orange circle is a vessel, and a white circle is a calcification. So you can use a low ablation atherectomy to reduce the calcium thickness. And the next step, you can use a cutting balloon or high pressure ballooning to break the calcium plate. Then you can implant the stent, and you can get the very good stent expansion. The next is bifurcation, calcified bifurcation lesion. So left light panel, this is a calcium, and this is a side blanch, and this is a calcified bifurcation lesion. You can discriminate from the fibrous bifurcation lesion or lipid bifurcation lesion. And calcification, if you see the calcium opposite to the side branch, there is a high risk for the side branch occlusion after main branch stenting. So because a stent is not expanded to the calcium hard plaque, stent is well expanded, easily expanded to the side branch ostium side because it is soft. And carina is easily shifted to the side branch ostium, and it's very high frequency of the side branch occlusion. This is a typical case of a calcified plaque at bifurcation and a side branch occlusion. So left pre-intervention, angiography demonstrated the bifurcation lesion between the aerated and a diagonal branch, and OCT demonstrated a severe calcification at the bifurcation lesion. This is the diagonal branch. This is aerated. And after stent implantation, main branch is well expanded, but the side branch ostium is severely blocked. So this is the data. The comparison between the side branch stenosis and non-side branch of stenosis after main branch stent implantation. The calcium was more frequently observed in the side branch stenosis complication group, and the maximum calcium angle was 79 degrees, and it was significantly greater than that of the non-side branch stenosis group. And so in those cases, we can use a low tablet atherectomy to reduce the calcium to prevent the side branch occlusion, and of course to get the better stent expansion. So this is the bifurcation lesion between the aerated and a diagonal branch. CV blockage is here, eccentric plaque should be here. And OCT image, this is a pre-intervention, diagonal branch and an aerated, and you see the calcification here, very thick, and a circumferential. So we use the load ablator. After load ablation, OCT visuals the cutting surface of the load atherectomy. Calcium thickness significantly reduced, and here and here. So we use a cutting balloon. After cutting balloon angioplasty, calcium plate was blocked here. You see the calcium fracture, and then we implant the stent. After stent implantation, you see the diagonal branch ostium here. Angiography demonstrate very good results of the main branch and as well as the diagonal branch ostium. So you can use a low tablet atherectomy in the bifurcation calcified lesion. The next is a calcified nodule. This is a pathology, calcium plate here, here, and nodule calcification is protruding to the lumen. This is not so frequent, but one mechanism of acute Conway syndrome. This is a typical image of OCT images of calcified nodule. The lesion is here, and more proximally, you see the calcium plate here. And across the calcium plate, you see the heterogeneous tissue protrusion into the lumen. This might be a calcium nodule and a slumps here. And this is also the calcified nodule, and proximal RCA filling defect is here, and a circumferential calcification is here, and a calcium ball is protruding into the lumen. And also this is a calcified nodule, a filling defect is here, and an OCT image and an IVUS image. So calcified nodule is protruding in the lumen, and the IVUS is a high in high echogenic tissue. So if thrombus, should be low but high, so this tissue including the calcification. This is also very interesting image. It's a continuous flames from distal to proximal. And most of distal side, you see the definite calcium. And moving proximally, calcium is spontaneously protruding into the lumen. So this is acute results of the PCI comparing among rupture, erosion, and calcified nodule. So myocardial blast rate and non-reflow rate was less frequently in calcified nodule compared to the plaque rupture, but more frequently in calcified nodule compared to the plaque erosion. And the peak CK is smallest in the calcified nodule group compared to the plaque rupture versus and erosion. The problem is the acute results. It should be under expansion. Light panel shows the calcified nodule. Calcified nodule after stent implantation, stent is not well expanded. Conversely, for rupture, erosion, we can get very great stent expansion. This is data. After stent implantation, we compare the minimum stent area, stent expansion index. The calcium nodule stent expansion index was smallest compared to the plaque rupture and erosion. The number is 76%, so more than 80% acceptable. So 76%, it is not acceptable. So how should you do? So one way is a low-tablet atherectomy, removal of the calcified nodule. Left panel show the before intervention. Right panel shows after low-tablet atherectomy. After low-tablet atherectomy, calcified nodule is removed, and the lumen is widely open. This is a laser atherectomy case. Before intervention, you see the calcified nodule protruding, and after laser atherectomy, calcium volume was reduced, and then we implant the stent. Stent is well expanded. And recently we use the orbital atherectomy, diameter back. The baseline, you see the calcified nodule here, calcium plate here, and low speed diameter back, low-tablet orbital atherectomy. Cutting surface is here and here. And next is high speed pullback, and cutting surface, cutting area is increasing, and then we implant the stent. But late outcome is also poor in the calcified nodule because residual calcified nodule is protruding into the lumen through the stent strap. After 1, 2, 3 years later, after the stent implantation, this is associated with the very late restenosis or very late stent thrombosis. So at the time of the PCI, decreased removal by low ablator or laser atherectomy or a diameter back, it's very important. Finally, I will talk about the neo-atherosclerosis calcified mesenchyma. Angiography demonstrates the instant restenosis in the proximal LAD. OCT demonstrated this is definitely instant area. Neointimal tissue is here, and there is a circumferential calcification within the neointima. So it is easily expected. It is very difficult to expand by ballooning or by stenting. So in those cases, atherectomy is needed. So this case, circumferential calcification within the neointima, center strut is here. And so atherectomy, low tablet atherectomy was performed, and if calcium volume is significantly reduced, and then a stent was implanted. So this is summary. OCT guidance have a great impact on the PCI strategies and severe calcified lesions. Detailed evaluation of coronary artery calcification by OCT enables prediction of center expansion, evaluation of low tabulator effect, risk assessment of bifurcation side branch occlusion, and a diagnosis of calcified nodule and calcified meningioma. Thank you for your attention.
Well, thank you, Dr. Kubo, for your excellent speech on OCT assistance. Is there any question from the panelists?
Thank you very much for your excellent talk. It is Dr. Wang from Cheng-Cheng General Hospital. For those heavily calcified,
所以我就说要看，还要累积经验嘛。
And the rotabulation ulcer is indicated after rotabulation. How often you use the cutting balloon?
Oh, yes. After rotabulator atherectomy, you can use a cutting balloon. So first step is a reduction of the calcium volume. The next step is a calcium fracture by cutting balloon. So you can use first a rotabulator, and the next step you can use a cutting balloon.
So you mean you use the cutting balloon routinely after arterectomy?
Oh yes, if possible. If cutting balloon can pass the lesion, we use cutting balloon routinely.
About the complication after cutting balloon angioplasty, how about the complication?
Okay, so we generally perform the OCT imaging. If after rotabulator atherectomy, a residual thickness of calcium or residual plaque is very, very small. It's very high risk for the perforation after cutting balloon. So in those cases, we don't use. But assessment after rotabulator atherectomy by using OCT is very important to predict the risk of the complication by using the cutting balloon angioplasty.
The last question is, how about the size of the cutting balloon? Is normal size?
Yes, normal size.
Okay, thank you for your excellent speech. I have a simple question that what kind of OCT strategy that you can offer to protect the side branch, and especially if the calcification extended into the side branch, is there any difference in your recommendation? Yeah, thank you, please. Did you hear me?
Yeah.
Yeah, okay. Can you hear my question before?
Oh, yes. Mm-hmm.
Okay, do you want to answer on that? Or you missed my question?
Yeah. I'm sorry. Once again, please.
Yeah, okay. The OCT strategy, would you make different recommendation for side branch protection? Mm-hmm. And if the calcification extended into the orifice of the branch, well, would that make your recommendation different?
Mm-hmm. Yes.
Okay.
So if the disease is extended from main branch to the side branch, you should consider the rotabulator atherectomy, and not only the main branch, but also the side branch. Sometimes it may be difficult. At that time, high pressure ballooning the side branch and the clash or culotte extending should be considered.
But do you roll the side branch first or the main branch?
Yeah, if possible, by using a small bar, we also perform the rotabulator atherectomy, the ostium of the side branch also.
First, and then the main branch.
Yes.
Yeah, okay. So a lot of times we'll encounter a very acute angle. So You don't recommend that, do you? Well, okay. Well, we need to move to the cath lab, please. Thank you, Dr. Takashi, for your
Thank you
expertise.
very much.
Thank you. Hope to see you again.
Yes.
Bye-bye.
Bye-bye.
So we can back to room 2, please. Dr. Gao.
Hi.
Hi. You're
Hi.
on.
Yeah. Okay. So actually, there's not much we have done after leaving you. You can see that's the 4-0 balloon post-dilatation at the LED ostium. And after that, we did the IVUS pullback. We realized that the stents are well opposed, well expanded, and not missing any landmark, especially the LED ostium. But distal to this stent edge, there is some plaque, but we noticed that we did not create any dissection, and there could be some spasm over there. So we decided not to touch anything more, and this is the final with the wires out. The circumflex is not affected. LED flow is good. And also from this one, we can appreciate that all the branches, the septals and the diagonals are all well preserved. There is a small indentation at the distal edge of the stent, but we have confirmed that with the IVUS, so we decided not to touch it. Okay, so basically the case is done. Both groins are sealed already nicely by Dr. Chi. So I think
okay, well, thank you so much for your excellent performance. That you said you were lucky at the start.
I'm lucky.
We are all agree on that. So.
And you are being very nice to me. Thank you.
Thank you so much.
Thank you. Thank you. Thank you. Okay.
Yeah.
Okay. Bye. Okay.
So do we get another demo, please? Okay. So now we are moving to case 5 in cath lab number 3. Hey, Dr. Cao. They lost our audio. Cao主任, can you hear me? Stop moving your hands. 没听到。三岛的音效。
主任没听到。
你听得到吗？傅医师。
有了，这我听到。
曹主任 ，You're on.
你说。
Brief us the history and what have you done so far?
Okay, so good afternoon, Dr. Jian-Pin Chao. The one next to me is Dr. Juey-Jen, our head nurse.
Technician.
And Dr. Fu will present the case. Dr. Please.
Show me PowerPoint. Okay. Good afternoon, everyone. This case number 5, we'll do left main intervention. This is a case of 74-year-old male. Patient has underlying history of CAD and PCI to the LAD, and hypertension, POD, and PDA to bilateral iliac artery, and all CVA. This time patient complained with dyspnea for men. Patient EKG is sinus rhythm, and patient salience myocardial perfusion scan is positive. The transthoracic echo is comparable with preserved early systolic function and severe aortic stenosis. Mean pressure gradient across the aortic valve is 42 mmHg, and aortic valve area is 0.69 centimeters square. We do coronary angiogram last man, and it shows severe triple vessel disease involving LAD and second phase ostium. And we also know that porcelain aorta. Next slide, please. Okay, as you can see, AP caudal view, the left main is very sharp, and both LAD and second phase ostium have critical stenosis. And second phase also have another critical stenosis at middle to distal portion. And the right side cranial, aerial cranial view, you can appreciate instant stenosis at LAD proxima. Okay, please play the video. This RC is relatively normal, but there's a segmental tubular lesion as proximal to middle.
and another tendon lesion as PDA. At right side, you can see the porcelain aorta. Okay, thank you. This is our case.
So this is a case of CAD triple left reversal disease. Actually, his lesion is not at the left main, is at the ostim of the LAD and the circumflex. That is left main equivalent. And in addition to the coronary artery lesion, he also has a severe aortic stenosis. The aortic area was 0.6 by echocardiographic. So, we refer the patient to surgeon because severe aortic stenosis and the coronary artery disease. Unfortunately, his coronary arteries are very calcified. That's the porcelain aorta, and so the patient cannot cannot receive surgical aortic valve replacement and bypass surgery. Therefore, we would do the coronary angiographic and do the PCI for its coronary arteries, and then we will do TAVR for the aortic valve. So today we do the PCI first, and then we do the TAVR and late. Any comment from our experts?
What's your strategy today? Well, could it be a Q-lock sort of maneuver, or you want to do T-stenting instead?
We've been discussing the strategy because most of our cases of coronary artery disease with severe aortic stenosis, we go straight forward to coronary PCI. But for this case, we are doing the left main. So therefore, we consider to do the BAB first to open up the aortic stenosis first, and then do the PCI.
Yeah, I was asking the PCI strategy. Will you do a one-stent strategy or two-stent strategy or a Q-lock sort of or
because
this and that?
Because both of the ostim are diseased, so therefore I will go for two stents. Probably I would do the mini crash or DK crash.
Or do you consider Q-lock procedure?
I prefer DK crash first or mini crash.
Yeah. Okay.
Yeah. So any comment from our experts?
This is a very high risk case of PCI, and because of the critically stenotic aortic valve. Do you think this if we have the circulatory support, for example, ECMO is more safely perform the PCI?
Yes, sure. We've been considered ECMO, but this patient has a severe aortic stenosis. You can see from the cine. Can you see the cine? You can look at you can appreciate the aorta. It's very calcified from the aortic root. So if we insert ECMO, I think we will further increase afterload of the LV. That is probably not good for the LV. So if we are going to use the support device, I will use IABP. Therefore, there's a punctual sheath at the patient's left groin. If the hemodynamic is not good, we will insert IABP device.
So you're going to dilate the aortic valve first right now, right?
Yes.
Okay.
We have done it. So just show you the procedure.
Okay.
So we use this M+ to cross the aortic valve with a straight guide wire, and then change to super stiff wire. So this is balloon. This is the nucleus balloon, 18 millimeter. So after rapid pacing, we inflate the balloon, but you see balloon ruptured. Probably because too calcified of the aortic valve. But anyway, there is no air in the balloon, so that's fine. You can see here both the iliac artery has stents. It's very calcified aorta. Then this is I just complete the angiographic right now and advance the wires, one in the LED and one in the circumflex. And I'm going to do the IVUS for both vessels. This is what I have achieved right now.
Is there any complicated aortic regurgitation after the balloon dilation?
We didn't change, but from the hemodynamic data, you can see the. Can you see the aortic wave? The aortic pressure is fine. There's no signs of aortic regurgitation, and patient sleep well. He is still sleeping. The blood pressure now is 134 and above 63.
Actually, you can't see very much of the hemodynamic change acutely in AR. So you probably need to do a echo to verify it.
Yes, sure. So this is the echocardiogram. This is IVUS. Can you see the IVUS? Dr. Liu explained the IVUS finding.
Can you hear me? Yeah, this already looks normal. Yeah, the stents here. Here comes the stent. With some intimal hyperplasia and calcium.
好像麦克风没开，所以没听到学长声音，有听到。
There's another stent here. The stent looks normal.
就看确认讲康。
There is some calcium right here. This is lemon. Yeah, lemon.
Okay.
Stop.
可以了哈。
Stop.
Okay, so replay it. So the vessel diameter at the LED, mid LED was about 2.5.
2.5 to 3, and the distal stent. There's some calcium and
this is a narrow one here.
SR there. Very focal. And the stent here is normal.
So can you see the IVUS image?
You're playing IVUS right now.
Yeah. So this is the plasma LED.
Yeah, the blood burden here is just some calcium without heavy burden here. Yeah, the osteo LED is very heavy calcified and with some plaque.
Okay. So there's a focal lesion at the mid LED that is instant restenosis, and then ostium LAD is quite calcified, but it doesn't look like the calcified ring. Probably I would only do the cutting balloon, probably. But your opinion?
Just go ahead. Don't worry about it.
So this is the IVUS for the circ.
That's much.
哎呀，打水。Go back.
This is the image from mid-circ. Stop.
There's some problem with the IVUS. 我们再来一次好了，好吧？重回来要，我把它拉出来，等下重新组装一下。哎哈，好，我们开始开个 run 哈，新的 new run。还没有 ？OK， 来，
可以吗？有动。Oh, okay. And this is the image from mid-circumflex. And there's some calcium plaque, but the plaque burden is not very high. Yeah, this is very, as you can see that the plaque burden here is very high and with heavy calcifying.
Okay. So from the IVUS image, we can see the only osteo has quite severe disease, and but the calcium is not a ring. It's less than 180. So therefore, probably I would try to use a balloon to dilate the ostium. If the vessel can be dilated, I would put the stent. And for the instant restenosis, probably I'll treat with a DCB. Yeah. OK， 先来一个3.0的 NC 好了，3012。3012 NC。
可以大概3.5左右。
啊，是。
那个密色可能3.5左右。
3.5对，更放。
曹主任，你们慢慢开始做，我们要换这个第3个 section 的这个 host。OK，
谢谢。
谢谢。我们现在进入这个 section 3的 moderators。请。来，请啊。
we have another CTO and a lot of case today. And now I'm the Cheng-Cheng from Single Hospital and Dr. Ren, Cheng-Cheng Hospital, and Chief Huang from the Tainan, and Dr. Gu from the Tainan the same. And we have another faculty is Dr. Toru Nakamura. He is attending physician in the Department of Cardiology in New Tokyo Hospital in Chiba, Japan. It's the same with Dr. Sunao Nakamura. Welcome. Can you hear us?
Yeah, I can hear you. Can you hear me?
Yeah. Can you introduce yourself?
Yeah. Nice to meet you. I'm Toru Nakamura from Japan. Yeah. I'm glad to join your meeting. Yeah. This is my first time to join from my house.
Oh, yeah. So, I know you have been to Taipei for a couple of times.
Yeah. So usually I join you from my hospital, but this is my first time to join from my house. So my kids may struggle me.
Yeah, that's true. Okay, we another faculty is Zhang Zhusheng. Can you introduce yourself? Yeah, here. English.
Hello, I'm Dr. Zhang from Taichung, China Medical University Hospital. Nice to meet you.
Okay, now we are the last demo from which room now? Oh yeah. Okay, I got it. Okay, please move to case room 3. 他的曹电平。他的曹电平 ，Can you hear us？ 曹电平。Please turn on the voice. 曹医师，
可以听到吗？没有声音，没有声音。OK， 现在可以听到吗？ Thank you.
Introduce the faculty here, including the Toru from the Japan.
Hi, Toru. How are you?
How are you?
Welcome.
Review your main case.
Okay, and because Dr. Fu just present the case, I just present briefly. This patient is a triple vessel disease, and we did the angiography for him last week, and showing the LAD osteo disease and circumflex osteo also disease, and the LAD mid portion has instant restenosis. But the patient has another problem. The problem is severe aortic stenosis. So we consult a cardiosurgeon. But because the patient has a porcelain aorta, the aorta is very calcified. Therefore, surgical aortic valve replacement is contraindicated. It cannot be done. Also, even bypass surgery cannot be done. Therefore, we will perform PCI today. And so you can see this is the, can you see the screen? You can see the aorta is very calcified from the aortic root and also the coronary arteries. So this is porcelain aorta. And for the patient with severe aortic stenosis and coronary artery disease, normally we did PCI without doing the BAV. But for this case, I'm going to do the left main PCI. Therefore, we decided to do the BAV first to open up the aortic valve a little bit, and probably the procedure can be safer. So this is the BAV we did just now. but the balloon ruptured. But that's fine. That's fine because there's no air in the balloon. So, and then we advance the guiding caster. So this is the angiographic. You can see the LAD ostium and the circumflex ostium are diseased, quite narrowed. And the left vein is very short. There's an instant restenosis at the mid LAD. You can see from the screen. So we did the IVUS for the LAD. The IVUS showing the ISI is focal, and there's a disease at the LAD ostium, but there's the calcium is not so heavy. It's less than 180 degree. Can you show the IVUS image?
Yeah, the
LAD.
Dr. Liu, we present the finding of the IVUS.
Okay. As Dr. Chao said, that the instant restenosis around mid LAD was just focal, and maybe some underexpanded stent, and there's a gap between two stents, and the gap between two stents was normal, and in the proximal stent, you can see maybe there is some calcium there, and very focal, very short calcium around here. Yeah, around the short very calcium plaque here. Some fibrotic plaque here, and the osteo LAD and distal left vein bifurcation is just also very calcified, but there's no circumferential calcification. So I think angioplasty or cutting balloon angioplasty is enough. And the left vein is very big. The left vein was around 5.5, and the osteo LAD is around 3.7.
And the circumflex IVUS, we also done the circumflex IVUS.
The circumflex.
Okay.
This is circumflex. Yeah.
The circumflex, the IVUS from circumflex show that the relatively normal segment in the mid portion, and also there's very calcified, but without circumferential calcification around the osteocirc in this left main. So rotablation is not needed.
So from the images from the data and any comments from our experts?
Doctor, I'm Dr. Fang.
Hey, Dr. Fang, how are you?
This case because of the circumflex the ostium lesion. How about the length of the circumflex, the lesion length?
Oh, the lesion.
By IVUS, the circumflex of lesion length.
Okay.
So my opinion, if the lesion length is less than 10 millimeter, means just one stent from LAD cross over to the main, and that's one stent. So if the lesion length is more than 10 millimeter, we so-called complex, but occasionally maybe two stenting. So how about the length circumflex?
Around 6 millimeter.
6 millimeter borderline.
6 millimeter, yeah. 6 millimeter.
Six. But from the IVUS, we can see the ostium of the circumflex is very narrowed. It's very narrowed, and the circumflex is quite big. So I agree that Dr. Fang's opinion for the not so complex left vein bifurcation, provisional stenting may be enough. But for this particular case, the big circumflex, although the length is short, then I would consider to do the two-stent strategy.
Yeah, we can ask other panelists. The cool. Do you favor the two-stent or one stent for this case?
Because the lemon size is so big, so I consider V-stenting maybe simple and and useful. Yeah.
So departing first, then the freestanding. Okay. Again, we ask other foreigner faculty, Dr. Toru Nakamura, can you hear us?
Yeah.
Yeah. What's your opinion for these countries? Heavy calcified two standing involved the men. So what's the choice of one stand or two standing?
Basically one stand. We already published a paper from our METO registry data showing that if the heavy calcification is located at the circumflex ostium, we see high rate of stent restenosis, even if we implant a stent. So basically, we try to avoid two stenting in such a case. Maybe I perform a rotablator for circumflex ostium, then DCB dilatation, then implant a stent only on main branch.
Only standing from the lemon to the LED, right?
Yeah.
And how the also of the circ? You did the rotablator, how about any cutting balloon or drug cutting balloon?
So for circumflex rotation and DCB.
Right. Any different opinions of faculties?
I agree with you, with Dr. Toru. There is some experience about the severely calcified circumflex osteo disease. If we put two stents in this kind of situation, sometimes we have to deal with the instant restenosis of the circumflex restenosis. And sometimes it will progress to involve the lemon and LAD. So when we meet this kind of situation, it will be very troublesome.
Okay, here another new faculty, Dr. Liu. Can you introduce yourself and give the comment for this complex region?
Thank you. I'm Dr. Liu from Tri-Service General Hospital. In this specific case, in my point of view, that circumflex is very tight lesion. But the calcification maybe is not very quite heavy. So that maybe the debulking by rotablatation maybe cannot for adequate debulking the calcified and the other side of carina. So it's tough in this case to decide whether a two stent or one stent strategy is best. It depends on I think a case by case. But in this case, maybe I would use a T-stenting or mini protrusion or tap stenting because the angle is a little bit larger. That's my opinion. I think I will do the two stents strategy.
Okay, we give the different opinion. One stent or two stent with different strategies. Okay, maybe we leave here and we'll be back very soon. Okay.
So maybe we put a one stent from left main to LD and then do the FFR.
Okay. Okay, we leave here and we move to the room 5.王志宏。
来个那个 B 好了，
哎，
长一点的3.0。
这给你主持。哎 ，OK， 好朋友。
Wei-Hsian, how are you？
哎，王副，我顾朋友。
好，我聽清楚啊，聽清楚。啊，我先把 case 報告一下咯。
好 ，OK，
好
，please，
來。
Speak English, please.
Okay. No problem.
Because we have foreign faculty.
Yeah.
Okay, Chief and panelists, dear colleague, I'm Wei-Hsian Lai from Cheng-Cheng Hospital. This case is a 56-year-old male with chief complaint of intermittent chest tightness for 1 week. His past history is coronary cerebral disease, post PCI at LAD, RCA, and circumflex, and also dyslipidemia. The echo showed preserved LV systolic function. Science scan showed apical myocardial ischemia.
有挖过啊，这边好啊。嘿，过了，我已经过了。嘿
Next one. And the angiography, we can see the LD proximal stent is pattern and circumflex middle to distal have a lesion. This is the angiography 2 months ago. The next one. And later we perform the PCI for the second phase first. This is the angiography or the PCI for second phase, middle to distal. And the RCA is, this is the PCI after angiography after PCI last time. And as you can see, we perform the stenting at the proximal to middle segment at RCA, but at distal region, please play the film at the slide. Okay. Please show me a slide. 可以看投影片，右边的 view 可以 play 一下吗？
The last time procedure to right coronary should be shown to the whole faculty.
And next one. Okay, previous slide. And as you can see, the right hand view, and we can see after we perform the PCI at proximal to middle, and we try to attempt to perform the PCI at RCA distal, but the device and the microcatheter cannot cross the distal region. So we stopped the procedure last time.
Yeah.
Okay.
Last time, yeah, it's last time. That's the operator is stopped due to Taipei can't pass through the ostia PL region. Yeah. So today's car plan is CTO in ostia PL region. Yeah.
Okay. So,
we can show you the first angio today we perform.
Because we know rotor operation should be done after wiring by traditional workhorse wire, and then microcatheter pass through, and then change to rotor wire. For this case, maybe it is impossible to under this strategy. So what would you do before this procedure? Pair rotor wiring or another strategy?
Yeah, by my experience, this case should be approached with bare hand. Rotor wire bare hand pass through, because the region is heavy calcified, and the Taipei is can't possible in previous study and in previous operator, and in previous I see the guideline microcatheter already reached to the ostia PL. That means a good backup. Even under good backup, the Taipei still can't pass through. So I directly planning to done rotational atherectomy. So I use one Sion brake under APT microcatheter 130 APT microcatheter. Luckily, the Sion brake is very easily to pass through the CTO stump and go to the distal PL branches. Then I rotate 5 cycles to fix the microcatheter. And under fluoroscopy, I see the microcatheter tip is fixed. Then I remove the Sion brake and exchange it to rotor floppy wire. Rotor floppy. Very smoothly.
昨天他没有丢上去，就暂时。有吗？有吗？今天的没有丢上去。是哦，那我们荧幕上不对啊。我们荧幕上是这个，那可以 ，OK， 可以。
OK.
So this is rotor wire.
This is Sion brake. I remove the Sion brake. Should be removed. Then it's changed to low-power floppy. Low-power floppy CY.
Dr. Wang, what kind of guiding catheter do you use?
Oh, Kimi. Because first I tried short tip and plus 1.0, but can't wedge. Because he's a superior uptake in Austin. So very typically to wedge. So I changed it to Kimi.
But it seems the support is not so good. Maybe rotation is good. Not easily to do not perform.
Because Kimi catheter Kimi catheter is very easy and very safety to deep seeding. So in usually I very likely I very favorable to use Kimi. When I need, I can make a very deep seeding, just a very short time. Then I perform need the good supporter timing. Just a very short. When I pass through, then I pull back. It's very safety. Now I change it to the rotor floppy wire, rotor C. Then we remove the micro catheter. And the insert 1.25 per rotor per. Then we start with
What's that? 1.25. Okay, this is small size.
Small size.
First, your guidance 7.
6.
6. Okay.
Because this quantity is not so big, but the territory is big, but the diameter is not so big.
So far, so good.
We used 160. Start with 160, but can't pass through. Hi.
I'm Dr. Liu from Tri-Service General Hospital. I think this very smart technique to advance the microcatheter as far as possible. And therefore, we can see in the middle proximal PL, we can see the heavy calcified lesion there. Maybe that's the tough lesion the tympical cannot cross. You heated the microcatheter to that point and used your sophisticated technique to cross the bale wire to rotor wire to distal PL. I think that's very good teaching for all of us. But I think that the circ is dominant in this patient, right? Because that the RC is not very big.
I agree.
The thallium to this case is the apical part of the LV. So I think maybe the lesion is important to the patient, but ischemia territory is not compatible with the RCA lesion. However, in this demonstration, I think the techniques, your technique is very good, very excellent. We learn a lot from you.
Thank you. Thank you.
So I'm Dr. Ren from Cheng-Cheng General Hospital. Yes, I know the first stand over the RCA proximal to middle is the new stand just developed last month. So how about to pass the first new stand? Because sometimes we are be afraid have some entrapment or some complication if the stand only deployed within the recent 1 month. So how about Professor Wang, you recommend to prevent the complication? The second one is, do you prefer use a guideliner to deep stitching to prevent the complication when we use the rotor to pass the first stand? Do you have any recommend?
Okay, thank you. By my experience, the new deployed stand, when we done rotation atherectomy to distal, stand distal, maybe some dangers. So we should good physician to the previous stand. So according the previous angiography, I think last operator is already good fix to the ASEAN middle region. So even I think it's good physician. I should be very careful, and I just the more safety is use the dinosaur director is very slowly go through. It's very safety. In my experience, when we wanted to try to put one microcatheter to pass the stent first, then we were very safety to pass through by this channel. But usually you when you wanted to very comfort and easily to use rotational atherectomy in microcatheter should be used the 7 French microcatheter. The 6 French microcatheter can be used, but very difficult to done the procedure. So in really experience and really situation, when I want to get a good support with microcatheter to distal debugging with rotational atherectomy, I just 2 experience. I tried 7 French guideliner. Then we done rotational atherectomy. In this case, I think the region, the critical area should be just in the proximal ostial PL only, not so diffuse heavy calcified. So I think it's not so difficult to done the rotational atherectomy. So I no planning to use the microcatheter for get a good backup.
Faculty, Dr. Toru, how about your opinion with the new stent? You deliver a data through the new stent. You will wait how long?
Even just put I can done the procedure. Yeah. You should be a good fix the first stent. Likely to use an oversizing balloon and oversizing small length balloon. I use bigger pressure to fix, especially the proximal. Should be good fix.
Yeah. How about this case with the long new stent? Why didn't you use the guideliner before your not operation?
I have just 2 cases experience. In those 2 cases, is not perform the rotational atherectomy procedure due to poor guiding backup. The one is in very big PL branch. The another is circumflex. I just 2 experience. So when I consider to use the microcatheter, just I consider the procedure can't perform is due to back up due to guiding catheter.
Toru, you online?
Yeah, can I ask one question?
Yeah. How about your judging for this special situation?
I want to ask that in our center, for such a case, it's mandatory to place temporary pacing. But what kind of case do you place temporary pacing in advance before rotablation?
Okay. In daily practice, at now, I rarely use a temporal pacemaker. Yeah, because I think I can procedure time. I rarely longer than 10 seconds. Yeah, so never get to severe bradycardia. If need in clinically, I can use just very short 3 to 5 second debugging. and debugging more times.
Okay, okay.
Yeah.
I see.
Yeah. So I never on schedule put a temporal pacemaker in every coronary. Yeah.
Dr. Wang, Dr. Wang, because you are expert for collaboration, because in this case, initially I asked you, because in this case, you need a deep seating, but deep seating may be bradycardia. So in this case, maybe I prevention pacemaker is okay. Because
I agree.
The case,
I agree.
You make a side hole for your guiding catheter?
No.
Because sometimes you get deep seating for this tight distal calcified region.
Yeah, so it should be very short time deep seating only. I can show you the following image. Okay, the following. So I start the debug. The dota is very difficult to pass through proximal stent. Yeah, so I make debugging in proximal pipe first.
Okay.
Yeah. Then we start. Difficulty to pass through. Then I upgrade the speed to 118. Upgrade the speed. So I deep seated. You can see in this image. You can see my guiding catheter is deep seating. Then very easily. Yeah.
What you speed? High speed?
High speed.
Okay.
18.
Yeah, good news. Okay.
Yeah. And I just debug maybe 4 seconds to 5 seconds. Then we stop and pull back the guiding catheter. Because at now, no blood pressure is flattened. Yeah. We just do 4 to 5 debug only. Maybe 4 to 5 seconds. Yeah.
It was. So what's the next? Your escalator, the size, or IVUS first?
I maybe make a more debugging to the distal.
The simple, right?
Yeah, simple. Then we see IVUS. If under IVUS image is good debugging to the classification, then I done the usual procedure with balloon post dilatation, then stenting, according by IVUS finding.
Dr. Wang.
Hi.
How you deep seated the guiding catheter just by pushing or during pull back the rota?
No, I just very careful rotation. My rotation and my push.
Okay.
Yeah.
So you push guiding catheter together with pushing the rota.
Yeah.
Okay.
Yeah.
That's a good point.
Yeah.
Very careful and slowly, and rotate very fast.
Okay.
We'll move to the room 3. I will be back very soon.
Okay. I continue my procedure. Thank you.
Okay. Congratulations.
Okay. Thank you.
Back to room 3.
好，我们再继续摸吧。
Yeah, we are back to see you again.
Yes.
Yeah.
And this is the image that I left you. So this is a 3.0 by 12 NC balloon. I just dilate the ISR, and then this dilate the proximal ISR. This is dilate the LAD ostium. So O by 3.0. And so this is DCB, but I use agent 3 by 15. This I use 2 agent DB. This is DB. Sorry, because this is instant restenosis. This 3 by 20 DB. So this is the image after DB. Then I use a cutting balloon. I attempt to use a cutting balloon 3.5 by 10. This old cutting balloon, but cannot be inserted into the circumflex.
Yes, acute angle.
Yes. So I use Wolverine. The Boston Scientific new cutting balloon, Wolverine, 3.5 by 10 by 6 by 6. So the cutting balloon can be pushed into the lesion. So this is angiographic, right? 3.5 by 6, and then direct. I performed 3 cuts. The first one, 6 atmosphere. The second one, the third one was 8 atmosphere. So there were 3 cuts. So the image after the cutting balloon, you can see the lumen is bigger. It's bigger. So I also use the same cutting balloon for the LAD. Also, the same cutting, yeah. So this
We'll
is
see the IVUS to see result on the cutting balloon.
Yes, I haven't done it yet. I will do it now. So this is the cutting balloon for the LAD. So later I will check the IVUS. Also 3 cuts. 8 atmosphere. So angiographic after the cutting balloon. So this is the angiographic I performed so far.
Yeah, it's fine. It says mild sensation, but okay.
Yes.
Well, what's the next plan? Would you do the provisional stenting, then DEB or DEB first to the circ Austin, and then one stent technique?
But I think I will still use 2 stent as you suggested earlier. Yeah, I'll do the DK crush.
DK crush. Oh yeah.
Yes.
It's a good result from the papers.
Yes. So I will check the IVUS for the circumflex.
What's your rota to the circ Austin? What's your opinion by the suggestion from Toru?
Yeah. You're asking Toru or you ask me?
I asked you, yes. Toru also asked you, I think.
Dr. Chao, Dr. Fang, because this case the name is very short. How do you do part? Because you do DK class, you must do part. Because the name is very short. So my opinion is because you have to cutting balloon, maybe DB Gen 1 state is okay. Because you do DK class, you must do part. Part you must touch the Austin or LAT. So how do you choose? Because the name is very short. So how do you do the part? Yeah.
Yes, I would stand the whole left man, and then use the balloon protrude into the altar. So there's no problem to do the pot.
8 millimeter with a half of the balloon hang in the aorta.
Yes.
Here the also can tolerate a high pressure and high balloon size.
So can you see the IVUS? IVUS for the LAD?
Yeah. That's all. Yes. And Dr. Ren, because I know you are the expert for the DK crush, so can you tell us why do you prefer the DK crush for this case? Why don't you choose clock or other two-stand strategy?
The first one, because the DK crush is my first favorite technique, because you can see the result from the Dr. Chen Xiaolang. The result is quite good. And the secondly, I have not so many experience of culotte in the left man. Culotte in the other publication, maybe I have some experience, but the culotte for the left man, I don't have as much as experience like Dr. Li Wen-Lieng. So I'm not using the culotte procedure, culotte technique for left man.
What else about tap or mini crush for this short main case?
Tap is very good and also very simple procedure, but you can see the circumflex, the distal circumflex still has disease. I think the future intervention is probably needed. So if for the TAP, it's quite difficult to wire the opening of the circumflex stent. Therefore, I don't use it for this case. Sometimes if I would do the circumflex next time, the wire may go through the stent slot in the very part of a circ stent. So that would be injury to the stent. So this is the IVUS for the circ after cutting balloon. Okay.
Dr. Toronto, are you online? Are you still online?
Yeah, of course.
I know in Japan, DCA is very available and popular. So in this case, do you in Japan practice, do you do DCA for second frame first and just one standing? Yeah. Another option.
As you said already, in this case, we see very short left main. So as you said, it's very difficult to perform a pot technique as well as a kissing balloon inflation. So basically, in our center, we try to finish this case with a single stenting. So as I said already, I would do a rotablation for circumflex ostium, then try to avoid stenting on circumflex ostium. Maybe treat with DCB. It's my opinion.
Dr. Toro, but DCB has been used since 20 years ago, but it's less popular then because probably due to the complications. But from the presentation of Dr. Nakamura, the result is very good. So what did you change any technique of a DCB? Any technique different from before?
Basically it's the same.
Can you tell us how many the DCB is available in Japan? Because Taiwan have four companies produce. What kind company the DCB
we can use only
This is 3.5 Thursday.
Okay.
This is second fresh.
Second, please.
3.5 NC.
Okay, that's all. So far, so good. You will do the DK class, and we'll be leave you or minutes to the lecture, and then we'll be back.
Thank you.
Okay. Dr. Toro Nakamura, we are waiting for your interest in the talk.
Okay.
It's going to be here after IVUS implantation. Welcome.
Okay. Can you see my PowerPoint?
You can see. You can start now, please.
Okay. So I have a 15-minute lecture about PCI after evolute implantation. Okay. So coronary artery disease is very common in Taipei patients, as you know. And today's topics, I have 3 topics to give today. about the evolute structure, relationship between evolute and coronary ostia, how we should implant evolute to correspond 3 cusps. So it's different from Sapien balloon expandable valve. Evolute self-expanding valve completely covers a coronary ostia. So when we discuss about this, I usually remember this discussion about bifurcation PCI. We have discussed how stent struts covers a side branch ostium. To me, it's the same with TAVI. So main branch and side branch are similar to Valsalva aorta and left main. We have to remember that the size of the 4 evolute valves. So basically, we have to remember 2 values, 26 millimeter and 13 millimeter. Evolute valve has an outer skirt like this, inner skirt and outer skirt like this. So if the skirt is in front of the coronary ostia, it's very unlucky. Also, we have to remember a C paddle. So C paddle means commissure of the evolute valve. You can find it on fluoroscopy as a C. If it's in front of a coronary ostia, it's very unlucky because evolute commissure is in front of a coronary ostia. Also, you have to remember that 23 millimeter evolute is different from other size of evolute valves. 23 millimeter evolute has 96 cells. However, other sizes valve has more than 100 cells. It's different. In Asian ladies, small ladies, we often implant 23 millimeter evolute. So it's a different situation from European and American TAVI. We have to know what size of the cell. It's different for each cell. If we see top cells, it's very large, like this. Usually, 6 cells from the top is in front of a left main ostium. So please see here. Usually, the width is 6.5 millimeter in front of left main, and the height of the cell is usually 7 or 6 millimeter. Let me show you our case. We treated 3 years ago. You can see a focal circumflex lesion like this, very simple lesion. Before TAVI, it takes 15 minutes to treat. In this case, the patient had a high bleeding risk, so we implanted the evolutor first and check if the patient is tolerant with DAPT, and then PCI we performed. However, it was very difficult to perform circumflex PCI. We tried from a left radial approach, 6 French. Standard SL catheter was not suitable. I tried JR for left main, but it was not good. Finally, I chose IM catheter. It's very uncommon for standard PCI. Then we could advance field barrier somehow. Then we use the guidogyra catheter like this with the anchor balloon technique, perform the IVUS and predilatation and stented like this. At the time, we didn't know how difficult PCI after evolute implantation, but we really realize the importance to check what kind of strategy we should do. In the same case, we just in case perform the right coronary angiography. It was also very difficult, even impossible to engage. So on the right panel, you can see a near shot, cusp shot. This is a CT scan before discharge in this case. As you can see, in front of a right coronary artery, you can find evolute commissure, which is a blue color. In front of left main, you can see a stent strut like this. So in this case, as a conclusion, both coronary ostia are very close to stent strut and evolute commissure. We checked the CT scan after evolute implantation with the CT scan before discharge. This is a paper from Tang et al. Published in ACC. They checked the overlap between evolute commissure and the coronary ostia. If it's very close, they say severe overlap. If it's far, they say mild overlap. So of course, it's lucky to see mild overlap, unlucky to see severe overlap. This is our case. On the left panel, you can see right coronary here. Then the C paddle is here. Commissure is here, which means the angle between commissure and the right coronary artery is 59 degrees. On the right panel, you can see angle between commissure and left main here, 15 degree. So in conclusion, in this case, very lucky case, mild overlap case. From our data, we find mild overlap case of both ostia in 26% cases, while severe overlap of both ostia, unlucky case, in 12% of TAVI cases. The question is, can we prevent severe overlap of evolute commissure and coronary ostia by arranging a HAT marker during the TAVI procedure? Basically, we try to get the outer curve like this to implant evolute implantation. In this paper, they say, if we see HAT marker outer curve or center front, it's better to get 3 cusp corresponding. This is our case. If HAT marker is outer curve like this, inside the red circle, we see C paddle like this. Then CT scan shows a mild overlap, which means a good orientation. This is another case. If we see HAT marker inner curve like this, we find the C paddle here. This is the CT scan before discharge. We find very bad orientation, severe overlap between commissure and right and left coronary ostia. Very bad case. To resolve this, basically, TAVI operators are recommended to advance the system. The flush port here is toward the roof, 0 o'clock. However, they say if we place the TAVI system at 6 o'clock like this, which means opposite side of the operator, we can get outer curve or center front in 90% of cases. In terms of guiding catheter to perform PCI after evolute implantation, in Japan, we recommend Jadkin's left or Ikari left for left coronary PCI, Jadkin's right for right coronary artery. Personally, I recommend IM catheter for both. We do not recommend backup type EBU or Amprats because very difficult to manipulate guiding catheter inside the evolute. And better to choose smaller curve, very small space to manipulate the guiding catheter. If it's impossible to engage a guiding catheter like this, better to choose use child catheter at earlier stage. Give up to engage a parent guiding catheter and use child catheter like this. Then advance a stent or IVUS or a balloon. Thanks. This is my lecture.
The next study with neocommercial overlapping with coronary artery os and use the new technique to prevent the overlapping. In your study, you use lucky case, you can do the PCI after TAVI. How about the unlucky case? Do you any experience?
Very difficult actually. So current studies, current publications say very high rate of coronary angiography and PCI even after TAVI. It's true, but it's not true. In some cases, it's very difficult. In our hospital, if we do PCI in patient with evolute valve, we do not allow younger doctors to do it. It takes time, more fluoroscopy time, more contrast. So we have to be careful.
Yeah, the Huang.
The size of child guiding catheter, the size 5 French or 6 French, the child guiding catheter.
We use a 6 French.
6 French child guiding catheter. Okay, thank you.
As we know, the coronal occlusion after the TAVI is a nightmare. So how do you prevent a complication? Do you use guide wire protection for the coronary artery during the high risk of the TAVI procedure to prevent the coronal occlusion after the TAVI? Because we have several delayed occlusion of the coronary artery after the TAVI, especially for the self-expansible TAVI stent. So how about you recommend?
Do you mean during coronary protection during TAVI?
Protection the coronary artery during the TAVI for some tough case, the high risk for the coronal occlusion during the TAVI procedure.
Oh, I see. If we find a small valsalva, for example, less than 15 millimeter valsalva height, less than 25 millimeter valsalva width, and then we find a very severe aortic leaflet calcification. It's very high risk to get a coronary obstruction. For such cases, we place guiding catheter and Linaat wire with a 3.0 millimeter balloon. Just in case, we place it on the LAD before TAVI valve implantation. Then usually we try to implant the valve at higher position to avoid the pacemaker implantation. However, if we consider coronary risk, coronary obstruction risk, we should not try to implant at the higher position. We have to accept to implant a deeper position for such cases, for such special cases.
high risk coronary disease, your implant TAVI is that lower level, right? Deeper.
Yeah.
What do you suggest you choose another TAVI, not the evolved R? You choose another kinds of TAVI. This type of the TAVI, that's easy to get the neo-commercial overlapping.
Yeah. In Japan now, we can use only Sapien bulb and evolved bulb. As you know, Boston Lotus bulb is gone from the market. So only 2 bulbs are available. So after Sapien implantation, if the commissure is close to the coronary ostia, it's usually very easy to engage the guiding catheter. Even if commissure is very close to the ostia.
Yeah, in time we have many four types of the TAVI, so we have many choice. Thank you. Your nice presentation. We learned a lot from your experience. Thank you.
Thank you very much.
Now let's move to room 2. Dr. Chai.
Hey. Hey, good afternoon, everybody.
Dr. Chai, I'm Dr. Huang.
Hi, Dr. Huang.
Good afternoon. Here we have several commentators here, include Dr. Cheng-Cheng, Dr. Ren Xulong, Dr. Zhang Shisheng, and Dr. Guoming, and Dr. Liu Junping. Okay, can you introduce your case?
Okay, please.
Okay, so
please.
Next page. Good afternoon, everyone. This is a 51-year-old male, and he had hypertension and dyslipidemia. He had chest tightness for weeks. He came to our outpatient department for exam. The stress tester, the treadmill tester was positive, so he was admitted for CAG. Next, please. Here's a coronary angiography over the left side. You can see there's a critical stenosis at the proximal part of ON. And the LAD proximal was CTO. Next, please. And there's no stenosis at the right coronary artery. And the coronary artery, the RCA gives collateral to LAD. From PDA to septal branch and the conus branch.
Okay. Let's see the today's angiogram. Okay, this bilateral simultaneous angiogram. You can see from the IO cranial view, the collateral from the RCA with two good collateral. One is septal to the middle traffication, D2 and septal, and the one to the LD distal. And the LD CTO is not so long. I think below 2 centimeters.
Okay, Doctor, before
okay,
you...
The next angel. Okay, this AP cranial is very clear. Okay.
Before you perform your procedure, I ask our commentator any comment. Dr. Liu.
Okay.
Dr. Tsai, I'm Dr. Liu from Tri-Service General Hospital. In this case, is the LD CTO at the proximal part. Can we see the initial diagnostic test, not dual injection, previous procedure?
Okay.
Because I can see the LCA in the beginning, before this dual injection, we can see some contrast flow to the middle LAD, just like island.
Yes.
So I think maybe this is the functional channel or intracoronary position collateral. how think in the diagnostic catheter instead of this dual injection?
Yes, from the previous angel, it looks like bridge corridor. Yeah. Can we show the previous angel to the screen? 可以帮我们秀一下上一次的 angel 到大荧幕上吗？上一次的 angel 可以到大荧幕。那个 AP cranial 那个角度。
秀上次的 AP cranial 有接我们那一台吗？没有。
Yes, from the previous angiogram, we can see some island, maybe bridge corridor, but come from septal branch or other side branch we cannot well define.
Maybe bridge corridor.
Yeah, maybe bridge corridor. Looks like small septal to the septal to septal.
Yeah, epicranial. So in this case, you use anti-glare approach in the IVUS guy, or
yes.
Point.
Initially, my plan is real-time IVUS guy. I prepared a bilateral transradial approach, but his left side subcranial artery is very tortuous, so I moved to the right femoral artery approach. Right femoral artery, 7 French guiding catheter, the new Hyperion from the Asahi SBT 3.75, which is like an extra backup 3.75. Right side, we use the Ikari left. We perform the bilateral angiogram first, and I want to, if the corridor is not so good, I will usually move the IL catheter to the left side, and with ping pong guy, and the IVUS from the Ikari to the side branch. Ikari left is real time IVUS guy to puncture the proximal cap. I usually do that. Bilateral transradial.
The good news for this case because the occult segment from the corridor, many from the RCA, is not so long. Bad news is no, has been tried serial PCR failure in another by other experts. So yeah, this is my case, and I will try again the integrating with IVUS guide any kind.
Any comment?
Dr. Tsai, I'm Dr. Gu.
Hi, Dr. Gu.
For this case, because previous failure case, I think some intramural hematoma or some dissection occur. So in my experience, IVUS guide is not so important for this case because the angle between diagonal branch and LAD is too big to see by IVUS to orient your puncture angle. So for me, I will choose a controllable wire such as Gaia second for puncture first, and then because the occluded segment is very short, so the first wire may follow the previous dissection, and then I will do a parallel wire with a harder puncture wire. Yes.
What microcatheter would you suggest in this case? What microcatheter? Crusade from the beginning or only?
I will use a double lumen microcatheter, one wire into a diagonal branch and side hole for puncture wire.
This is. I prepare also this kind of technique. But this patient is not a previous trial fail. It's fresh case. It's first time attempt.
Doctor, because we have foreign commentator. Dr. Tolo, do any comment? Or any other option?
Hi, good afternoon, Dr. Toro.
Yeah, this is Dr. speaking. Thank you very much. Yeah, as you said already, this is a very short CTO case. So I would go from a femoral approach, 7 French. In our center, EBU catheter, maybe with Corsair. My first guide wire, maybe I may use Fielder XT first, then switch to Gaia series. Then radial approach, contralateral contrast injection.
Okay, thank you. Any other comment? Okay. Dr. Tsai, do you do your procedure?
Okay, so let me see again today's bilateral angiogram.
And what is strategy? Is the IVUS guide? What's the first wire for this case?
Yeah, initially I want to perform the IVUS guide, but after bilateral angiogram, maybe a little stump. We can see a little stump, and even maybe small channel between the distal cap and the proximal cap.
So you choose STR?
Yes, I just use the STA.
STA, yeah.
Because some calcium, yes. And I'm very lucky. The STA close. Okay, next. Yeah, it's now
too fast.
Yeah, I'm very lucky.
So this is a lucky case.
Yes. So we perform
maybe you dilate the IVUS and then the final, and we'll back later to see the final result.
Okay, thank you.
Quite successful short time CTO PCI. Okay, now we'll move to room 3.
Okay.
Yeah, to see Dr. Chang.
Hey, different.
You're on here now, and we'll see your successful DK.
So let me finish the kissing, and then I'll explain the procedure to you. Okay?
Okay.
来 ，in front 2个一起。
Just a second first.
先停一下，我先 in front 一次好了哈。好 ，LED 嘛哈，还没有。
是。
哎，错了。对，主要是 LED 等下。啊
，in front 多少
？LED 来。
nominal。
10、12、14、16。是3.0嘛哈，18、20。Break。来，一起来哈。好的。先站在，好，一起。12。好。Break。12。照身看看的。来，出去。This is second kissing.
有点被咬住。
这个3.5 by 12 NC balloon in the circ and 3.0 in the LAD. That meant to LAD. Then I do the angiogram. 太淡，再次来。
So the circ stent is bigger. The size of the circ stent is bigger than LAD.
Yes. Right? These 2 stents are all 3.5.
Okay.
So I'll check the
final port.
Yeah, I'll do the final port.
I think the LD ostium is not fully dilated, right?
Yeah, I'll do the post dilatation later. Yeah. So this is the stent, 3.5 by 12 in the this is the stent, 3.5 by 12 in the element to circ and 3.0 NC balloon in the element to LAD. then after position of the stand, then I deploy the stand. This 3.5, and then I remove the wire and balloon in the circ, and then balloon, high pressure balloon to the left main to LED.
3.5.
It's and only 3.0.
What's the pressure? Is the burst pressure?
20.
Okay, 20.
20, yeah, 20.
A higher pressure. Maybe you can check the IVUS to see now we'll expand the stand or something special.
Yes, but then I rewire the circumflex, and I aim for the proximal.
In this situation,
yeah,
Doctor. In
yes,
this situation, because I know you want to do ticket crash, how do you know the wire from proximal cell? Because the main very short.
Very good question. Yeah, you can. If you want to make sure you can see the IVUS or OCT, you can check with IVUS or OCT. But we can just presume from the angiographic pictures and enter the wire from the strut as proximal as possible. Yeah. But if you want to do precisely proximal strut crossing, you need to check with IVUS or OCT.
Yeah.
So this is the first we use. This is 3.0 balloon into the circ, and this is LED. Sorry. So this is the first kissing. This I like to use a balloon, the LED balloon in the proximal LED, and inflate as anchor balloon, and then the bigger balloon can enter from the left main to the circ. That is easier. And this is the first kissing, and then this LED, the 3.5 by 20 synergy stand. Both stands are synergy. And after checking the position of the stand, we also need to very careful, because the synergy stand, the stand edge is below the marker, not as science stand. Science stand, the stand edge is on the marker. So we need to check the stand position very carefully. And then I deployed the stand and also remove the wire. So this is 3035. So then I use crusade to rewire the circ by using the crusade.
We usually use the crusade, it's more safe.
Yes, because the stand is a little bit protrude into the outer. So if you don't use the crusade, it would be some chance the wire enter from the side strut.
Yeah, that was a nightmare.
Yes, so it's crusade to enter the stand, and then I use the trapper. This trapper balloon easier to withdraw out the crusade caster. So this is the angiographic.
Yeah, now it's better.
Yes. So by using the balloon anchor technique, I also 这边其实上有一个没有记录到。Actually, I record the balloon anchor to the LED, and then the 3.5 NC balloon can be easily pushed into the stand from left main to LED, to circ, like this, very easily. So this is a 3.5 by 12 NC balloon, up to 18 atmosphere. And then this 3.0. Probably I'll use 3.5 for the post-dilatation of LED and the kissing. So this is second kissing. Then I'll do the post-dilatation and then pot. And that would be maybe I'll check IVUS. Yeah. That would be our procedure today. Any comment from the experts?
For the circuit, usually use the higher pressure for post-dilatation because the os on the circuit easy to develop this stenosis.
Yes. So I use up to 18 or 20, I forgot. Yeah. Maybe higher, huh? So 3.5, 3.5. Because I'm the pressure is beyond the schedule, I would make it quicker. Probably after the pressure balloon, after the part, maybe a quick IVUS, then finish the procedure.
Okay.
How large of the balloon for the parts? Dr. Fang, can you suggest me?
I think 4 or 4.5. Right.
Yes. Maybe I use 4 point because I asked Studio. Different. I asked the yes.
Because today is the left demonstration, do you have any commenting for D class from AD to Wen-Lieng? What kind of stent do you prefer?
You mean the DK clash? DK clash.
DK clash, yeah. And the stent structure is the same? Or because I know that today is the left demonstration.
Yeah, that's a little bit different. I think a little bit different. Some stent can be dilated larger in the left man, and the stent will not be shortening. Some stent will be shortening a little bit, and if the stent is dilated larger, the structure on the angiograph is different from the normal one. Yeah, so it's a little bit different.
First option.
Maybe I tell you later in Friday. It's my only opinion. It's not the definite opinion. So I tell my opinion later.
16.
Very smart answer.
Yeah, thank you.
Tori, in Japan, do you have any comment? How do you choose the D class or Hwang LD to limit? How kind of stent do you prefer?
Yeah. To be honest, recently we don't care what kind of DS. for both single stenting or double stenting.
Better job.
That's right.
All DS are very nice.
Yeah, totally. Thank you.
That's how we can see this time the balloon in the LD ostium is fully dilated. However, we often see that the kissing there will be waste both in the circ and the LD ostium during kissing balloon, maybe due to large plaque burden. Do you recommend only one, not kissing, but just like the final kissing, then followed by one balloon in the LD? It is more important than do the pot instead of kissing.
Yes.
You know what I mean?
Yeah, I know. Because I just dilate LD ostium with 3.5 balloon, high pressure. So now I'm going to do the pot by using 4.25 because the stent can be only dilated up to the 4.25. So I'm not going to use 4.5. So 4.25 and then check the IVUS. 4.25 4.25的吗？ Okay, they give me 4.5, so I just do it. 4.25。Sorry, they gave me 4.40, so I changed to 4.25.
And short at.
Sorry?
How long? Very short, 8 millimeter?
Oh, 4.5. 4.5. Yeah, 4.0 is too small, so we don't have a
4.5.
Yeah, 4.5. Yeah, 4.5.
8 millimeter, right?
8 millimeter. Yes, yes.
Okay.
Okay, 好。So use 4.5 NC balloon.
Yeah, and this just at provocation.
So, what's when you do the kissing balloon, what kind of balloon you use? Use semi-compliant or NC balloon for the kissing?
NC. Yeah, NC balloon and a high pressure.
Both balloon are NC balloon?
NC balloon.
Yes, I also use NC balloon. Yeah.
Before kissing, I always alternate with a very high pressure, maybe over 20 ATM.
Okay. So test.
Tip at just at the provocation.
Yes. Yes.
Can you see Angel?
Yeah. Can you see it? Test. I think how about the position? This one. 来，照相来。
You can see the angel. Yeah. Okay.
I think the position is fine. Okay.
It's good. It's good.
Okay. Inflate.
It's 4.25 or
4.5.
4.5.
Yeah. 12, 16, 18. Okay, deflect.
We didn't see the angel.
Yeah. 哎，可以跳过去吗 ？Angel。Okay, this is after the part we shoot the angel graphic. I think it's fine. It's fine. Then I'll do the IVUS. Okay.
Okay.
Because I'm delayed too much, so maybe can you allow me to just do the LAD, and then to LAD, and then I will close the case, because the next operator is waiting for quite a time.
Believe you, we move to the room 5. Dr. Wang Zhuo.
Okay.
Okay.
等下我这样直接照就好。
这样好了，我们看那边哈，来
，IVUS proof
来。
大国王，
所以这个是30。Hi。
Yeah, we are back.
Okay.
Come.
Okay, wait. I remove my balloon.
Total with a 1.25 only.
Okay, yeah. We done 1.25 rotor debugging for 3 times. But just the debug, maybe Proxima 2/3. The distal 1/3 is not touched. Because my rotor catheter is difficult to approach. then we use 前面 then we then we use the 2.030 ballon for post dilatation. 来 ballon 第一次 ballon but the 2.030 ballon is difficulty to pass through to distal. Yeah, this one is a 2.030 ballon. Yeah, difficulty to pass through the distal. So I changed it to 1.512. Unfortunately, still can't pass through. I changed to the 1.512 only. This ballon still can't pass through. So I back to data debugging again. Then we set we yeah. Oh, so we set up the wire, and the wire I put it to very deep. In this situation, should be very careful, and my speed is upgrade to 20. Oh. Yeah, because 19 still can't possible. So upgrade to 20.
25, right? Burr.
Yeah, 1.25. The same burr. Then pass through with 20 in speed. Yeah.
So
then
cascade is longer and harder than we expect, right?
Yeah. Then we post dilatation with 2.030 ballon. 来，那个下一个我不会按。2.030 ballon. Then we post dilatation with 2.0 ballon. Okay, post dilatation. Yeah. Then we see IVUS. Can you see the IVUS?
Starting from very distal PL.
Yeah. And the vessel size is around 2.5. And now, 所以那个支架再来是33吧？33吧？或者上应该30，刚是30够了吧？够吧？我刚看起来那就32，那应该是要多少？刚刚看起来是多少？不是，上面是多少？上面是3.5。It's around right now. 我们看一下上面。Close. We can see the circular calcium with deep, very thickness. 我都看支架的话，哈，这边我在那里都不掉，我在哈拍摄哈，我在更 care. The basal segment beyond RV branch until PL branch, we can see region very severe calcified. 3.5应该是 severe circular calcium is located at B2 boom mark here. So the stand size maybe we can choose 2.5 and the length about 38.
Were you the lot of a bigger size or just standing?
Yeah. So we start standing. We put one 2.5 38 synergy.
So you put the stand along the rotor wire, rotor floppy wire.
No, it changes to walk cross wire.
Okay.
Run through floppy. Yeah. I afraid of the distal perforation, so I change it to Xiong. We change Xiong brake to Xiong. Xiong wire is more safety.
Dr. Wang, because from I was finding a circle classification, the size maybe 2.5, but the vessel size maybe larger.
Yeah.
To 2.5. How in this situation do you use cutting barren to cut the casing wing, or no?
Because
I know this casing because the position is too long. Yeah.
In clinical practice, in usually because the the full calcification, intimal calcification is in other is well debugging. Yeah, so I think the NC balloon should be good post dilatation. Yeah, so I think I use a more bigger NC balloon is okay.
Okay.
So
in the case you do the NC balloon and larger size.
Yeah,
no?
in the later.
Oh, okay, okay.
In the later. Oh. I just down to there. Yeah. Okay. Now we will put the second stent to distal RCA.
Then can fully dilated, maybe larger non-conventional balloon with larger.
Maybe I use the 2.75 or 3.0.
Yeah, maybe in the future you can use the shockwave.
Yeah. Oh, yeah. The second stent is very difficult to pass through. Yeah. Okay. 一定要安尼无法度。哦，你看这一定要安尼，过啊嘛吼，过啊嘛吼，有过啊嘛，简单嘛过啊嘛吼，好嘛是，有啦有念嘛，拢有念嘛吼，拢念嘛啦吼，再回来一点，我这样差不多，这样比较好哈，照一下。今天照一下，可以啦，我不用不死，等下回来再回来一点。这样子，看一下，来看一下，来看一下，可以的，这样很好了，这样可以的吧？可以，可以了，起来，起来，So, OK, different. Then we post the patient with a 3.0 balloon, NC balloon. 来，3.012 NC。哎，不要紧，做3.0，一个个打到底就好了哈，因为它是钙化了，还好了。So now we use the 3.0 balloon, NC balloon, to make a post dilatation.
How long?
12. 3.012. Because
okay, Dr. Wang.
Hi.
Today you very good demonstration how to manipulation the guiding cassette and rotation, very good experience. Because we just give you a memo to room 2. Is it okay?
Okay. Thank you.
That's room 5. Room 2. Okay. Dr. Tsai.
Hey.
We are back. Yeah. Good news.
Yeah, I nearly finished.
Yeah.
Okay.
You finished the case? Yes.
No. Nearly.
Okay.
We have put the first stand from the LED ostium.
We just leave you with a successful wire to close the CTO region. Can you check IVUS?
Yes. Okay. Pray back. After wire crossing 5.5 balloon pre-dilatation.
You can start from here again.
Yes. Okay. Please show the IVUS image.
After stent implantation.
Pre-stenting.
And some calcium is also noted. And around, then we are near the relative acceptable landing zone. It's like here, fibrous plaque only, and vessel is 2.5. And now we are approaching to diagonal 2. However, at this point, we can see the vessel is positively remodeling. The vessel size is around 3.5. And then now the vessels return to the relative normal size about 3.0. So here is the relative landing zone beyond diagonal 2. So now we are near the CTO body. And we can see some lipid, this is a lipid-rich plaque, and lipid is located in a very deep side and some risk for no-referral. However, the calcium is only superficial and looks like not so heavy. So
Xi, Dr. Fang, that is my question. Yes. Because this IVUS shows some attenuated echo, you say some maybe the risk of lung referral. So how do you, when you perform a stenting, do you any procedure to prevent a lung referral or just a stenting?
Okay, so we can measure the length of the attenuated plaque. If the length of attenuated plaque is longer, the length is longer than 5 millimeters. So maybe we should pay attention on this. However, in this case, the length of attenuated plaque is not so long, around here.
So the cut point by IVUS attenuated echo, the length. How about the length? 5 millimeters.
5. 10. According to previous studies, it is 10 millimeter. However, in this case, it's only 5.
1. Okay.
Yeah. So it's around 5. Yeah.
How about here near the diagonal 2 Austin, because we can see the angel, there's the big diagonal 2. Will be the secret 5 if we put a long stand. So can you demonstrate the Austin of the diagonal 2? Do we need a second one to protect the diagonal 2?
Diagonal 2 is around here. So of course, in this point, the diagonal 2 Austin is relatively acceptable. So however, the landing zone should be chosen beyond diagonal 2, like here, or cover this positive remodeling segment until here.
Based on some CT and FFM study, if the cyberage length over the 73 millimeter, the cyberage supply myocardium volume is well over 10% of LV. So we can estimate the cyberage length through correlation to FFR. If the cyberage length over 73 millimeter, that his supply territory will over 10% myocardium. So if the cyberage length over 73 millimeter and the proximal portion with significant plaque, we have to treat this cyberage. From the angel, the diagonal 2 is length maybe nearly around 70 millimeter, maybe below the 70 millimeter. And from the IVUS, the ostium plaque is not so severe, burden not so severe. So I think maybe we can just like
because this case has no function study. During procedure, how do you estimate the acorn branch maybe suppress more than 10%? Because in this case before procedure not do function study. So just by size.
No, length.
I know 30 millimeter. And how about the size?
Not to attend to the size diameter is not associated.
Not important.
Yeah. Length, because length is supply the territory. So the length more than with some study correlation FFR to the CT angel. The length, cyber length more than 73 millimeter, it's supply the territory with over 10% LV in myocardium. So length is the key point. Because diameter will change, it's changeable. If flow increase, the diameter will increase. If flow decrease, the diameter will decrease. So it's a dynamic. So length is fixed from the baby. So and the length is the key point. So I do this, the bifurcation lesion, the cyber to treat or not treat based on the cyber length. And the proximal 10 millimeter, proximal part 10 millimeter plaque burden.
Yeah, that we agreed that the diagonal is quite important, but also diagonal is acceptable, so no need for, not unnecessary for the gel wire to protect. Okay, then we can develop how many stents is the long leading for this case?
Yeah.
The metal jacket?
Based on the IVUS finding, we want to discuss what about the
it is 3
panel? Yeah. I put the implant the first stent from the LDO stem to cross the D2 traffication. Okay, next. Okay, to cover the CDO body and the LD proximal heavy plaque burden area. Okay, next. But after standing, you can see the behind D2 with a short segment, relative critical stenosis, and the plaque burden is heavy. From the angel, we can see the post-standing IVUS. See, please.
Okay. And
long steno region. Sometimes we will develop the stem from the distal, and some experts will start from the proximal. What's the difference? We ask Dr. Toru?
Yes.
Yeah. It's a long CTO region. You will develop stem from the proximal or just from the distal end?
Basically, we implant the stent from this distal one. Then to try to minimize the stent overlap. Basically, distal first and proximal second.
Okay. That's how you want to check IVUS or balloon dilatation or just develop another stent?
Yes. So, Dr. Dan, please show the first standing IVUS image.
Okay. So now we are in the LED distal, and we can see here is a disease-free segment, and the vessel size is around 2.0, as just as before. And now we can see here is start with the calcified region and some fibrous, some calcified. But the disease burden is not so heavy. So, and it is segmental lesion. So somewhere is disease-free, and then a short segment of some plaque burden, but the plaque burden is not so heavy. So now we are close to the distal edge of the stand.
Yeah.
Okay, so beyond the stand, it is disease-free. And now the stand looks like fully expanded and the wrong shape. So I think the stand area is over 4.5. So I think the effect of stenting is very good. And now we are in the CTO body, and the stand is also can be fully expanded. And here is the proximal part of the stand. So it looks also fully expanded. And in a very proximal edge, maybe a little position. That's all. Thank you.
Yeah, but time is over of this section. As you know, we thank for the expert and team and all the faculty. To now, so far so good. Every case is so successful. It's a lucky day. And thank you. And then we will invite the next faculty, Dr. Yin, Dr. Xie, Dr. Sunao, Dr. Xi, and Dr. Huang and Lin. And thank everybody, including our most important Dr. Toro in Japan. Thanks to your lecture and your quite good opinion and any point or the chips. Thank you.
所以我们刚刚是从
Hello?
Yeah, hi.
Hi, Aaron. Are you on the
Hey,
air?
how are you?
Hi, long time no see.
I know.
Aaron.
Hello, I'm
How have you
Dennis.
been?
Good. How is it your end?
Yeah, we are fine.
Congratulations. I heard everything is going really well so far for you.
Yeah, I saw. Are you in Hawaii or something?
No, man, I wish. I want to be there.
From your background, we thought you were in the Hawaii.
I would love it.
Yeah, so you look like a superstar. Yeah, movie star.
Yeah, we are wondering which
It's
movie
the
are you?
Hawaii background.
Okay.
How are you guys doing? Everything is going well? Are you guys pretty safe
Yeah,
there?
so far so good. So far so good.
I don't see masks. Okay, that's good.
Yes.
Yeah. You too, it seems. You are fine too.
Yeah, I'm alone here. I'm good. It's all good.
Okay. So let's get started. Okay, we move to the room 5, case 6. Dr. Wang Zhihong will show us the final result of his case. Dr. Wang, are you there? Room 5.
Yeah.
Yes, please. You are on the air.
This one is the second approach with 1.25 per. The speed is upgrade to 20, then pass through. Sorry.
Please show the screen.
Yeah.
Angel.
Show
the angel.
Can you see the angel?
No.
Yeah.
Yes.
After adequate debugging, I post dilatation with 2.0 30 baron. Yeah, good. Good baron expansion. Then we see IVUS. Yeah, already show impasse. Then we put one long stent, 2.5 38 synergy. Cross the ostia PL to distal RCA. Yeah, the stent is good opening. Then we put from the angiography, since distal RCA is a significant lesion, so we put the second stent, 3.0 32 synergy with overlapping to previous and to PL stent. Then post dilatation with 3.0 12 NC baron. This area, since not so good opening, so we shift one 308 millimeter baron, peanut baron. 哇，这不见了。哦，谢谢。But since still some residual stenosis, just in the critical calcified area, because the procedure time is very long, so I think leaving alone, maybe in the later, if the stenosis, we try the cutting baron or laser. Laser may be a good choice. The final shot. This one is a final shot.
Okay, it looks good. I think there may be a ring calcification or something there, but the anti-grade flow is really good. Chemistry and all the myocardial brush is satisfactory. I think we accept this excellent result.
Thank you.
Thank you so much for your effort.
Thank you.
A good job. Thank you.
Okay. Okay. Bye-bye.
Then let's move to lecture first.
Hi, Dr. Arun.
Yeah, hi.
Can you hear me? I'm Dennis.
Hi, Dennis.
So, hi, and so can you start?
Starting with the lecture?
Can you start now? So I introduce you first.
Sure, happy to start.
So yeah, so
let me share the screen, and we'll get going. Yeah.
Screen first. Yeah.
Yep.
So the next lecture will be delivered by our good friend, old friends, Dr. Arun Kayanastharan.
Wow. Okay.
Yeah. So Dr. Arun is the Chief Division of Cardiology, ProMed Hospital, Chennai, India. He came to Taiwan for I think several times, especially came to our hospital for several times and taught us how to do the ADR. So now he is expert and the master of the CTO PCI, especially on the ADR. And today he is going to give us a talk. The title is Avoiding Complication in CTO PCI. Arun, please start your lecture, please.
All right. First of all, it's truly an honor and a privilege to be part of the conference today. I really appreciate Dr. Dennis inviting me for this. More than anything, I mean, he's a dear friend, so I'm glad I had the opportunity. Anyway, I got 15 minutes, so I won't keep talking on and on. But anyway, long and short of it is, thanks for inviting me. So as we know, CTOs are kind of held to a different standard. The point I want to really mention is that myocytes don't really care if it's a CTO that's causing the patient to be ischemic or if it's a non-CTO that's causing patients to be ischemic. However, obviously, we need a whole different set of skill sets like before we become successful in CTO PCI. For starters, we know that volume program support and technical skill sets are needed beyond just wiring for you to be a successful CTO operator. And why does this matter? Because remember, if you are a highly successful CTO operator, you can help more patients. That's the bottom line. And you know, it's always a balancing act between, you know, improving your skill sets, pushing boundaries, yet doing it safely. And inevitably, when you do have a complication, if you have better skill sets, you're going to be better off bailing the patient out. So, I mean, this is from Galassi a couple of years ago, but regardless, you know, there are a lot of patients globally. And I mean, especially I think it's true in countries like India where people have profound symptoms and be told that they really have no options. So the key I want to mention is whatever is your yardstick, be sure that you're doing CTO PCI for the right reasons. And then there are lots of algorithms that are out there. Hybrid was the first one published in 2012. Then you have the AP-CTO algorithm, you got the Euro CTO algorithm, you got the Chinese algorithm, and now you got a Japanese algorithm, whatnot. Now, the message, or rather the first pearl that I really want to emphasize on is make sure you know your skill sets and you're well-trained. Do it for the right reasons for the patient and have a good plan before you embark on doing a CTO PCI. And if the answer is no for any of those things, the best way to avoid complications is don't take it on. Don't do CTO PCI if the answer is no to any of the prior questions. Now, we do know from large registry data that, and this is from Progress, that CTO PCI is not without complications. The MACE rate is about 3%. The biggest and the most frightening complication is perforations. And this is from OpenCTO. Again, if you look at the percentage of complications, anywhere from 3 to 5%, depending on if it's core lab adjudicated or not. And we know which demographics are the highest risk for complications. You know, the older patients, the more complex CTOs, the use of retrograde techniques. And like I said, perfs, the most common and the most fearsome. Now, when you look at who is at risk for CTO PCI, the risk is typically limited to 3 domains, like, you know, 3 variables control it. The substrate of the patient itself, we talked about that. The lesion characteristics, and then the operator characteristics. So it is important, you know before you embark on this procedure, okay, who's at risk? What am I going to do to mitigate risk? And again, use whatever score, progress has a complication score, open had some predictors of who is at higher risk, etc. The key is whatever measure you use, have an individualized risk assessment before you take the patient on. The other important thing is this is not something that's set in stone. Even as you are doing the case, it's important for you to assess in real time. How's the patient handling this? What am I going to do next? Is this putting the patient at a higher risk of complication? How is the knuckle behaving? If all else fails, am I going to star and get out? What is happening? So it's important for us to know the big picture, who's at higher risk based on the various factors that I told you, and also to assess real time about the risk of complication. So just to illustrate the point, again, the details of the case don't really matter, but this is a circ where all the usual options had not worked. So it is important for you to know, I'm done, know when to stop. And what was done in this particular case was subintimal plaque modification, or as we call failed with style. So essentially wire, knuckle, balloon, don't stand and walk away. Okay. 6 weeks later, this just turned out to be a functional occlusion that was wired and successfully revascularized. So to put these things in a nutshell, CTO-PCI is the highest risk coronary procedure that's elective, right? So having a lot of skill sets and being familiar with various techniques will help you mitigate risk, and also you will do what is right regardless of the anatomy. It's important that we continuously update the risk benefit as the case progresses. And the most important thing is know that it's okay to stop. You don't have to win at all costs. Harming a patient is certainly the worst thing that you could do to a patient. So know when to stop. And again, this is not a toolbox talk, but again, I think it is important that before we embark on CTO-PCI, you are familiar with a lot. Again, I'm not going through each one of these, but have a good toolbox. And remember, having the right tools are going to help you manage the case efficiently. Knowing how to use them is important. Consolidate your toolbox and stay prepared for complications when they do occur. So what I really want to emphasize on is know your hardware and know how to use them. All right. And inevitably, when a complication does occur, I think this is a slide from my friend Craig Thompson. And really, I think this was it's a good slide because it really kind of tells you, think about for 60 seconds, can this patient fly on autopilot? And if the answer is yes, you have the time and the luxury to kind of go through the differential, figure out if you can reverse something and then start acting. If the answer is no, then obviously you got to stabilize the patient and still go through the differential diagnosis. We have a lot of complications that can go wrong with CTO-PCI potentially. Now, again, we're not going to talk about things like radiation, collimation, etc., because I think hopefully most of us know some of these. But I'm going to just show you about how to possibly avoid perforations. So perforations can happen in one of three areas: the main vessel, the distal wire, or collateral. So that's the main vessel, CTO body itself, a wire perf, or a collateral perf. So how do you avoid it? So first thing, and this is, I can't emphasize enough, wire perfs are typically benign, but if you take a device, and this actually happens with crossbars, and you have exited the architecture of the vessel, you've created a much bigger complication for yourself. The other one is you got to be careful when you're dealing with osteal disease. If you do have a dissection, don't keep injecting. You don't have to see it. You need to recognize it and manage it. Do not keep injecting. Just because you have side holes is not a guarantee. And this is another important point that I want to emphasize. So many of us do think, oh yeah, that looks great. Looks like I can follow, but it's not. And you can see in another projection that you're completely outside the architecture of the vessel. So make sure, and again, these are basics, but for those that are getting started off, it's important that you check in orthogonal views. And this is a term that we often use called dancing. So when we do say something is dancing in sync, it means in all projections that they are together. When the vessel moves, both antegrade and retrograde, it is moving together. So like I said, wire exits can be forgiving. Device won't. And if you've already crossed a collateral, then the best thing with the wire perf is just to wire, balloon, because many times it just ends up tamponading the perf. That's why you get away with it. The other point, another pro that you can essentially use to avoid the vessel, exiting the vessel architecture is not taking stiff wires through long distances. All right. And I'll tell you, typically we have low threshold for knuckling. When you do have proximal cap issues, use imaging to identify the proximal cap. And when you have an ambiguous course, don't take a stiff wire, take a knuckle, because knuckles tend to stay in the architecture of the vessel. And the other thing about distal wire perfs is don't keep injecting. I mean, this is essentially, workhorse stuff, but we need to recognize this. Once you've crossed with a CTO wire, exchange for your regular or your workhorse wire. Don't nanto or blow out, especially with the CTO wires. Also, when you're starting off, know what will be the consequences if you end up perfing, right? With the collaterals, especially. Generally, vein grafts are safer than septals that are safer than epicardials. Also, it's important that we know how to manage your microcatheter, what collaterals that you can take, how far can you push it? Now here, that the microcatheter just involves the whole collateral, and this is a septal hematoma. So it's important for you to know how much can you push this collateral, what's going on, are you getting good feedback? It's also important, this is a slide from James Pratt, that you know how to use your microcatheter, especially the torqueable ones. Caravel and fine cross, yeah, you can torque them, but they're really not torqueable catheters, and it's more of a push maneuver. Again, epicardials, super careful, never surf an epicardial, don't balloon dilate an epicardial. Understand that when you are injecting through a collateral, I highly recommend using the medallion syringe, which does not break. These can be used, but medallion doesn't break. It's made of a much stiffer material. And again, as you said, if you've already damaged your collateral, don't keep injecting. That's the general rule, whether it's a guide dissection or a collateral dissection, don't keep injecting. You don't have to see it better because you will end up having a disastrous big perf. So even anti-grid wire escalation, something as benign as that, can be dangerous. Be really respectful of epicardial collaterals. Be gentle and manipulate with finesse when you're going through epicardials. They are typically always serious when you do end up perfing an epicardial. Control both ends of it and have a bailout plan. That's always important because when you do have problems, you need to know how to bail yourself out. So, and I think this is the one thing that I want to say is that when you do get consent, please get CTO-specific risk consent because it's important that patients know what they're signing up for. Always go into the plan. Now, the rest of the talk is going to be on, I think it's kind of case-based, and I just want you to take a look at a few things. This was a case that I did in India where the lima had failed and large ischemic territory in the anterior region. So it's a long lesion. So as you can see, the first thing is to kind of have a mental plan. Long lesion, unambiguous cap, collaterals were really iffy because I had to go through the vein graft and then an epicardial collateral through the last remaining vessel to tackle the LAD retrograde. So not my first choice. So my plan, as you can see, knuckle and then keep going, microcatheter knuckle and what to do ADR. And then again, I have a wire down there that's a Miracle 12. And I thought, okay, let's do ADR. And then I found out that they didn't have a Stingray balloon catheter. So I ended up parallel wiring this. This is kind of like a throwback in time, but it's important that we are comfortable and we have bailout strategies. So rather than take this epicardial, I decided I'm going to wire this antegrade. And that's what I ended up doing. And once I wired it, exchange for a workhorse wire, and here's the final result. The second case was actually a live case in Hong Kong 2019, where, again, this is a Circ CTO. Plan was to wire it. First is to identify the proximal cap. This is, again, just emphasizing some of the stuff that we talked about. We don't blindly poke. We identify the proximal cap. Initial wire was subintimal. I'm going to just let this play. So again, not a great landing zone. So, but I knew I could wire this. So the next thing was just to put the dual lumen catheter and ended up parallel wiring this. Now I'm in the vessel. The rest of it was pretty cookie cutter. So I ended up wiring the true lumen, exchange for a workhorse wire, and that's the final result. So you need to know imaging and you need to be a good wiring person if you're going to start on CTOs. None of the other stuff, techniques, tools are a substitute for good wire escalation. One word of advice for people that are starting off and they're dealing with an ambiguous cap, and for whatever reason, if you're not able to penetrate it, or it's an impenetrable cap, base or balloon-assisted subintimal entry is way safer than scratch and go. I'm not saying that there is no role for that, but you got to. This is if you're just starting off, base or balloon-assisted subintimal entry, way safer. Where you take a 1-to-1 NC balloon, create a dissection, wedge a microcatheter, and get a knuckle going into the vessel architecture. All right. So that's an important pearl that I want to leave you with. Then crossing the CTO segment itself, again, this is something that I think is increasingly being used in Asia Pacific, but still not as much. So this was a case, again, live case last year where I co-worked with another expert from another part of the world. This is a Cirque CTO. As you guys can tell, fairly long, distal vessels possibly okay, collaterals are iffy, proximal cap is ambiguous. So the plan was to do an antegrade wire escalation. So this was done successfully. You can see around 10 to 11 o'clock that we punctured exactly where we wanted to. However, with the dual lumen catheter and penetrative wire, we weren't making much progress with wiring. And again, the two experts had to be respectful and kind of work with the other person too here. But despite multiple efforts, we were not able to wire it, and there were no retrograde collaterals. So finally, the other operator consented to knuckle antegrade. So, and again, Dennis kind of knows this. I mean, I tend to knuckle fairly early on if I'm struggling, but it's all good. So the decision was made to knuckle, and then the knuckle was clearly in the architecture of the vessel. And then I got a Stingray balloon catheter. You see the two markers here being advanced. It was in the right position. You can see that. So the right side is the correct orientation. You want to see one line and two dots. And first stick and swap didn't work. So I just did a stick and drive with a Conquest Pro 12. So then this was done blind. Because with the Pilot 200, I knew which exit to take. And then, so I just did it ended up doing a stick and drive. That's the caravel going back. As you can see, I didn't boss it. I just went straight to a knuckle Stingray. And here again, dual lumen catheter, wired the other branch of the obtuse marginal, confirmed with imaging that I was true lumen. And I had both the branches. You can see that come here. That's true lumen here. Furthermore, it's subintimal and very proximal. It's true lumen. And so it's important that you know your imaging and you do the right thing, and that's the final result. Knuckles can be used, again, in the interest of time, I'm going to skip this particular slide because I think I'm running out of time. But again, when you're dealing with ambiguity, the key point is knuckles can be used antegrade or retrograde, doesn't really matter. So it's important. Again, this was a case from, I think, last year where it was a double CTO where I had to end up knuckling because, the PDA was a flush occlusion. And there was also an occlusion in the RCA itself. And as you can see here, knuckles just going retrograde, and then the rest of it was just guide extension reverse card. So I'm just going to kind of just get to the end of this particular case, hopefully. All right, let's go. All right. Whoa. All right. That kind of overshot, guys. Sorry about that. So I think, anyways, the key is knuckles can go retrograde or antegrade, and it's important that we understand how to use these. Hold on just one second, guys. My PowerPoint is acting up. I'm super sorry. That sucks. Okay, I gotta wait for it. I think I went too fast. All right. Okay, so let me just show you snippets of what needs to be done. So the key point is CTOs can be crossed multiple ways. And I think this is where you guys saw this. Give me 1 second, I apologize. Let me just go back here. Okay. All right. So this is kind of what I wanted to emphasize. This was an epicardial, that in fact had to be entered. It entered right at the place where I had literally no landing zone at all. So I had to retrograde do a Carlino. But remember, when you're doing Carlino very close to the left main, you got to put in a safety wire. That was the final result of that. You didn't see the initial run, but again, in the interest of time, I'm going to keep going. I think it's important that we understand the use and role of guide extension catheters. That's another important pearl. Really helps simplify a lot of cases. This was a case like from a few years ago in China where, again, no CT, nothing. So ambiguous, so I had to Carlino retrograde, and then again, it was a guide extension reverse card after this. So you guys saw the final results of this already. So CTOs themselves can be crossed a multitude of ways. You can cross it with a knuckle, crossbars, antegrade. You could do Carlino, whatever it takes. The key is understand what these different maneuvers can do, use imaging appropriately, and guide extension catheter when you can do it. One point, and an important pearl, if you're going to try and do retrograde true-to-true wire, especially into the left main, you got to be super careful because you might end up going subintimal and closing off the cert. So that's an important thing. Always use imaging if you're going to try and wire the left main itself. And then again, I also think we need to think about long term. So I'm not going to spend a lot of time here because I think I'm running out of time. So it's important that we optimize whatever we do well, because you know what had happened in this particular CTO. Again, how we crossed it doesn't really matter. Someone had put in a stent without doing good lesion prep, so I had to kind of, and it was closed, and now I had a much bigger problem to deal with. But the key point is I opened it, I optimized it, and then I ended up stenting it. So think about the long term when we do CTOs and how the patient is going to do. So just don't throw in stents after the vessel's open. In summary, complications are inevitable in CTO PCI. It's a high risk procedure. We can use data to guide us, identify who's at high risk in real time. We share complications, learn how to minimize it, and we got to treat the right patient, the right tools, with the right skill sets, with a plan. And thank you, guys. Sorry about the technical glitch in the middle. Really appreciate your time.
Yeah, thank you, Dr. Aaron, for your outstanding talk. And you mentioned 12 lessons to avoid the complications, and also teach us how to many techniques to do the CTOs. Because one of the operator has finished the procedure, we are going to move to the room. Okay, thank you so much. Will you join us the rest of the session?
Sure.
Thank you.
OK， 那个郑婷。OK, Dr. Tsai. Dr. Tsai, can you hear me?郑婷, I heard that you finished your case already. OK, 郑婷, I can see you. I heard that you, OK. OK. Dr. Zheting, can you hear me?
Yes, yes.
Yes. I heard that you finished your case already, right?
Okay. Can you play back the angel since the first stand? This case is a LED CTO, a very short LED CTO. We use the XTA wire, anti-gray, can cross very easy. It's not so long time, just a minute. After wiring, pre-dilatation, and IVUS show the diffuse atherosclerosis from very distal to the LED ostium. Not just only CTO segment. It's very diffuse lesion. So we'll put the first stent to cover the CTO from the LED ostium. Next, please. Next. Next, epicranial. Okay, from the epicranial view, you can see the first stent just reached the D2 and the septal branch. But behind the diagonal 2, you can see the short segment atherosclerosis, and from the IVUS, its plaque burden is very heavy. So we put the second stent to overlapping the previous stent. Please next.
So Zhen, how did you decide the landing zone for the second stent?
Yeah,
from IVUS finding, right?
Yes,
because
yes,
this
from
vessel is
IVUS.
very diffuse disease vessel.
Yes, yes. So I don't want to put the long stent because you can see from the angiogram. Next. He's behind the distal lesion to the very, very distal lesion. From the IVUS measurement, the distal LAD is diameter nearly 3 millimeter. So I think the gap, the diffuse distal LAD diffuse atherosclerosis is negative remodeling. So yes, maybe you need time to remodeling again. Okay, next. This second stent. Next.
So what's the size of the second stent?
2.75 by 26.
26. Okay.
Yes, it's a 0. And
okay.
And after standing, you can see it's distal. Yeah, it's not so good looks.
Yes.
So we do long balloon long dilatation, low pressure long dilatation.
Yeah.
Maybe some master call is vessel massage.
What's the size?
Just one, the stent balloon, 2.75 or 3.0 is okay. Just one ATM or one ATM, and you can see after
0.75.
Yes. Just one ATM, and after vasodilator injection, you can see, and the distal segment is very big. Under the IVUS, nearly 3 millimeter. So we just let it be.
Okay. Yeah.
Maybe need some time.
Yeah. So did you perform the IVUS study after standing?
Yes. Dr. Den, Xin-Yi can show the after standing IVUS image.
Okay. Now we are in the segment beyond the diagonal 2 branch, long distal to the stem edge. So, and we can see here it's relatively disease-free, good for landing zone. And here is the stem edge. So looks fully, the stem can be fully expanded. And inside the stem segment, the calcium is not so heavy, so the stem can, the long shape of the stem can be noted. And now we are near the stem junction, and we can see this heavy plaque burden here, and some calcified paper, but the stem still can be opened fully. And now we are in the proximal stem segment, and in here the stem area is also very good beyond 5. So I think the effect of the stent is very good. Thank you.
Yeah, I agree with you totally. From the IVUS finding, the distal stent edge, there's no dissection, and the stent is well expanded, and the area also is quite good. So very good. Any comment from our panelists?
Dr. Tsai, I'm Cheng-Cheng. Nice work. Congratulations. And we just heard a speech of the avoiding the CTO complication. So would you regularly exchange your CTO wire, such as XT or Gaia wires, to workhorse wire after you pass microcaster or balloon? A second question is would you think about the DCB is suitable for this case in the distal lesion?
Yes, thank you for your question. The question one, in my daily practice, we always use the microcaster to cross the CTO. But this case today, we're just wiring and easily cross because under the angel, we detail frame by frame. Maybe it's a functional total, not really CTO. So I just direct wiring. So no use the microcaster. As you know, in Taiwan, and the microcaster patient have to pay. So I don't change the workhorse wire. But in the daily practice, I also recommend if you use the OTW system, you have to change to the workhorse wire. It's more safe for safety. And the question two, this long lesion is distal diffuse atherosclerosis segment is quite long. If we want to put a stent, there will be the metal jacket. I don't want to
drug-coated balloon.
Yes. So drug-coated balloon may be effective, but I also concern dissection. Yes, dissection. So maybe give the patient more time and close follow-up because it's OM with a fixed lesion. I think maybe can follow up later, months later, and wait and see. Thank you.
Okay, Jenny, regarding this case, in case of the XTA cannot close the lesion, what's your next choice of the wire in this case?
Yes, maybe we'll consider use the double lumen microcaster, and the first wire as a landmark, and the second wire I always use the controllable wire, Gaia first or Gaia second, based on the angiogram to perform the maybe parallel wire first because the lesion is not so long.
Yes.
If the lesion is very long and the distal cap is not so clear, I will do retrograde.
Okay.
Because this case is very short
Yes.
CTO. Yes.
Yes.
So I think the anti-grade can overcome.
Okay, Zeti, thank you very much for your very excellent demonstration. Thank you very much, and congratulations for your success.
Thank you.
Great case.
Demonstration.
Thank you.
Then we will move to the case 8, room 3.
run through.
Robin.
Yo.
Yeah. I'm Dr. Chang
Hey.
Nice to meet you.
Yes, nice to meet you.
Robin.
Yes.
Now move to your classroom. So can you explain and introduce your colleagues?
Okay. Please introduce the case and
please show the PowerPoint. Good afternoon, everyone. This case number 8. This is a 71-year-old male patient with a line history of hypertension and hyperlipidemia. A patient recently have dyspnea exertion, so went to other hospital while he received a coronary angiogram. A patient EKG is sinus rhythm and EKG show inferior myocardial infarction. And patient received silent myocardial perfusion scan and which was positive. Transthoracic echo was comparable with preserved LV systolic function and LV inferior wall hypokinesia. coronary lesion, coronary angiogram show distal left main lesion with Medina classification 1 or and another lesion I left a lady mid portion 80% stenosis, and second fresh distal is near total occlusion. Okay, you can see from this aerial corridor, AP corridor view, you can see left main, distal left main, about 50% stenosis. And second fresh distal is near total occlusion with microchannel to distal. And next slide, please. Okay, this slide you can see LED middle lesion. RCA was relatively normal. So this is a case of two coronary artery disease with two vessel disease.
Okay, let's.
Okay, so this is a lemon plus two vessel coronary disease, including the distal near total occlusion and also. Yeah, I think this is a functional CTO because we can see some flow anti-gravity.
Yes,
and also some stenosis at maybe the second OM branch. So before you perform this case, I want to ask the opinion from the panelists. So
maybe maybe I can show you the diagnostic chart today.
Today's okay.
Yes, today's.
Especially
we do the diagnostic angiogram first. Yes. Yeah. And this is the frontal view. As you can see, in my opinion, the lemon lesion is not very severe, and I would like to. I don't like to touch it. Yes.
It's not so severe. Compared with the previous study. Yeah.
Yes.
You can perform maybe IVUS study or FFR. Yeah. Okay.
I don't think that's necessary for the lemon lesion, and also for the distal lesion. This must be critical.
Yeah.
And it's a functional total. Yes, maybe.
Yeah. And there's some stenosis.
Yes.
Of the OM brain.
So the main lesion is at the circle, and LED also has a significant lesion from the aerial cranial view.
Yeah, another view?
Yes, I will show you.
So this case, left side dominant. I saw
left side dominant, yes.
Yes, I see it not so large.
Yeah.
Okay, LED also very severe stenosis. Okay.
So my target is second flex, and lemon, maybe you can have some discussion about it.
Okay, so I want to ask the opinion from our panelists. Dr. Allen, can you hear me?
Yes, loud and clear.
Yes.
No, great case, and I think it's super interesting. I think thus far the discussion's been good, but just one quick question is that I think yes, the circ is probably the tightest, and I'll probably go after that first. But I most likely, and if I had to guesstimate, the LED is also going to be significant. I'm kind of on the fence about the left main. I personally would probably throw in an IVUS catheter. You could image the circ. You could also image the left main. The LED and the left main, and then make decisions about the left main. So I personally would do this only with imaging.
2.55 balloon.
Dr. Aaron, what is the cutoff value of the lemon lumen area in your practice?
That is a great question. I wish I really could give you like one straight answer. I think like the Western population typically, we tend to use 6 as the cutoff, but I think in most of Asia, especially thanks to the Koreans and Dr. Park's group, a lot of us just do have lower numbers as threshold, like pretty much 4.5, etc. But my suspicion is that this might be tighter. And I'm not, there is no downside at all in imaging. And I'm kind of curious in Taiwan, like, do you guys, I'm assuming you probably follow the Korean studies more, given the demographics. How do you guys do this? Because in India, we don't have a lot of data on Indian patients. So I tend to go with functional assessment And also, I mean, if it's 4.5 to me, below that is absolutely non-negotiable. I will treat it. The gray zone, you might end up doing some kind of a functional study like an FFR or something if you are in the gray zone. What do you guys do typically?
Totally agree with you.
Yes, me too. I will decide by the functional study, for example, FFR, much more than the IVUS finding. Yeah. So, other comment?
Maybe larger, the minimum lumen area larger than 6.5, then I will skip the functional study. Otherwise, I will.
Functional study, but it has a downstream lesion and also has a LAD lesion. So I don't know.
Yes. But because the diameter of this element is quite large, so I think the area will be larger than 6.
Yeah. I crossed the circulation by XTR.
Okay.
And then I will do some predilation at that area. And then I will perform the IVUS from the distal circle to its ostium and lemon bifurcation. And then we will know the area.
Yep.
Robin, the consensus from the panelists, we agree with you totally. We have to treat the circumflex and the LD today, and the first yes. Then we will study the event later.
Okay.
Yeah. What's the wire?
I use the microcaster Corsair and use the XTR to cross the functional photo lesion of circ. And then I advance the Corsair to distal circ and exchange to a workhorse guide wire. And this is the run through.
Yeah, very classic procedure. Robin, don't you want to protect the OM branch?
The first OM, yes. When I proceed to standing, I will protect that one. The second, maybe not.
Perfect. I mean the largest one. Some stenosis over there.
Yes, maybe after the IVUS. Or I can advance another wire into it and then perform IVUS to evaluate its osteolesion as well. Okay, now I can do the IVUS.
I think, Dr. Lo, I'm Mao Xin from NTU.
Yes.
I think the challenge for the further standing will be the size discrepancy between the proximal to distal circumflex. There's no doubt that there's ectasia, ectatic artery in the proximal.
Yes.
So I think we should very careful to using IVUS to evaluate vessel size before we plan to stent.
Yes. To prevent the hanging in the lumen, yes, proximal edge.
So Dr. Lo, this is two bifurcation. One is in the left main, one is in the circumflex and osteomargin. And for the circulation, are you going to treat the bifurcation? I mean, provisional standing.
It's a short lesion, so I would like to use a provisional strategy. After bifurcation, after kissing, if there's a need, I will put in another stent tap.
So you don't insert the second wire to the OM or just leave it?
If the IVUS is started.
Yes. Before the IVUS, yes. IVUS. Okay. 那你另外一个是用 blue。
So, Robin, please continue your work. We will move to the room 5.
Okay,
Dr.
please.
You will demo LED long diffuse lesion.
Yes, please. Okay, see you later.
Okay. Okay, very good. So please move to the room 5. Yeah. Okay. Jian-Min, this is Dr. Chang speaking.
Movement area 3.0，开口的小了一点。
麦克的声音太小一点。
麦克风声音不够。
Hi, hello.
Can you hear me? Yes.
Yes.
This is Dr. Chang speaking, and we have a new panelist, and we'll be back up with you.
Okay,
and can you introduce your colleagues and your case?
Okay.
Can you show me the PowerPoint?
Let me introduce my team. This is Wei-Chen and Dr. Liao, Guanzhi Liao. So please introduce our case, please.
Okay.
I need. Can you show the patient profile for me? The PowerPoint, the patient profile. This is a case for the intervention for the tortuous LAD, and he's a 88-year-old man with underlying disease of hypertension and type 2 diabetes. He had a chief complaint initially is effort-related angina, and the EKG shows signs of bradycardia and the first-degree AV block. The non-invasive test is the multi-slice CT, which show the LAD and the RC a significant stenotic lesion. The echocardiography show the preserved LV and RV systolic function. And we do the PCI successfully to the RCA days before, and we will undergo the stage PCI for his LAD proximal lesion today. And we can see the CAG. Please. Okay. The CAG, we can see the CAG, the spider view show the LAD proximal eccentric around 80% stenosis. And the circumference root is not like the general population. It's just a course around the ramus course. And the lemon with a variant LA branch. And we can see the RCA. The next slide. LAD is a tortuous root, and LAD proximal to middle, we can see the tendon stenosis. And the more distal part is one lesion. And the stenotic plaque is across the diagonal branch. And the diagonal branch ostium, we also see one stenotic lesion. And we can see the RCA. RCA proximal and middle with stenotic lesion, and we done a PCI with stem implantation days before, and the patient tolerated the procedure well. So we change back to the our CAG panel today.
Okay, so today's target will be LAD, right?
LAD.
Yeah, yes. Actually, these are tendon lesions. There are 2 long segmental lesions, and of course, will involve a very large first diagonal branch and some stenosis at the orifice of the diagonal branch. But the vessel diagonal branch is not so large. So regarding this case, I want to ask the opinion from our panelists. Dr. Allen, can you hear me? Dr. Allen? Arun, sorry. Dr. Arun?
Hey guys, can you hear me now?
Oh, right. Yeah, very nice to hear your voice. Regarding this case,
yeah.
No, what's your opinion regarding this LAD lesion?
No, this is a very interesting case, and before we definitely define our strategy, I think it looks like they've already IVUSed it. I think that would be the first step. You absolutely should do this with imaging. The good part is that proximally you have a very, very good landing zone. Distally is really the problem. I mean, you have tandem lesions, you have a branch. How are we going to address this? The branch, I agree, is not very sizable. So I would, first IVUS this before I do anything. I didn't find my distal landing zone, and then, typically my guess is I'm going to do this as a provisional strategy.
Yes. Okay, very good comment. And any other comment from our panelists? Okay, so Jian-Ming, so
yes.
what's your strategy for this case?
I think we'll do IVUS first to check it out. As I think there's multiple lesion, including the middle portion. There's a short segment. Actually, the critical lesion is in the proximal to middle part across the bifurcation. So let's show the IVUS study. The IVUS, please. Yeah.
This is from the distal part. We can see here is more disease-free, and so about 217.5 to 30, and you can see some focal lesion and negative remodeling, and go back to normal. Then the focal lesion again. Okay. Okay, you can see here is a focal lesion, and the very focal, and go back to normal size and the disease-free. And we go to the middle part. There's some focal lesion over here. It's no calcification. Yeah, some disease over here is not so severe.
Yeah.
And then we go back to the more middle and the proximal part is the disease-free area. And here is some dense fiber. And the negative remodeling is septal branch. And here is a plaque got bigger. And it's actually plaque over here. And we go to the proximal region, and you can see here is the plaque burden is get huge, and the vessel get bigger. And go to the proximal near the also VLD. They're coming from the circ from the 12 to 11 o'clock. And here is the main. So we can see the distal actually is some focal lesion. And the most severity disease area is in the proximal LAD.
So from IVUS finding, what's your suggestion?
My suggestion is
short stand and proximal long stand.
Maybe the two strategy. One is a very short stand, just cover the proximal region, and the other one is more longer than cover to next to the septal branch. There's a focal region over here. You can from the IVUS here is a focal region over here. So maybe longer one is going to the stand landing to the septal branch, cross the proximal to the septal branch. Cover the two region.
How about a very distal region? You think it's okay?
I think it's okay. It's a very focal and not so severity.
Okay. So can we use a very long stand to cover the proximal, the middle region? For example, 48 millimeter in length.
I think it's okay.
Okay. But we have to close the diagonal branch, so maybe we should protect the diagonal branch.
Yes, I agree. Yeah.
Okay.
I have to put a guide into the diagonal branch. Major. Okay. Then do a balloon dilatation and to see what's going on. Okay.
Yeah. Comment from the panelist machine.
I think that there's several spot lesion all the way from distal to proximal. So I think I will just put the stand, maybe one stand, to cover the lesion proximal distal to the diagonal branch, and then leave the rest of the spot lesion, and then do FFR combined with IVUS and the functional study to confirm that whether it's adequate for just one stand strategy.
So Mao Xin suggested that we just put a short stand at the proximal LD first. Yeah.
30 or 24, just cover a very proximal to lesion, and then do FFR.
From very distal to see how well
because he's 88 years old. Old lady. So I think maybe if functional, that we can just leave some more lesion behind.
Okay.
I think that's okay.
Okay. Okay. Good.
What is the MLA beyond the diagonal?
Pardon?
What is the minimal luminal area in that second area beyond the diagonal? How much was it? Just beyond the diagonal?
Beyond that, maybe 3.0 to 3.5. I think so from the IVUS finding.
Mm-hmm.
Yes, at least the 3.0. Yeah.
And I think the point of keeping it simple is well taken. You know, overall the patient is 88 years old. So,
yes.
I mean, I think a one-strand strategy, you know, instead of like having multiple overlaying stents is probably, you know, a wise move. Now, the key question is, do we want to just keep it super focal, or do you want to go across and cover that area beyond? I mean, if you can get one stent to cover it all and then walk, I mean, I guess that really is the only point of debate. Now, again, what typically happens, and again, I'm not saying if we can stick to our guns, if you do end up stenting the proximal, we always have the oculostenotic reflex. The mid part is going to look worse, and then you're going to be like, all right, now I'm going to stent that other one too. So I think whatever strategy we decide on, we kind of use imaging right now. Let's have a clear game plan of what the distal landing zone ought to be, and then stick to it.
Yes, I agree. This is an issue. I prefer to put a stent across the diagonal branch to the septal branch. Maybe
I would too.
Yeah.
One stent to cover it, walk after that.
Yeah.
I mean, image, make sure everything looks good, and then that's personally what I would do. But again, I think that the other approach is also very reasonable. My concern is once you stent the proximal, the mid is going to look a lot worse, and we're going to be kind of saying, all right, now let's do more.
Dr. Huang, I'm Dr. Xu, Cheng-Cheng Xu. And how about the ostium of the large diagonal? Would you perform the IVUS first, or because I'm thinking about it, that if the stenosis is critical from the IVUS, maybe we can do some scoring and the DCB before the stenting, before the one stent strategy.
How about gentlemen?
Dr. Arun, do you think it's reasonable to prepare the side branch before the stenting?
That large diagonal does not look particularly diseased, and you know, at least on from what I can see in the imaging through the Zoom platform, and angiographically too, doesn't look too bad. I would, you know, I personally, I mean, I'm just concerned. Like, even if you do put in a scoring balloon or something there, I don't know if it's required. So personally, I would wait and watch.
Yes. Yes, I agree with you. Maybe we don't need to touch this vessel. Just as we say that it's 88 years female patient. Yeah. So, okay. So, Jimin, please go ahead.
Okay.
Work. We will be back very soon. I want to go to the room 3 to see the result by Dr. Robin.
Okay, yes. Thank you for your comments. Thank you.
Thank you.
Hi, Rakesh.
Robin.
Hi.
We are back.
Okay. I'm performing IVUS examination of the LAD.
Yes, I think it's very interesting to see your IVUS finding.
Uh-huh.
Can you
this
show
is
us?
pullback from distal LAD, yes. This is the lesion side and proximal.
So even the distal also vessel also is very large. Yeah.
And now it's approaching LAD ostium.
LAD ostium, this is circle.
No, LAD. I pull back from LAD. I will show you the pullback from circ later.
Okay. So this
Here's
is
the distal circ. Distal lemon lesion is significant. Yes. Okay. Sure, this is the distal lemon.
Here is distal lemon.
Yeah.
Oh,
yes.
okay.
Yeah.
So, so the finding change your mind, change your strategy.
Yes.
Not yet.
Yes. I believe in science.
8.48. Do you think it's enough?
I leave the decision for you. I will show you the pullback from Cirque first.
Okay.
Sure.
So okay.
Yes, so now we are in a second phase distal, and here is relative beyond the bifurcation region, and we bookmark the landing zone of second phase bifurcation region at B2. So now we are approaching. However, in the distal part of the bifurcation region looks like a long diffuse region. And now we are in the this bifurcation region, and we can see the wire come from OM wire, come from 11 o'clock. And here is proximal to the bifurcation. But the DC plague looks still very heavy. And now in the proximal landing zone, and the vessel size is quite large, over than 5. And we stop here and we check the landing zone. If we use the distal B4 landing zone, is around stand length is around 38. If we choose B2 landing zone, the stand length is around 13. So this depends on.
Please show us the ostium of Cirque.
Ostium of Cirque.
Yes. Here's them.
Here.
Yes. Okay, maybe next round. The second round I did was a pullback from the OM branch, the large OM branch, to evaluate the oscillation.
Okay.
Next round.
Circumference.
Here is the area of the ostium of Cirque. It's very big.
Yeah.
Okay.
And this round is a pullback from OM. Actually, its oscillation is very short.
Next round of IVUS.
Yes. It's in the big OM branch.
Yeah.
Here's the ostium. The lesion is very short.
So you decided to not to treat this OM branch, right?
No, I decided to treat it just by kissing.
Okay, good.
Yes.
So the major problem, there are two major problems regarding this case. Of course, the first one is shall we touch the lemon lesion? And the second question is there is discrepancy of the vessel size between the distal circumflex and the middle circumflex. So what's the opinion from the alum regarding these two questions? From the IVUS finding the minimum lumen area of the lemon around 8.48. So what's your opinion?
I mean, 8.48 makes it very hard to stent it, right? I think, you have to kind of go with the initial plan is to leave it be. I just want to, and again, he has done IVUS runs from both the Cirque and the and the LAD. and we are pretty convinced that there's nothing there. The thing that I didn't get a clear sense of is the very proximal, the ostial circ. What was the MLA there?
17 MLA.
Ostial circumference is okay.
It's okay. So yeah, I mean, then you have a hard time then saying like, do anything at all. And I think, unless, so here's the big challenge. If the ostia of both the vessels, right, the left LAD and the circ are not to be touched, then there's no point in stenting the left main. I mean, you have your MLA is 8.4 something. Yeah. So just leave it be. Just focus on the circ and the LAD and then call it a day. And in terms of size discrepancy between the distal and the proximal, I mean, I like his idea of like, doing the kissing and then let's redo an imaging before we actually stent in that. And I think we're talking about the OM circ itself. My guess is based on the vessel size, it's going to end up being maybe even a 3.0-ish. But let's, yeah, I mean, I would image one more time and I think it's going to end up being a 3.0 stent.
Okay. Any comment from our panelists?
Will you do kissing before standing?
Very good questions.
Robin. Yes.
Question is, will you perform the kissing balloon technique before you stand in the circumference?
Oh, no. I'm afraid if there's any dissection resulted from ballooning, rewiring may result in some difficulty.
Okay, so what's your strategy now after the IVUS study?
Just to stand across, and then just to use a guide wire to protect it.
Yes,
then
so you will put a long stand.
Yes, a long stand. Yes. Maybe
at the circumference.
30 or 38.
Yeah, what's the size?
I will try to dilate it first with 2.5 by 30 balloon, and after that I will choose the size of the stand.
Okay. So, Robin, we will move to room 2.
Yes. Okay.
And we will be back very soon. So.
Okay.
Please move to the room 2, Dr. Zheng, to show us LAD CTO. Zheng. Yeah. Can you hear me? Yes.
Yes.
Okay. So.
Okay.
Would you please introduce your colleagues and the case?
Okay. Good afternoon, everybody. And I would like to introduce my team. My right side is Dr.
Liu.
Dr. Liu.
Liu.
Okay.
Yeah.
This is Dr. Lu Yawen. And
from IVUS, right?
Yeah. So now I would like to ask Dr. Liu to present the case, LAD CTO.
Okay.
Case number 10. We're gonna do a LAD CTO. This is a 39-year-old male with past history of hypertension and myasthenia gravis and post-thyroidectomy. And he suffered from AMI about 2 months ago, and he was the PCI was done in another hospital, but it failed. And his sinus, when he presented to our hospital, sinus EKG was sinus written with poor outward progression without Q wave. But the thoracic echocardiogram shows that the general hypokinesis of LV and LVEF was 33. And the CAG there about 2 months ago was a mean LAD CTO. The JCT score was 3. And can you next slide, please? As you can see from the left-hand panel and right-hand panel, and the doctor there attempted PCI for LAD CTO, but it failed. And somehow the doctor there do the balloon angioplasty for proximal LAD and the Remus intermediate. But because the patient cannot tolerate the procedure anymore, so they closed the procedure and the patient came to our hospital for help. And this is our case.
Okay.
So So this is a very young patient and
Yes.
one vessel coronary disease, LAD. So before we discuss the procedure, intervention procedure, I'm curious about did this patient receive a functional study? I mean, the silent scan because just only one vessel CTO and with very good collateral from RCA, but his LV function is not so good.
Yes.
LV ejection fraction just around 33, and echo showed a generalized hypokinesis. So the LV dysfunction cannot be explained by the LAD lesion. So this is a very key point. So is there any explanation for this LV dysfunction?
Actually, no definite diagnosis cardiomyopathy was found. We didn't do any perfusion imaging or cardiac MRI. No, we didn't. We just do the ultrasound, the echo.
Yeah, of course, we hope when we reopen this vessel, the LV function will become better. But I think that's a very interesting point for this case. Okay, so
I think this actually this patient has also the disease as RCA distal, and actually he also has a large intermediate branch, ramus intermediate. So there are also some lesions there, and the ECG shows poor way progression. I think maybe there is some anterior myocardial infarction. This may be related to his relative poor LV function, I think.
Yeah. But from the echo show generalized hypokinesia, not just only anterior akinesia. So that's not compatible. Yes.
Mm-hmm.
So before we perform this procedure, any comment for this case, Dr. Arun?
No, I again, very interesting case. I think your point of why does the LAD territory doesn't explain the whole general hypokinesis, I think is well taken. Now that being said, let's just assume that it's a valid one. Now the only other thing, and I'm sure that you've already talked about, doing just a lima to the LAD has been probably addressed. So I'm not going to get into the indications part. So my one question was, when you said the patient couldn't tolerate it last time, it looked like there was a wire into a diagonal, and they were pretty close to the proximal cap. What was any attempt made retrograde? Number one. Number two, how or why did the patient not tolerate? Did he get hemodynamically unstable, or was it too long? What happened?
Yeah, according to the medical history he provided, that the doctor there attempted about 1 hour PCI for integrated approach. They didn't do 2 hour attempt for integrated approach without performing any retrograde approach. And the reason why he cannot tolerate the procedure, maybe it's just a dyspnea, or we're not quite sure. Yeah.
Yeah, maybe because his LV function is not so good. So this is a problem. So today we should be very careful about this point.
Yeah, that procedure, the previous operator do the integrated approach. They put a wire to the diagonal and do the integrated approach, but they unfortunately they go into the subintimal space, and finally they try to open the ramus, but they just but at that time acute closure of the ramus happened. So that at that time the patient feel dyspnea and maybe a too long procedure, and then they just balloon open the diagonal branch and open the ramus, but they did not put the stent. And so at that time they closed the procedure. They did not try retrograde approach.
Yes.
And Doc, one other question: how long ago was the last attempt? Like
2 months ago.
What's the time gap?
2 months ago.
Perfect.
Yeah.
Okay.
Yeah, the occlusion is not so long, but some is not very sure. So did you find because we cannot see the retrograde collateral clearly from the presentation slides, then do you shoot the angiographic?
So let us show the angiogram today, but we can see here. We do the bilateral injection, and you can see that the RCA is from the left coronary sinus.
Yeah,
and,
much better.
Yeah. It looks like the retrograde go much higher than the previous.
So last time we didn't perform the bilateral injection last time.
Yeah.
No.
No. They did not do the bilateral. Yeah.
Okay, this is a very, very important point that I want to emphasize on. Yes, they probably did not a great attempt last time without bilateral injections. However, the very fact that they did balloon it last time might have I was actually going to just make that comment because the wire was very close to to where the vessel itself was filling. It was kind of one of those subintimal plaque modification. Honestly, right now they made the case a lot easier potentially by their attempt. So hopefully we should be able to do this antegrade. And again, remember, even if you did have a very robust collateral, unless the patient is super well compensated with an EF of 33% or whatever, going retrograde might cost the patient of hemodynamic compromise. So we got to be super careful. And if you're going to do it retro, you got to do it bloody fast.
Yeah. So at first we wired to both sides of the guiding. The guiding we use today is Asahi guiding. That's not commonly used in Taiwan.
So will you do IVUS to guide the entry side?
Yeah, yes. We use both sides the guiding catheter, and we use the guide wire and to stabilize the guiding, and then we wire to the diagonal branch and do the IVUS first to check the IVUS at the entry point of the mid-LED CTO. And so can we show the IVUS?
The entry point, the distance between the entry point and the diagonal ostia, there is some distance. So I'm afraid that the IVUS can find the entry point is correct or not. But we can see the IVUS finding.
Yeah. Previous operator they do the balloon dilatation of the diagonal branch, and the wire go into the intima space of into the CTO. So
okay,
we check the IVUS.
Try to avoid to enter the.
Yeah. I think the IVUS check for the entry point is very important.
Yes.
Because maybe we will very easily go into the intima space. But at first we are afraid. I'm afraid that the IVUS cannot pass, but actually it crossed very easily. So we can ask the Dr. Deng to interpret the IVUS.
Okay, so now we are in the diagonal branch, and we are approaching the CTO head. And as you can see, here, from 7 o'clock, we can see the LED, the shape of a LED vessel is coming from 7 o'clock. And then, coming, and here is a very attenuated plaque here. And we can see here is our attack angle, attack point. And then we can see the septal branch here from 8 o'clock, and then we can see the calcified plaque. So, so the best puncture point is between here. Here is the border of LED, and here is the septal branch. So the best attack point is between these 2 points. So here's our finding from IVUS.
See from the picture of the IVUS, because the color is very black, very dark. So I'm not sure. You mentioned that that's a LED.
Yeah, it is a little difficult to recognize.
Yeah.
However, from this frame, we can see here is the border of LED, and then I will show you the dynamic frame.
Yeah.
Dr. Deng.
And then it's coming.
Rotate the line, the perpendicular line indicator, to the 7 o'clock. Then we can see the long view. To the 7 o'clock that you mentioned the origin of the LED. It's okay, but can you replay again from the stories?
Sorry. Okay, so I can replay.
Yes. Yes, I agree with you. Yeah, there is the LED coming.
So the next question is, what are you going to do a live IVUS guided puncture? Do you have an 8 French or a 7 French one? Are you going to use a dual lumen catheter? What's the plan?
Yeah. So Zheng-Ming,
what's your plan?
Where you?
Pardon.
What's the size of the guiding catheter?
Oh, both sides is 7 French.
7 French.
And,
so
yes, I would like to use.
You will not leave the IVUS to guide the rear.
Yeah. I retrieve the IVUS.
Oh, you retrieve the IVUS. Okay.
Yes.
So the IVUS just to localize the entry point, and Dr. Lu will not perform the real-time IVUS guidance to perform the penetration of the guide wire.
Okay. During the comment of the Dr. Deng, we have just why why try to go into the LAD, and we can.
Can you show us the angiography? Okay. 导播换一下 Okay.
Okay, we use this is the XTA-Y. I use a Sasuke double lumen microcaster, and I use actually. Actually, I went to the distal LAD and try to put back, and then he dropped into the, I think, maybe a space, maybe a LAD or subintimal space, and very easily he can go down to the, I think, maybe LAD. But after we check the images, we had take a picture, and you can see that actually he is in the subintimal. I think this is the subintimal space of the previous intervention. Okay, this is now our progress is here. And what's your suggestion from the commentator? What's the next step?
Maybe you can try parallel technique because it's very close.
Yes,
very close to the true lumen.
Yes. So next step, I would like to use a double lumen microcaster to go into the XTA and use another wire, try to puncture back to the Truman.
So tell me what's your next wire?
Maybe I can try Gaia. Gaia second.
Dr. Would you use ADR at this point?
No, actually, I would do exactly what you guys are doing. You're so close to it. And in fact, I'm not, the problem is with the XTA, with any of the XT family stuff is that it's not stiff enough now for you to be able to drive it further down. So I would exactly do what you guys are talking about. Pull out the Sasuke, load it over the XTA and take a Gaia second or whatever and then try to get in. You got a great target there. If that fails, then I would consider ADR, but I would definitely try to wire this. It's too close for me not to wire.
Yes. Okay.
Thank you. We will be back very soon. We have to move to the room 5 to see. Jamie is finished the case.
他再看一下，需要吗
Okay, Jamie, we are back.
Hi. Okay.
So can you explain what's the current status you perform now?
Okay.
Yeah.
Okay.
Last time we discussed maybe we can use a long stent to cover the proximal LD only. So
yes.
What's your question?
Okay. Let's looking back to our procedure. We first of all do balloon dilatation. We using a 3.0 by 15 balloon. We protect the side branch of the diagonal bridge, and we measure the length of the lesion. About 38 millimeter in distance to the turn in the middle portion. So we inflate here and the proximal portion, we can see very severe dissection. So at this moment, so we determined to put a stent from osteo to the middle part.
What's the size?
It's 3.0 by 38. Resolute. Okay, after a stent implantation, we see the stent is looking good at the distal portion without edge dissection. And also the side branch were well protected by the guide wire and no evidence of gel. So we are looking back to the IVUS finding.
Okay, good.
With Dr. Liao.
Here's the middle part where this is some disease over here, and here is the distal stent edge. There's no dissection over the distal stent edge, and go back to the stent middle part. And here's well expansion, and in here there's a little bit under expansion in this part.
Yeah.
Okay. Now we can see the wire. Diagonal wire is 3 o'clock. The one. And we go back to the all-stem part. Here is the all-stem part, just the landing in the all-stem.
Yeah. It's just the precise standing at the location of the osteo. Yeah. Thank you.
So you have to perform some post-standing adaptation at the not so good, well expanded site, right?
Yes.
Middle
yes,
LD.
yes.
Yeah.
Right, right.
So what size of the balloon?
We use 3.25 non-compliant high pressure balloon.
A larger balloon.
Yeah, yes, yes, yes.
5 larger than the 3.0 of the stent size.
Yes.
Okay, good. So can you show us the final result?
Okay. Final result. So we didn't do the last shot. So
okay, okay.
We look at the imaging.
It's okay.
Okay, how do you think?
Oh, okay, very good. Okay, it's very good. Okay.
Thank you. Thank you.
Yeah, Jimin, thank you very much because the diagram also preserved.
Yes.
And the distal vessel seems like better than the baseline angiography. So thank you very much for your demonstration. Thank you.
Thank you. Thank you so much.
Great case.
And I will move to the room 3 to see the result of the Dr. Robin.
Hi, Dr. Xie. Hi.
Yes, Robin, we are back.
Okay.
Oh, Robin, you also protect first OM branch.
Yes, because the branching angle, I think it's difficult to approach it.
Because
it's gelled. Yes.
Okay, I see. So.
I put a 3 by 34 stent to cover the whole lesion to the.
Robin, you say 3.0.
Yes, 3 by 34.
Oh, okay.
And then I dilate its distal part by 3.0 non-compliant balloon and the proximal part by 4.0 non-compliant balloon. I have switched the guide wire of the distal circle and the second OM already. And the next step, I will perform the kissing ballooning at the distal bifurcation. Yes?
Robin, long-term mentioned that the first wire in the OM branch seems like a little bit kinking. Yeah. So maybe you should be careful.
No, just the angulation. Maybe there's the angulation.
Maybe it's okay, but we should be careful.
Yes. Sure,
yeah,
of
means
course.
of the wrong turn. Yeah.
Yeah. It's a seum. The first one is a seum. Now I will do
also, we discussed this case very completely, so we have to say something.
Yes, sure. Okay, please give me a 2-5. Yes, we'll open the straws and then do the kissing ballooning.
$2.550.
Yes, I pull back a little bit of the first wire. Okay.
Your pressure gauge.
Okay. Okay. 2.5呀。
Dr. Luo, you are going to dilate the first OM? First OM?
No. The second one. The large one.
But the flow looks very good.
And its oscillation is very short, so I think maybe I can fix it with just a kissing balloon. No need a second stem.
Sometimes if dissection,
yes. The question is, do we want to do anything at all?
等一下，你那只3.0的 ANC 先给我。因为我怕它那个翘起来之后，等一下把容要再进就不容易，所以先让它到位。OK， 帮我抓这只给我。OK。Sorry， 抓紧一点，然后这边阻力很大。
Yeah, Dr. Arun. Yeah, regarding the distal bifurcation region, will you perform the kissing balloon technique or just leave it alone for this?
Yeah, I mean, it's that's kind of what I was getting at earlier. It's like, I mean, if it's you got TIMI3 flow, why muck around? And I do share your concern. You end up doing anything, and then you have a dissection. Now you're going to make it a lot more complex than you intended to. So personally, if you have TIMI3 flow, we do know from FFR studies that most of these are not significant. If you really want to be a purist, you could put an FFR wire, confirm that it's not significant, but I personally wouldn't balloon it unless I had to. What about you? What would you do?
Yeah, I agree with you totally.
We can have a wolf. There are 5 of us.
Okay.
6 of us.
Okay, leave it alone. Please raise your hand.
I'm the operator.
I love it.
Consensus.
In the meantime, can I ask a question to Dr. Aaron?
Yeah.
We just have some complication symposium recently, and we have discussed a lot of the coronary artery perforation. So do you think is there any difference between the CTO and the non-CTO PCI about regarding to the coronary artery perforation? Any different treatment strategy?
No, in terms of treatment strategy, I mean, that's kind of what I was alluding to earlier. Like, I mean, I think perfs need to be defined in terms of where you have the CTO. Is it in the body of the stented, like, is it the body of the CTO? Is it a distal wire perf, or is it a collateral perf? And each of those have to be handled very differently. I mean, so yeah, I mean, typically if it's the body of the CTO segment itself, if it's just a wire perf, then, crossing and then stenting across many times helps seal it. If it's the body, because we are over dilated the whole thing and sheared the vessel, then you might have to end up putting in a covered stent. Collateral perfs, I mean, it's a whole different topic depending on whether it's epicardial or not. I mean, and distal wire perfs, I think many times you can get away with just fat or fibrin, some clot embolization, rarely needing a coil. So I think depending on what is the perf, I think your management strategy will differ accordingly.
Thank you.
Robin, what's the size of the balloon when you perform?
2.5. 2.5.
Okay. Okay. Robin.
Yes.
We will be back later. Okay. So we will move to the Zhemin's classroom.
Okay, we try to puncture.
Yes, I know.
First entry point or LAD, but actually I tried the Gaia second. The Gaia second, actually the curve is very, very large.
Yes. So we don't want to bother you, so you just keep on your work, and because this is a very interesting case, so we are very focused on this case.
That's our room.
Okay, no, I got upgrade my Guidewire to Conquest Pro 12.
Nice. All right.
For the contemporary ADR, do you still use the stick and swap, or you just choose the new stiff wire to puncture the lesion and change it to the workhorse wire?
So in a case like this where my landing zone is this juicy, and there's not much disease distal, I would just stick and drive it, and then exchange it obviously once I've crossed into the true lumen for my workhorse wire. Beautiful, nice.
I think we are. I'm so lucky.
Yeah, very good.
Congratulations.
Yes.
Good job.
Yeah.
So the second point for discussion is that should we do the two-stent strategy for the dyno and both dyno and the LAD?
Yeah.
Actually, the dyno is not so small.
Yeah. Dr. Arun, what's your opinion? Should we perform the bifurcation standing?
I mean, this is a young guy. I mean, this is a 39-year-old guy, right?
Yes.
And I mean, I agree. I mean, I wouldn't lose anything. Yeah, I mean, I probably would do a two-stent strategy. I mean, especially considering that it's diseased. It's pretty long. So there's a possibility that if you just stent across it, you might end up losing the diagonal. So I probably would do a two-stent strategy. Hey guys, watch the wire.
I think Dr. Lu will show the IVUS after the balloon predilatation because the association of the LAD diagonal, the wire is the past the false lumen or the still in plaque, the plaque tracking. We will see in the IVUS.
What is the second wire?
I think that was a Conquest Pro. Now that
Conquest
is
Pro 12, yeah.
a really good point. I mean, have you gone true, false, true? Because if that is the case, it's almost a given that you got to do two-stent strategy. But even if it were intra-plaque tracking, I would still have a pretty low threshold for it, just given the fact that the diagonal ostium is, I mean, it's not just the ostium. It's a fairly longish lesion and it's big enough. While I think imaging is always a good idea, I personally would do two-stent strategy, but we'll see what Dr. Liu wants to do.
So tell me, what's your strategy? You also will perform that two-stent in for this bifurcation region?
Yes.
Depends on the IVUS finding.
I think according to the IVUS finding, the diagonal looks not so small. Maybe more than 2 or 2.25 or 2.5, right? 2.25.
2.5, yeah.
2.5.
再往远一点。对。
And actually, the lesion is very diffuse. I think maybe I will try the two-stent strategy for this case.
But the length should be very long for this diagonal branch. Okay, so we will be back later. So we will move to the Robin's lab demo.
Yes.
Okay. Congratulations.
Okay,
Robin, we are back.
Yes. Okay, I'm performing the IVUS pullback from OM now. Just please show us the IVUS. Okay, this is from the big OM.停，再给他跑一下，让他跑一下，看那个 bifurcation 的地方。往回推吧呢。
It seems not so bad.
上一个让，上一个。This is a pullback from from PL branch. Our landing area is just before the bifurcation.
Nice. Okay.
After high pressure dilation with 3.0 non-compliant balloon, the stent still seems not big enough.
So will you try the bigger balloon to do a dilatation?
Yes, I think so. Okay, let me show you the last angio we have done. This is the angiogram after kissing balloon. This shows us the angio.
Can you show us the angiography to the major screen? 导播切换一下。对，好 ，OK。
So, what's your opinion? Do you think it's okay? And then I will move to LED. Or use a bigger
very
balloon.
beautiful. Yeah.
Excellent.
Yeah.
Okay, thank you.
Can you pull back the OM1 wire?
Oh, sure.
Dr. Xu
OM1
comfortable to
okay.
answer Dr. Xu's question.
Okay, first I want to make sure which one is that one. This one.
Very easy. Yeah. No problem. Yeah.
No problem.
Yes.
That's all.
Always no problem for Robin's demo.
Okay, let me show you.
Robin, very good result.
Okay, thank you.
Yeah,
ACT.
I forget that you still have some work at the LED.
Okay. Thank you.
ACT.
Thank you for your reminding.
ACT.
So Robin, we will be back later. So please move to the Dr. Ru's classroom, okay? 转到哲敏的那一间看看好吗？
这个很弱，这个很弱，做垂屏不太好，很涩，算了弄。
换一次，
哎是。
Yeah, we are back. So
okay.
Can you
check?
So I
一样的。
After my conquest cross the region, I use Sasuke to change
the Y.
To run, change the Y. Sion blue.
Yeah.
And of course, if the Sasuke cannot cross, I would be dilatation.
Okay, I see.
Actually, the Sasuke can cross, and I have shift to Sion blue.
Yeah.
So now we have 3Y conquest Sion blue both in diagonal branch and in LED distal.
Yeah.
So now I would like to use a small balloon to open the LED and check with IVUS.
Okay. Yes.
But because we use the track balloon 2.5 to anchoring the wire and to pull back the Sasuke, but actually first track was damaged, so I changed to use the second track. This is a track 2.5.
The guiding is 7 French, right?
Yes, 7 French.
So Dr. Lu, do you feel any resistance when you pass the Sasuke double lumen caster?
A little bit, yeah. But now you can see that the balloon is very smoothly can cross the LED.
Yes.
So here.
But Zheng, when you perform a balloon dilatation, were you concerned that the plaque maybe were pushed to the orifice of the diagonal? Yeah.
Sure. But because I have to put the wire has cross go to the diagonal, I think.
Yeah. So you have some rescue procedure.
And this is only 2.5.
So do you think the Conquest Pro 12 penetrate through the plaque of the CTO? or?
Actually, from the IVUS pullback from the diagonal, we can see there is a small septal branch at first. If we advance our IVUS from proximal to distal, we can first see the septal branch and then the LAD. And so we can, from the IVUS, you can see that actually the orifice of LAD, there's no so much calcified. But actually the wire can easily go into the subinter space. I think is located at the distal of the trumen. So I pull back a little bit, and the puncture, the point is a little bit proximal to the first XTA.
Okay, I see. Okay. So, Cheng-Ming, please continue your work. I hope we can still have some time to go back to you. Yeah.
Okay.
Okay, we have to move to the room 5, Dr. Ren's case.
大手点，
大龍，
倒手哦，來對，
大龍，
係勢，
大龍，
哦，一件用好啊，一件用好啊，小等下就好啊，注下少少好。
Dr. Ren, can you hear me?
風行順利哈。
但是你有聽到嗎？他這裡講，但是沒聽到。
This is Dr. Yi Zhang speaking. Can you hear me? Yes.
Okay. Can you louder?
Yeah. Can you introduce your case?
Okay.
We will discuss some strategy.
Dr. Wang. Yeah. Okay. Dr. Wang, please, can you present a case?
Let me show the PowerPoint. Our case is number 11. Next. Our patient is 46 years old male. He has a past history of the hyperlipidemia. This time, he is just complaining with intermittent F4 chest tightness for months. At EKG, the OPD is sinus rhythm and left axis deviation. At echo, reveal the LV and RV function to preserve systolic function. And the surveillance scan reveal the ischemia in the RCA territory. 我们看一下那个 PowerPoint. Here we can see that the left circumflex is there is no prominent stenosis, but the LAD middle has 50% stenosis. And we can see that the collateral from circumflex and septal to RCA. We can see the RCA distal is the total occlusion. This coronary angiography we take in the last 2 months.
Okay. So for this case, it's only the RCA distal CTO. And the patient complained typical the angina and the echo show the normal LV function. So I think this typical the angina case. So today we are revascularization for the RCA distal part.
Yeah. So this diagnosis angiography was performed 2 months ago.
2 months ago. Yeah.
So at the moment, did you try to reopen the vessel? No attempt 2 months ago.
Because we have several demonstrations within the recent 2 months. So we collect so many cases for the live demonstration. Yeah.
Okay. But how about the history of the chest pain of this patient? I mean, maybe 2 months ago, that's not a real CTO lesion.
Yeah. Maybe we cannot make sure. So, but the case we have to keep for 2 months. So, maybe wait a moment. I can test the.
Yeah, because the patient has some collateral from left side, so it's quite safe for the patient to wait for another 2 months.
Yeah.
So the strategy of antigrade or retrograde would be after the bilateral injection, and then you will make the decision, or you go primary for the antigrade.
Yes, because this fresh case, so this first attempt, so I will try the antigrade puncture, and then if fail, then I will use Paraguay. And if we cannot go to the true lumen, then we will use a retrograde approach. And we can see the angiogram there, the some collector from the septal branch and some collector from the second phase from the epicardial channel. So by my strategy, I will puncture for the anti-grade first, then retrograde. Yeah.
So Dr. Arun.
Yep.
Yeah. What's your comment for this case? What's your strategy?
So yeah, I mean, I completely concur. I mean, I think, you know, take bilateral pictures, see how it is, and typically, I mean, it does look like I mean, the distal part, I'm not exactly sure about the length of the lesion, but I think starting antegrade is probably the you know, my initial strategy. If it's a pretty short lesion, hopefully you get done. Whatever it is, keep moving, bilateral pictures, and then take a call. I'm kind of curious to see how it does look on bilateral angiography.
Yeah.
Comment from our
它体重几公斤？先你几公斤？103。好。那103公斤。
Okay, because the time is limited, I have to close this section and make a closing remark first. Then I will invite Professor Yin to make another closing remark later too. So at first, I would like to say thanks and congratulations to Zhenxun General Hospital because they this very beautiful successful meeting. Today's meeting, including yesterday, the topic will be regarding the Hwang, and today is regarding the CHIP PCI complex case lab demonstration. And you can see the case is very interesting and very educative, including the CTO case and also the lemon bifurcation and also calcified region needed to receive the rotor ablation treatment. So I think the course, the program is quite educative and informative, and we can learn the very new knowledge and share our experience with each other through this platform. So I think this is a very successful and very useful meeting. And I usually encourage our member of the Taiwan Society of Cardiovascular Innovation to join and to attend this meeting, especially during the COVID-19 pandemic. They can join this meeting through the virtual webinar meeting. So congratulations again, and I hope to see you very soon and also next year. Thank you. And I would like to invite Professor Yin to give some word.
Hi, everybody. It is my great pleasure and honor to be here to close today's meeting. Actually, for many years, Zhenxun Hospital hold this kind of meeting, hoping to share the latest update of PCI intervention. In recent years, we also involved the field of structural heart intervention and many surgical techniques improvement. And I think this can bring us a very new idea regarding the new technology and the advancement of cardiovascular medicine. I think in this year, many friends of ours attend the meeting and share their excellent ideas and their technologies or techniques, and which can largely improve our future patient care, especially during the COVID-19 tough period of time. And today we have 4 outstanding lectures. In this session, we have Dr. Arun, who is our good friend and old friend. He has been here many times. I think he's lecture regarding how to deal with PCI and for CTO complications will let us improve our patient management in the future. And I really appreciate everybody to attend this meeting. Without your participation, this meeting will be of no meaning. I think we will do this kind of meeting every year, and I hope you enjoy it. Thank you very much.
Guys, thank you so much for inviting me. Great show, wonderful cases, great learning. Thank you. Thank you again. Hope to see you all in person. Stay safe.
Thank you. You too. Thank you. Bye-bye.
Bye-bye, guys. Thank you. Bye-bye.
Thank you.
大家到场，让我听到你们的声音。哇哦，好棒啊！大家今天的心情热情吗？在哪里？